Good morning, everyone. It is my immense pleasure to invite all of you in this diagnostic week, which will be held from today to 7th of April. In this, you will get the opportunity to meet virtually with a lot of experts from all across the country. They will share their knowledge, they will share their experience, and they all are from the very various prominent institutes of our country. You will be able to get knowledge, and whatever query you want to solve, you will get opportunity for that also. PGs will get the opportunity to present their research work in the form of oral presentation, in the form of poster presentation, and we have organized a quiz also. In this, first 3 days are dedicated to hematology. First 2 days hematology, then there is one session on quality, one day, then histopathology, cytopathology, then again one session on hematology. So like that, various sessions are distributed all across the week. So now, without taking much time, now we are starting our scientific session. And
Good morning, everyone. I welcome you all to this day two of our diagnostic week. Today, we are dealing with the diagnostic aspects of various malignant hematological disorders, which include acute leukemias and lymphomas. So, we start the day with the diagnostic aspects of acute lymphoblastic leukemia. So, for the sake of understanding, the slides, I have is my slide. Are my slides moving?
No, ma'am, it's still on a first page.
Okay. Yeah. I started moving. Oh, okay. So for the sake of understanding, I have divided the entire this for next 40 minutes into two half. In the first half, we will be dealing with the basic concept of acute lymphoid leukemia, where we will be talking about ALL classification with special emphasis on WHO 2022 update. After that, the diagnostic considerations of acute lymphoblastic leukemia, which is include morphological evaluation, flow cytometric immunophenotyping. I have highlighted it in red because that is the main aspect which we are going to discuss in detail. And the third is cytogenetics and molecular studies. I will just have an overview of these because we have an entire lecture dedicated to this molecular aspects of hematological malignancies. And in the second half, we'll be doing the few case-based exercises. So acute leukemia, as all of us know, it is a malignant proliferation of white blood cells. And recently, WHO it has re-envisioned that to emphasize the major breakthrough in the various molecular and cytogenetics abnormalities in past few years. So now the overall classification of acute leukemias, it emphasizes on the multimodality aspects, which includes integration of clinical, immunophenotypic, molecular emphasis for both clinical pathological judgment as well as for the guiding the treatment. So broadly, if we can look into the acute leukemia classifications, we can broadly categorize them into three categories. Acute lymphoblastic leukemia, which is either B or T lymphoids, then acute myeloid leukemia, and the third is acute leukemia of ambiguous lineage or acute undifferentiated leukemia, which is neither fitting into the ALL or AML type of subcategory of acute leukemia. So now we have just WHO has introduced a recent version WHO 2022 updated classification of precursor lymphoid neoplasms. So if we look into this, what it emphasizes that it has identified a lot of new genetic drivers, and in most cases of B-ALL or B acute lymphoblastic leukemia, the pathogenesis remains around this, including few common novel genetic drivers like intrachromosomal amplification of 21 chromosome, BCR ABL1 fusion protein, and KMT2A arrangement are quite some of the known pathogenetic mutations which are there. So, however, Compared to the previous WHO classifications, the current nomenclature focuses on the molecular events rather than the cytogenetic alterations. How? So, as you can see here, we can see that earlier in the WHO HEM4, that is in the WHO version 4, there was a B lymphoblastic leukemia with translocation 922. So, entity remains more or less same. However, we have just classified, we have renamed it, the nomenclature has been revised as B lymphoblastic leukemia with BCR-ABL1 fusion. So essentially the entity remains same, only the slight change in nomenclature is there. So the classification based on these groups, they remain largely unchanged from the previous WHO classification. However, there is certain minor updates where few incorporation of new genetic findings are there, which leads to the further refinement of these new entities. Like two new provisional entities are BALL with ETVX RenX1-like feature, which was not included in the previous version, and the BALL with TCF3 HLF fusion, which was also not included. So these two are included as a provisional entity in the WHO HEM5. Similarly, for the TALL, despite our lot of understanding of the TALL, there is not enough evidence to establish the genetically defined subtypes of TALL with clinical relevance. And that's why the TALL, and there is not a lot of confusion in the name of this lot of genetic abnormalities. So we have primarily, the TALL is divided into T lymphoblastic leukemia or lymphoma. Now, it has nomenclature has again updated as T lymphoblastic leukemia lymphoma NOS, that is not otherwise specified. Then another entity is ETPLL, and the third, which was included for the first time in the fourth edition of WHO, that is NK lymphoblastic leukemia lymphoma. This entity has been deleted from the fifth edition. So now, why this entity has been deleted? The reason is that there is lack of clear-cut reliable diagnostic criteria for this NK cell leukemia or lymphoma. The lack of published information on expression of NK cell associated antigens, like certain NK cell associated antigens like CD94, CD161, we do not have enough evidence in the literature to show their relation with this. Then, and third reason is the morphological as well as immunophenotypic overlap with other entities like BPDCN, which also express CD4 and CD56, then CD56 positive acute myeloid leukemia, and the presence of CD56. So just based on CD56 expression, we cannot label TALL. It is very difficult to actually segregate TALL into TALL or NK cell lymphoblastic leukemia or lymphoma. That's why this entity has been obsolete or deleted from latest edition of WHO 2022. Now moving on to the diagnostic algorithm of acute leukemia. So in the diagnostic algorithm of acute leukemia, so the first step is the morphological identification of blast. So we look into the blast, whether in our peripheral blood or bone marrow or any body fluids, and we just label them as they are blasts. The second step is immunophenotypic characterization and classification of these blasts into lymphoid, myeloid, and undifferentiated kind of category. And finally, there is the cytogenetic and molecular events are defined, which will further target our therapy, and they have the prognostic relevance as well. So moving on to the step one, which is the morphology part. So in morphology, if we talk about ALL, so the FAB classification, it morphologically classifies lymphoid blasts in three categories. So the L1 category of lymphoid blast, they are the small blast of the uniform size. As you can see in the first figure, you can see all of the blasts, they are of the same size, small in size, uniform size. Cytoplasm is not enough. This scant cytoplasm, nucleus is more or less regular, and small nucleoli is there, which may be not so prominent. Then a second morphological subtype or variant of lymphoid blast is L2 type of lymphoid blast, which is large, irregular in size, with abundant cytoplasm, irregular nuclear contours, and prominent nucleoli. And this L2 kinds of lymphoid blast, actually, it is a lot of time it is very difficult to differentiate them from myeloid blast morphologically. The third variant of lymphoid blast is L3 type of blast, which is again very large size. They are also essentially more or less of uniform size. So there is not much heterogeneity here. with abundant cytoplasmic vacuolations. So L3 type of lymphoid blast, they characteristically have a cytoplasmic vacuolation along with one or more prominent nuclei. So this L3 type of lymphoid blast, it is characteristically seen in Burkitt's kind of leukemia or lymphoma. So I'm just sharing some of the this photomicrographs from our center. So in the first figure, we can see that the blast morphology is slightly uniform. In both the figures, the blast morphology is essentially more or less uniform with small size, scant cytoplasm, inconspicuous or not prominent nuclei. So they just belong to the first category of L1 kind of morphology of blast. In this figure, we have another, we can see lots of blast here. So they are having abundant cytoplasm is there. Nuclear chromatin is slightly heterogeneous, nuclei is inconspicuous. So just looking at the morphology. So at this step, is the morphology enough to label them as lymphoid or myeloid blast? No, we can only one condition where we can confidently label them as myeloid blast when we are saying all rods. So if the all rods are not present, so in that case, what is the next step? So then we go for the after assigning our blast, after seeing our blast, the next step is step 2, which is the assignment of lineage identification as lineage assignment of blast. So having seen the blast in our peripheral blood or bone marrow, how do we identify the lineage? So for lineage identification, we go for our immunophenotypic characterization, which is by more commonly by flow cytometric immunophenotyping or on bone marrow biopsy, also rarely by immunohistochemistry. So for lineage identification and immunophenotypic characterization of any kind of leukemia, flow cytometry is the gold standard for diagnosis. So now this is the WHO classification for lineage identification of various subtypes of lineage of cells. So for myeloid lineage, we can have strong cytoplasmic MPO positivity either by flow cytometry, immunohistochemistry, or cytochemistry, or evidence of monocytic depreciation by the presence of at least two of the following, which is MSC, CD11C, 1464, or lysozyme. For B lineage, as such, there is no lineage specific marker. So for B lineage, there is the gray zone is always there. So for B lineage, what WHO has laid down is strong CD19 expression with one or more strongly expressed B lineage markers, which is cytoplasmic CD79, cytoplasmic CD22, or CD10. Or when CD19 is weakly expressed, then two or more strongly expressed B cell markers, which again include CD79, CD22, or CD10. For T lineage, again the lineage specific marker is either cytoplasmic or surface cytoplasmic CD3, with or without the presence of one or more T lineage associated markers, which are CD2, 5, 7, and 8, but they are not given the lineage specificity for T lineage. Why? We will just see subsequently. So just I was talking about the lineage specific and lineage associated antigens. So lineage specific, what is the difference between lineage specific and lineage associated antigens? So it's very important to understand this concept. Why? Because just we have said that WHO has laid down very stringent criteria for lineage specific antigens, where T lineage is identified by either surface or cytoplasmic CD3 positivity, and myeloid lineage is identified by cytoplasmic MPO with CD64, CD11C, and markers. For B lineage, we have no lineage specific marker. It's not there. So it's very important to understand that lot of B markers, CD19, and that's why we just rely on these criteria which is laid down by WHO. So lineage specific marker is for that particular lineage, and lineage associated marker is commonly frequently seen in the cells of that particular lineage, but it can be present in the cells of other lineages as well, like CD19. CD19 is commonly expressed in the acute myeloid leukemia, especially with translocation A21. Then AML may present other T lineage associated markers like CD2, 5, and 7. And that's why CD2, 5, and 7, they have not labeled as T lineage specific markers, but they are lineage associated markers. Same is for BALL. BALL may express lot of myeloid markers like 13, 33, CD15. And that's why these markers 13, 33, 15, they are myeloid lineage associated markers and not lineage specific marker. So just based on this WHO stringent criteria, at times in practically the life becomes very difficult where we are not getting a clear-cut expression of one or more marker of a particular lineage. So for that, AZL, European Group of Immunological Characterization of Leukemia, they have also laid down certain criteria for lineage identification. So for the lineage specific marker, they have designed two points for myeloid lineage for MPU and lysozyme 2 points and 1 point each for 117, 13, 33, and CD65A. Similarly, for B lymphoid lineage, CD79A, cytoplasmic CD22, and IgM has been assigned 2 points, and rest of the markers 19, 20, and 10, they've assigned 1 point. So based on this, if we can say if the score is more than 2, then we can assign that particular blast as the of that particular lineage. Having said that, because in a lot of times in AML it happens that in M0, M1, M4, M5, M6, M7, in all these lot of tab classification, they are not expressing MPO so brightly or even absent. In that case, if I am getting my CD13, 33, CD117 positive, so as per ASIC criteria, it is 3 points. 3 point is there. And I will look for the other cytogenetic and molecular abnormalities before going ahead, and then I can confidently label it as acute myeloid leukemia, even in the absence of lineage-specific MPU. So that's why here lies the significance of this ASIC classification, and at times we refer to this also for assigning a lineage for ALL or AMLs. Now, after the lineage identification, the third step is immunophenotypic characterization. So in immunophenotypic characterization, basically we are dealing with ALL. So we will look into the normal B cell maturation. So normal B cell maturation pattern is very important to understand, as we can see that CD45, certain markers which are dimly expressed in immature precursor cells, CD45, it is very dimly expressed. Then stem cell markers TDT34, they are brightly expressed in mature precursors. CD10, again, it is very brightly expressed in mature precursors. 38 is dim expressed. 19 is essentially more or less, it is homogeneous in expression throughout the B cell lineage. 20 is absent. So this maturation pattern, it is very important to identify for the immunophenotypic characterization of BALL. And based on this maturation pattern, actually, we have divided the precursor BALL into 4 subtypes, which are pro-BALL. Pro-BALL is characterized by the absence of CD10 expression, both CD10 and CD20 expression. Then we have common ALL, which is Kala-positive BALL, which is characterized by the presence of CD10 positivity. Then we have pre-BALL, which is characterized in which it is similar to common BALL, but at this stage there is the cytoplasmic immunoglobulin. They also start appearing. And the last is the transitional pre-BALL, which is more or less essentially of the type of mature immunophenotype, but it do express certain immaturity markers like CD34 and TDT. So this is the immunophenotypic classification of BALL. So now moving on to the immunophenotypic characterization. So these are the flow cytometric dot plots. Here we can see that in my first dot plot, this is the side scatter versus CD45 dot plot is there, where I can see my green color population are mature lymphocytes in AU gate, then my granulocytes are in AV window, and then my CD45 moderate to dimly expressed red color population are there, which is in my blast window. So these are my blast. Now in the second plot, CD39 versus CD34 bivariate plot, we can see that all my blasts, they are brightly expressed for cytoplasmic CD79. So this says that somewhere we are dealing with B lineage blast. And then these blasts, they are also expressing CD34 heterogeneously. Why I am saying heterogeneously? Because it is positive in a subset of blasts and negative in a subset of blasts. In third plot, we can see that it is my blasts are both positive for 19 and 79A, and then again brightly positive for CD10. So if we go by the WHO criteria, so bright positivity for CD19, CD79, and CD10. So we are dealing with BLA. This is a simple case to show you how the BLA looks like on the simple flow cytometric dot plots. So these are certain other combinations. So my blast here, they are 38 moderately positive. Then I have also included some markers like 81, CD1, 23, 58. These are the markers of aberrancy. And why we include these markers in our panel? For the MRD assessment. So if these markers are aberrantly expressed, then they help in MRD, they help us in identifying the leukemic clone of blast at the time of monitoring of the disease during miserable residual disease assessment. So what we call as LAIPs, leukemia associated aberrant immunophenotype. So based on these aberrant markers, we can actually label them as MRD positive or MRD negative. But since the today's talk is primarily focused on the diagnostic aspect of acute lymphoblastic leukemia, so I will just skip this MRD concept from here. Likewise, my blaster here MPO negative and CD7 negative. So this further confirms that this is we are not dealing with myeloid or T lineage blast. So these are this is a one simple case of BLN. Similarly, now moving to the maturation spectrum of normal T cell. So in T cell, again, the immature precursor state prothymocyte and immature thymocyte, they have the CD45 dimly expressed. CD34 is only present in a very primitive precursor T cells, and in the rest of the T cell maturation stages, they are CD34 negative. TDT again immature, another immaturity marker which is present there. Then we have CD7, which is a pan B cell marker, and though it is not a lineage specific marker, because it may be aberrantly expressed in lot of AMLs, but CD7 is one marker which is or more or less homogeneously expressed in all varieties of T acute lymphoblastic leukemias. And not only that, it's actually the pattern of expression is brighter than the normal T cells. So based on that, and like BLL, we have the immunological classification of TLL as well. So in the immunological classification of TLL, we have categorized it into again 4 categories: pro-TLL, pre-TLL, cortical TLL, and mature TLL, which we also call as medullary. So as we can see that lineage specific marker is cytoplasmic CD3 and CD7. They are positive in all four subtypes of TLS. TDT is positive till cortical TLL. And the very primitive variety of TLS, that is pro-TLS, they are negative for CD2, 5, and CD28. Primitive TLS, pro and pre-TLS, they are double negative for CD4, 8. Cortical TLL will be double positive for CD8, and mature TLL or medullary type of TLL will either express CD4 or CD8. Likewise, CD1A will be negative, only positive in the cortical variety of TLL. Surface CD3, in the immature variety, it is absent. It may be positive in the mature kind of TLL. CD34, it is variably present in the immature or true TLL subtype and negative in rest of the subtypes of TLL. Now, this is another flow cytometric dot plot. Here we are just showing a case of a routine TLL case. Again, we are in my blast window, around 89% blast are there with CD45 dim to moderate expression. If we can see the expression of cytoplasmic CD3, you can see this is a heterogeneous expression from very bright to negative, So we call this kind of expression as heterogeneous. So cytoplasmic CD3 is heterogeneously positive. Surface CD3 is negative. So if you refer to here, then surface CD3, it is essentially negative in the primitive varieties of TLS, pro, pre, and cortical kind of TLS. So we are dealing with one of these pro, pre, or cortical type of TLL. 7, very brightly positive here. 34, again positive in a subset. TDT is negative. CD56 is negative in this particular case. 1A. So 1A is positive. And if we can see 4 and 8 is double positive. So what we have learned just now is that cortical variety of TLL, they are double positive for CD4 and 8, and they are also expressing CD1. So this was the case of cortical kind of TLL. CD2 was negative. We have seen that in the very primitive kind of TLS, they may not express CD2 and CD5. So CD2 is negative in this particular case. Then negative for other myeloid markers like 13, 33, CD117, and negative for aberrant marker, which is CD123. So after that, uh, we have just done the three steps. Step one was the morphological identification. Step two was the lineage identification. Step three was immunophenotypic characterization. What is after that? So after assigning a lineage, after uh, extensively studying the immunophenotype of my B or T blast, the next step is cytogenetic and molecular studies. So I will not go into the details of cytogenetic and molecular studies. However, it is just we need to learn this from here that flow cytometry itself for immunophenotypic characterization do have the prediction for molecular profiling. So if we look into the VLL, so certain like MLL gene rearrangement 11q23 cytogenetic abnormality VLL. This is characteristically CD10 negative and associated with CD15 and NG2 expression. So we have to keep all these things in mind when we are dealing with a case. So if a particular CD10 negative case comes to us, then we look for CD15 and CGN and NG2, which is a surrogate marker for MLL gene rearrangement, and they may come positive on our flow cytometric immunophenotyping. Similarly, for BCR ABL fusion proteins, so it is actually expressing very brightly CD19 and CD34, and it may be positive for one or more myeloid markers. Similarly, is for translocation 1221. So here also we can see for the BCR ABL, it is frequently associated with the expression of myeloid antigens like CD13 and CD33, and may be associated with CD25 expression. So what we can see that immunophenotypic characterization or immunophenotypic detailing of the particular blast of B or T lineage, it do have the molecular correlation. So with this, I will just switch on to, the time is limited. So we will discuss few of the case-based exercises. So I've just included 3 or 4 cases of B and T ALS just to see how we encounter these cases in our real-life clinical scenarios and how do we make a diagnosis. So this is a first case. He was an elderly male, who was presented with fever and weight loss. It was severely pancytopenic with a very low hemoglobin TLC and platelet count of 60,000. Peripheral blood showed 25% blast. Bone marrow showed 70% blast. So these are the peripheral blood pictures. It was more or less cytopenic kind of picture with these kind of blast morphology was there. So they were looking like a L1 kind of morphology of lymphoid blast. So from here only we were pretty confident that we are dealing with ALL. And the next step, what was the next step? So the step 2, lineage identification as well as immunophenotypic characterization. So this is my CD45 versus site scatter plot. Here we can see that all my blasts are CD45 negative. The rest red colored highlighted events are cells are my blasts. So they are all lying in the CD45 negative zone. So my CD45 negative blasts are brightly expressing CD19, brightly expressing CD10, moderately expressing CD38. These are my plasma cells which are CD38 brightly expressed. CD20 is negative. CD123, which is the marker of aberrancy, this is also moderately positive. 58 is positive. 86 is brightly positive. 200 is positive. So this is a case of BLL. So just to summarize this case, so we are dealing with a case where it was CD45 dim with brighter expression of CD19 and cytoplasmic CD79 along with CD34 and CD10 expression. So this was a CD10 positive or Kala positive BLL. This is a routine case just to showcase. The take-home message from this particular case was that in majority of cases of BLL, CD19, cytoplasmic CD79 and cytoplasmic CD22 are always positive. However, no single marker is specific in isolation, as we have discussed already. Strong and uniform expression of one or more of these markers suggests lineage specificity. Now moving on to the case 2. So this was a 4-month male infant which was presented with fever and failure to thrive. Routine investigation revealed hyperleukocytosis, severe anemia, and severe thrombocytopenia was there. LDH was borderline raised. Peripheral blood smear showed 90% blast. I have not seen the photomicrograph of blast. All the blasts they were looking like morphologically lymphoid kind of morphology. Now, these are again the flow cytometric dot plots of this particular case. So here we can see that blasts were almost CD45, moderately positive. These are our mature T cells, which give blue color. If I take it as a positive control, so all my blasts here, they are CD45 moderately positive, negative for T lineage cells, cytoplasmic 3 and surface 3. So as I said, my blasts were morphologically lymphoid, however, negative for T lineage, negative for CD7 further. So this shows that we are not dealing with TLF. Negative for surface CD22 as well. But my blast were brightly positive for CD19. My blast were and only dimly positive for CD79A. You can see here CD79A was dimly expressed. Negative for CD20 and CD10 and negative for MPO. So we are not dealing with BLN. We are not dealing with myeloid kind of blast because cytoplasmic MPO was negative. We were not dealing with T lineage because it was negative for cytoplasmic alveolar surface CD3 and CD7 was also negative. Some B markers were positive. CD19 was very brightly positive. CD79A was dim positive and 20 and 10 were negative. So here comes the diagnostic dilemma in this particular case. So these are again some of the rest other markers to just show here. So blast were negative for CT117, HLA-DR 1333, 123 were moderately expressed, but it is again neither lineage associated nor lineage specific markers, not going to help. CD81 was again moderately positive. So in this particular case, if we look into the positive markers, what I was getting was only strong CD19 with moderate CD45 and weak cytoplasmic CD79. Only I have these set of positive markers. And negative for T lineage markers, myeloid markers, and other B lineage markers like CD10, cytoplasmic CD22, and CD20. So, what is the diagnosis? So the diagnostic dilemma in this particular case was one strong B marker, one weak B marker, bright CD45, and negativity for all other markers. So as per WHO guidelines, it was not fitting into any of the leukemia. So our differential was BLL versus acute undifferentiated leukemia if we are not able to assign a particular lineage. On revisiting the case, what we found that he was an infant. In view of looking at his age and CD10 negativity, we just put some additional markers, which were CD15 and NG2. And to our surprise, what we found was NG2 was found to be nicely positive in this particular case. As you can see here, CD15 was negative, however, NG2 was positive. So infantile leukemia, it is actually associated with MLL gene rearrangement. And since surrogate marker for rearrangement, which is NG2, which was found to be positive, so we label it as a based on a flow RPT or provisional diagnosis of infantile BLL was given. And later on, cytogenetics in this particular case also showed translocation 411, which was consistent with MLL gene rearrangement. So the final diagnosis was infantile BLL with MLL gene rearrangement. So the take-home message from this particular case is that MLL gene rearrangement, it is seen in de novo infantile leukemia and in adult secondary therapy related leukemia. So in cases of all CD10 negative cases, whenever there is CD10 is lacking, we should from the flow cytometry, we should always look for expression of aberrant myeloid markers, which is CD15 and NG2. Because a lot of time it happens like in this particular case, diagnostic difficulty may arise or dilemma may arise because none of one or few of the only conventional B cell markers are positive. And it is associated with usually poor outcome in infants. Now moving on to the third case. So this is a case 3, which was a 4-year-old child which is presented with again fever and mild leukocytosis of 25,000. Hemoglobin was 8.5. Peripheral blood smear shows 65% blast. Again, blast were morphologically lymphoid. Now, these are my flow cytometric dot plots. So here again, my blasts are CD45 moderately positive. Now, by this, we are able to interpret this my red colored blast. My blast are both. This case we just diagnosed last week at our center. This is positive for both surface CD3 as well as cytoplasmic CD3. As we can see here, So from our T cell maturation pattern table, what we learned that both surface CD3 and cytoplasmic CD3 positivity it is associated with majorly type of TALL. CD7 was again brightly positive, even brighter than my normal T cells. And 4 and 8, 4 was slightly heterogeneous, 8 was positive, moderately positive. So it was 4 and dual positive. CD5 was positive, CD2 was negative. Here we can see that in all the, this is again another thumb rule for TALL, that in TALL, in almost all cases, glass, they are overexpressing CD7, which is brighter than my normal CD4 and CD8 positive T cells. As we can see that CD7 is brightly expressed as compared to the normal T cell counterparts. Just to complete the list, again, it is negative for CD117 and other myeloid markers, which include CD14, 64, 13, 33. Negative for B cell markers, 19, 20, 10. So the final diagnosis was a TALL. So the take-home message from this case is that there is a for TALS there is variable positive expression of various T cell markers. In this particular case, it was negative for CD2 and positive for rest of the all T cell markers. CD34 is often negative in T cell, as in this case also. TDT, CD99, CD34, they show precursor nature and essentially they may or may not be present. It was also negative in last case. Now with this, we are just moving on to our last case, which was case 4. A 10-year-old child presented with fever and bone pains, moderate degree of anemia, borderline high TLC, and platelet counts of almost 1 lakh. Peripheral blood showed 40% blast, bone marrow showed 60% blast. So morphologically, these blasts, we would level it as myeloid. Morphologically, these were like the nice morphology. They are abundant cytoplasm, moderate to abundant amount of cytoplasm, prominent neutralized. So to us, it looked like myeloid blast. So now let's see what the immunophenotype characterization shows. So these are again my CD45 moderate to dim blast are there. They are brightly positive for CD7. All the blasts they are expressing cytoplasmic CD3, as you can see that they are cytoplasmic CD3 positive here with heterogeneous expression and surface CD3 negative. On my x-axis, surface CD3 is the surface CD3 is negative. So here, 4 and 8, all the blasts they are negative for, dual negative for 4, 8, negative for 5 and 2 as well, expressing CD56 and CD34. So till now, my blasts were cytoplasmic CD3 positive, CD7 brightly positive and negative for all other T cell markers, and CD34 was positive. CD56 was also positive. TDT was negative. CD117 was also negative in this particular case. CD19 was negative. CD10 was positive. CD1A was dim positive. CD38 was moderately positive. Then the CD33 and 13 sites are missing here. So CD33 was also positive in this particular case. So just to enumerate the positive and negative markers. So in this particular case, CD45 was moderate to dim positive, along with cytoplasmic CD3 and CD7. Myeloid marker CD33 was positive, along with aberrant CD56 positivity. CD34 was positive. CD10 was moderately positive. So and these were the list of negative markers of a CD3, CD2, CD5, CD4, and dual negative. So based on this, the diagnosis of ETP-ALL was set. So what is ETP-ALL? So if we look into the immunophenotypic profile of ETP-ALL, I didn't talk about this earlier because I'm talking here in detail. So ETP-ALL is a type of TLL which is characterized by the absence or characteristic absence of CD1 and CD8 negativity. Then CD45 absent or dim expression, which is usually the expression of CD5 is at least 1 log dimmer than the normal mature T cells, and it may express one of the following myeloid markers, which is CD33, CD13, HLA-DR, CD117, as well as immaturity associated markers like CD34. So in this particular case, if we see that my markers were, my blast were of T lineage expressing cytoplasmic CD3 and CD7, my blasts were expressing myeloid marker, which was CD33 and CD56. My blast was and expressing Primitive marker, which was CD34, and CD5 was CD5, 4, 8, and 1A was characteristically negative. That's why we labeled this case as ATP-ALL. So ATP-ALL, it is added as a provisional entity in WHO 2016. It actually arises from the primitive subsets of T blasts, which retain the multilineage differentiation potential because it expresses certain B lineage markers like CD10, myeloid markers like CD13, 33, and then stem cell markers are also present. So they have the potential to differentiate into multilineage differentiation, and that's why it has been included as a separate entity in the WHO classification. Why do we need to understand what is the clinical relevance of ETP-ALL? That increased because of this thing, the primitive kind of nature of this ETP-ALL. It is actually associated with a lot of genetic aberrations, and it is associated with overall poor prognosis. So it is associated with high risk of remission failure and hematological relapse. And patient may relapse as AML as well because there is a lot of overlap of ETP-ALL with AMLs. Low overall survival and event-free survival, and that's why it is very important to identify ETP-ALL at the time of diagnosis itself. Now, so with this, I would like to conclude my talk. So, just the concluding remarks are that immediate diagnosis of any acute leukemia, whether it is AML or ALL, relies on morphological and immunophenotypic features. And the diagnostic workup requires integrated approach and comprehensive assessment, as we have said, and it should be the diagnostic algorithm. It will be like step one. It's not like we are directly jumping into the flow cytometry or molecular studies. It has to be in the algorithm fashion where we first look into the morphology, after that release identification, then we look into the immunophenotypic characterization, and finally in molecular and cytogenetic abnormalities. And finally, the certain newer studies and the high throughput techniques like next generation sequencing, they are actually opening the newer facets for certain actionable newer mutations of these kind of acute leukemias for the targeted therapies in future. So that's all from my end. I would love to answer.
Good morning, everyone. And I would like to take this opportunity to thank Dr. Nupudas, who has set the stage for the day and has explained quite a bit about immunophenotyping and the basic gating strategies. So the work of rest of us becomes easier. So I'll be in the next 40 minutes, I'll be giving you an overview of chronic lymphoproliferative disorders, including multiple myeloma. Although 40 minutes is a short time to cover the entire spectrum, but I would try to cover the most frequently seen entities in the clinical practice. So if you look at the chronic lymphoproliferative disorders, you can classify them as Hodgkin's lymphoma, non-Hodgkin's lymphoma, the stroma-derived neoplasms of the lymphoid tissue, and the plasma cell. So today I'll be discussing with you the second and the fourth entity, that is the non-Hodgkin lymphoma or the chronic lymphoproliferative disorders of the B and T cell type, and a little bit about the plasma cell neoplasm. So if you look at the approach to the diagnosis of chronic lymphoproliferative disorders, there are essentially four different kinds of algorithm technologies that we use and fit it into the algorithm. So first and foremost is the clinical presentation, which is important because it gives us a clue as to which tissue should we be evaluating and what kind of illness our patient has. This is followed by the cytomorphology. Now, depending on the involved location, it can be peripheral blood or the bone marrow or the body fluids or the FNAC of a lymphoid tissue or the biopsy that you undertake, and look at the morphological spectrum of the CLPD. And the third is the immunophenotypic characterization, which can either be done using a flow cytometric immunophenotyping or in immunohistochemistry, which is done on a biopsy or a cell block. And finally, you also do the genotyping to further molecularly characterize the different entities. And for this, we can use fluorescent in situ hybridization and the entire spectrum of molecular studies ranging from various types of polymerase chain reactions to sequencing, which can be Sanger sequencing or next generation sequencing, and their variants thereof. So today We will be, because in this diagnostic way, we are focusing on flow cytometry. So I'll be dealing mostly on the immunophenotypic features of these chronic lymphoproliferative disorders as we encounter in our day-to-day practice. So if you have a case of suspected chronic lymphoproliferative disorder, this is the kind of algorithm that we follow. Whether this suspected CLPD is B type or the T type is based on whether they are CD19 positive or they are CD3 positive. So in our practice and in our country, we see 75 to 80% of our chronic lymphoproliferative disorders that we encounter as a liquid hematologist is B cell type. So that's why I focus this talk is more focused on the different kinds of B cell chronic lymphoproliferative disorders. So once we have figured out that it is a CD19 positive chronic lymphoproliferative disorders, we look at the other B cell lineage marker, frequently seen as the CD20. And then we also look at the expression of CD5. So this is the first step in classifying the BCLPDs. Is this BCLPD CD5 positive or negative? Within the CD5 positive category, the two main classes of chronic lymphoproliferative disorders are CLL, that is chronic lymphocytic leukemia, and the other is the mantle cell lymphoma. The other smaller, the fewer patients of BPLL and MBL are also seen and covered under this category. So let's look at the first and the most frequent entity in this group, which is CLL. Morphologically, these cells have a characteristically irregularly condensed chromatin, which has been likened to the look of a football, right? And apart from increased number of such cells in the peripheral blood smears, you also see some degenerating cells, which are known as the smudge cells, which are very characteristically seen in CLL smears. So sometimes not all the cells are of the same morphology, and when more than 10% of the cells have atypical morphology, atypical to the characteristic CLL morphology, for example, when you have larger cells, cells showing cleavage, or the cells showing abundant amount of cytoplasm or plasmacytoid appearance, we call them to have an atypical morphology. Sometimes the prolymphocytes may be increased, but you always get some typical CLL cells in the background. So here it is important to do an immunophenotyping to fully characterize and diagnose CLL. So I'll explain the immunophenotype using a case study. Here we had a 79-year-old lady who was incidentally found to have ITLC, right? So on CBC, she showed anemia, a high TLC, and a normal platelet count. So as you can see in the peripheral smear, these lymphocytes, they have clumped chromatin, they are small, some smudge cells are also seen. And when we did the immunophenotyping, so first we removed on the forward scatter height and the area plot, we removed the doublets, which you can see here. So we take the singlets and then we use 45 versus side scatter gating. The lymphoid cells have moderate to bright expression of 45 and they have low side scatter. So we gate the lymphoid cells because that is what is the population of interest here. And in the 519 plot, you can see an expansion of 5 positive, 19 positive cells. And these 5 positive, 19 positive cells show lambda light chain restriction, telling us that there is a expansion of this monoclonal population, which is lymphoid cells, which is not normal. These cells are 23 and 200 positive. So essentially what we are dealing with is a chronic lymphocytic leukemia, because this is the characteristic immunophenotype of CLL, 5 plus, 19 plus, light chain restricted, expression of 23 and 200. Now, apart from this, diagnosing this entity, we can also use immunophenotyping for prognostication. For example, the expression of 49D, which is associated with increased angiogenesis, accords a poor prognosis to CLL patients. Similarly, CD38, which is absent in this case, is associated with more proliferation, and ZAP70, which is again negative in this case, has been linked to the unmutated subtype of CLL, that is the unmutated IgHV gene, which is associated with poor prognosis. So initially, as early as 94, a scoring system was designed by Stella Mathieu's group, where they scored for presence or absence of these characteristic CLL markers. And when the score was 4 or more than 4, it was believed that we are dealing with CLL. And when it was less than that, they thought that they're dealing with some other CLPD. But now we have very specific markers for other CLPDs. So the scoring is more or less not used in clinical practice. So what is the to sum up this case, we have seen that there is an expansion of CD5 positive, CD19 positive monoclonal B cells. As per definition, they count for more than 5,000 cells in the peripheral blood. They are positive for CD23 and 200. We have seen that there are three prognostic markers which can be assessed using flow cytometry, that is CD38, ZAP70, and 49D. And using molecular FISH and NGS, you can identify other poor prognostic variables in CLL, which are deletion of 17p, deletion at 11q, and trisomy at 12q, which is associated with an intermediate prognosis. And on NGS, the mutations in TP53, Notch1, SF3B1, ATM, and BERG3 are associated with poor prognosis in CLL. However, for a wider application, a CLL International Prognostic Index takes into account only the 5 features: age more than 65 years, Binet and dye stage more than 0, that is from 1 to 4, then high beta-2 microglobulin levels, the mutated IGHV status, or deletion in 17p or TP53 mutations. So the next entity in the 5 positive, 19 positive group is the mantle cell lymphoma. Classically, they are small to intermediate size cells. They're slightly larger than the CLL cells, less condensed from it, and have a typical fish mouth notch in the nucleus, as is evident in the 2 cells shown on the right hand side. There are variable number of nuclei. They may vary from inconspicuous to a prominent nuclei. Now, mantle cell lymphoma, if present with the variants, it can be a small cell variant where the cells look more or less like CLL cells, or it can present with larger cells, which may confuse you with a DLBCL kind of morphology. So here, immunophenotyping is important to characterize the CLPD as mantle cell lymphoma. So in this case, a 50-year-old male who presented with abdominal distension, the ascitic fluid was stacked and sent for flow cytometric immunophenotyping. As you can appreciate, the morphology is really not contributory. You can see some smaller cells. Because of the condensation, the morphology is not very clear. So when we did the immunophenotyping on this case, you can see that there is a small subset of 19 positive, 5 positive cells, which shows kappa light chain restriction. Now, these cells are 23 negative and 200 negative. So we thought that we're dealing with a mantle cell lymphoma, and simultaneously, when we assess the peripheral blood in this patient, we realize that there is an expansion of 19 positive, 5 positive cells, which are negative for 23, which show kappa light chain restriction, have bright 20, and we confirm the diagnosis as mantle cell lymphoma. So apart from this, the other markers that one can use is the cyclin D1 on the bone marrow biopsy. So to move forward in the spectrum of 5 positive, 19 positive entities, we go to the third case, which is a 55-year-old male. He was asymptomatic. On routine evaluation, the CBC showed mild thrombocytopenia. There was no organomegaly. So the patient got a peripheral blood smear done, followed by an immunophenotyping. So here you can see that the lymphoid cells are really not very much increased. There is a population of 5 positive, 19 positive, dual positive lymphoid cells, which are positive for 23. But these B cells do not express kappa or lambda. Okay, so there is an absence of surface expression of light chains, right? And these cells are negative for CD10. So we are essentially not dealing with mature lymphoid cells or hematopoiesis. So they are mature lymphoid cells, which are 5 positive, 19 positive, 23 positive, and they're also positive for 200, negative for FMC7, and do not express surface light chains. So what are we dealing with? The TLC here is 9,000. So the total B lymphoid cells, our absolute count becomes 1,535. So we are dealing with a condition called monoclonal B cell lymphocytosis, where the total count is less than 5,000 and it does not fit into a diagnostic criteria for CLL. So MBL is defined as flow cytometric detection of a light chain restricted lymphocytosis. Now there is a detection of monoclonal B cell population in the peripheral blood with an altered kappa lambda ratio, and it has a disease specific immunophenotype. And in this example, the immunophenotype is consistent with a CLL like immunophenotype. The clone has to be persistent for more than 3 months, and features of other lymphoproliferative disorders must be excluded. Now, this MBL is further divided based on the cell count of the clonal B cells into a low count MBL and a high count MBL. So the cutoff is 500 monoclonal B cells in the peripheral blood. Why is it important to differentiate? Because high count MBL has a tendency to progress to the specific lymphoproliferative disorder. In this case, it was a CLL phenotype, so likely to progress to CLL. When it is a mantle cell kind, it can progress to a mantle cell lymphoma. So the yearly follow-up is recommended in high count MBL. Later on, people also reported a third kind of MBL, which is a tissue-based MBL, where the lymph node size is less than 1.5 centimeter on CT, and you do not see any proliferation centers on the lymph node biopsy. So essentially, the 19 positive, 5 positive clonal B cells, when they are more than 5,000, you're either dealing with CLL or mantle cell. Then you can do subsequent immunophenotyping to differentiate the two conditions. Then the IGHV unmutated mantle cell lymphoma also shows mutations in SOX11, and those which are mutated subtypes do not show mutations in SOX11. So, as opposed to previously believed, the MBL is not labeled as CLL even if cytopenias are present or the B symptoms are present. So now moving on to the last entity in this group is the prolymphocytic leukemia, which presents with splenomegaly characteristically. Then the diagnostic criteria is presence of more than 55% of the prolymphocytes in the peripheral blood, and often in PLL they can constitute more than 90%, and CLL with increased lymphocytes needs to be excluded to diagnose before making a diagnosis of prolymphocytic leukemia. So here morphologically you see slightly larger cells which are twice the size of the lymphocytes, and you may see moderately condensed chromatin and a prominent nucleolus. So in this 35-year-old lady, we found bilateral axillary lymphadenopathy. The CBC was deranged, and on cytomorphology in the peripheral smear, the characteristic cells of prolymphocytic morphology were seen. And when we did the immunophenotyping, we found a 5 positive 19 dual positive population which showed kappa light chain restriction, did not express CD10, was negative for 23, but was positive for 200 and FMC7. So diagnosis of B prolymphocytic leukemia was rendered. It is important to remember that 1/3 of the cases of BPLL may show absence of CD5 and 23, and in this case, 23 was absent. So we have now covered the CD5 positive B CLPDs. Now moving on to the next group, which is the CD5 negative group. Now the CD5 negative group can be further subdivided into CD10 positive CLPD and a CD10 positive CLPD. Within the CD10 negative CLPDs, the common ones are the splenic B-cell lymphoma, the hairy cell leukemia, and the lymphoplasmacytic lymphoma. Let's look at some of the cases to understand how does the immunophenotype of these variants look. So the splenic B-cell lymphoma, the cell size is medium between the CLL and the prolymphocyte. And important to see here is that they have hairy projections, and the hairy projection generally tends to be on one side of the nucleus or on both the sides of on the two poles of the cell, rather than the hairy, instead of hairy cell, in opposed to hairy cell leukemia, where you see the hairy projections all around the cell. Some of the cells may show lymphoplasmacytic features as well. So in this 54-year-old male who presented with generalized weakness and pain abdomen, we found mild anemia. The TLC and the platelet counts were normal. However, when the immunophenotyping was done in this case, there was an expansion of the 19 positive cells, which were positive for 20 but negative for CD10. This is important to distinguish it from the 10 positive CLPDs. The FMC7 was dimly expressed, 11C negative, and as you can see, these cells, the 19 positive cells, are positive for 25, but negative for 103, show kappa light chain restriction, and are negative for 23. So essentially, absence of 5 rules out any of the 5 positive CLPD, that is CLL, mantle, prolymphocytic leukemia. Positivity for 25 and negativity for 11C and 103 rules out a hairy cell leukemia, and presence of a splenic B-cell lymphoma. So our next entity in this group is a hairy cell leukemia. Characteristically, there is an expansion of this population within the spleen leading to splenomegaly. Patients typically present with pancytopenia because the massive spleen culls a lot of white blood cells. Characteristically, on peripheral blood smear, you see a monocytopenia. Now, as I explained, the hairy cell projections are seen all around the cells, and these cells are tartrate-resistant acid phosphatase positive. So in this 48-year-old male who presented with generalized weakness is AZ fatigability, we found moderate amount of splenomegaly. We found a pancytopenia, and the cytomorphology of the cells seen in the peripheral smear was characteristic of hairy cell leukemia. And now if you see the immunophenotyping, the 19 positive lymphoid cells show kappa light chain restriction, are dual positive for 2511C. They're also positive for 103 and 305, which is one of the other marker for hairy cell leukemia. These cells are negative for CD10. So this is a case of simple hairy cell leukemia. Now there is another variant of hairy cell leukemia, which is not very frequently seen, but here the TLC is high to normal, unlike the characteristic hairy cell leukemia, where there is leukopenia. Monocytopenia is characteristically absent. These cells may be TRAP negative. They can be 25 negative, but yes, they are 103 positive. And it is important to identify this variant because in XM5, which is usually done, immunohistochemistry is also negative in this hairy cell leukemia variant. The next entity in this group is a lymphoplasmacytic lymphoma. The name explains its morphology, that is, it has abundant amount of cytoplasm, lymphoplasmacytic kind of morphology. Here there is, in such cases, you see an admixture of small lymphocytes as well as plasma cells, and one needs to exclude the features of other lymphomas. So how does the immunophenotype of this entity looks? Let's see. So here in this real life case, what I would like to draw your attention to these small lymphocytes. Like I said, there is an admixture of small lymphocytes, plasma cells, and some lymphoplasmacytic cells here. So what are we dealing with? So here, if you see, there is an expansion, 20 positive B lymphoid cells, which are positive for 19 and 20, negative for 23 and 200. They show moderate expression of CD38 and show kappa light chain restriction. So because we were seeing a lot of plasma cells in the background, so we wanted to look at the immunophenotype of these plasma cells. Are we dealing with a plasma cell disorder, or are we dealing with a lymphoma? So here, look at the 138 positive plasma cells. They are bright 38 positive, but they are polyclonal on kappa lambda light chain expression, whereas the lymphoid cells, which are bright 38, not to the tune of plasma cells, but still a moderate amount of 38, they show kappa light chain restriction. So essentially, we are dealing with a lymphoplasmacytic lymphoma with proliferation of polyclonal plasma cells in the back. So we have covered the splenic B-cell lymphoma, the hairy cell leukemia, and the lymphoplasmacytic lymphoma. The important markers here are 103, 11C, 25, and 38. Although splenic B-cell lymphoma do not have any reported characteristic molecular abnormality, but they are associated with MAP2 kinase 1 mutations. Hairy cell leukemia have typically BRAF V600E mutation. The LPLs show mid88 L265P mutation, and those which are negative for this tend to show the CXCR4 mutations. So now we have covered the CD10 negative CLPDs. Also, coming to the CD10 positive CLPDs, the three entities that I'm going to discuss are the follicular lymphoma, the Burkitt leukemia, and the DLBCL. So let's look at the morphological features of the follicular lymphoma. They are small lymphocytes which show through and through cleaving, characteristic of the follicular lymphoma. So it has a uniformly condensed chromatin as opposed to the previous CLPDs. You will appreciate that the condensation is more here. So in this 22-year-old, let's see the immunophenotype. So here what you can see that these lymphoid cells, which have are 19 positive, are also showing expression of CD10. They're 38 positive. There is expression of 20. Here 23 is positive, but this is not an important marker for differential diagnosis. In the 5 negative, 10 positive CLPDs, 200 is again negative, and they show lambda light chain restriction. So we are dealing with a follicular lymphoma here. In addition to the immunophenotype, which I've shown you, these cells are also positive of BCL2 and BCL6 and negative for CD43, which is usually evaluated on the lymph node biopsy. So important here to remember is that the grade 3 follicular lymphoma may be CD10 negative, and when there is a spill from such grade 3 follicular lymphoma, you may not get the typical CD10 positivity on the peripheral smear or the peripheral blood and the bone marrow immunophenotype. So the next entity in this group is the Burkitt's leukemia, which has a very characteristic vacuolated cytoplasm appearance. And the 7-year-old male who presented with abdominal mass with ascites, the ascitic in the cerebrospinal fluid was seen for flow cytometric phenotyping. Here in the ascitic fluid, you can see a very nice morphological appearance typical of Burkitt's leukemia. In the cerebrospinal fluid, although you can see the vacuolation, but the morphology is not very well preserved. On immunophenotyping, we got a lot of viable cells, which were 19 positive, showed expression of 20 and 10. The TDT was negative. The 5 is also negative. There is a heterogeneous expression of surface IgM and bright expression of 38. They're negative for 23 and 200, and some expression of lambda, showing lambda light chain restriction. So this is a case of Burkitt's leukemia with characteristic morphology and immunophenotype. So in the 5 negative, 19 positive, 10 positive CLPDs, which we have covered, follicular lymphoma, the Burkitt's leukemia, and the follicular lymphoma are characteristically CD10 positive, surface IgM positive, may show expression of 38. The proliferation index is high, the space fraction is high in the Burkitt's lymphoma. The follicular lymphoma are associated with translocation 14-18, that is the BCL2 translocation. The Burkitt leukemia is associated with 8-14 translocation, which puts the MYC gene in a presence of strong enhancer, the IgH at chromosome 14. The DLBCL are the larger cells which look similar to the grade 3 follicular lymphoma, which can be the ABC, the activated B cell, or the germinal central B cell type. In the molecular subtyping or in the based on the origins of the lymphoma, the presence of MYC, BCL2 and BCL6 helps us classify these lymphomas as the double hit or the triple hit lymphoma, and some of them may be associated with EBV positivity. So we've covered the different entities within this group. Now, one entity that I would like to discuss here is which is 19 positive and 20 negative group. In this, the primary effusion lymphoma, the plasmablastic lymphoma, and the L positive LPL entities are there. So they're relatively very rare. The PELs are associated with the massive pleural effusions and infiltration by monoclonal B cells. The plasmablastic lymphoma generally has very cells which have plasmablastic morphology with eccentric nucleus of deep blue cytoplasm as shown here. These lesions are generally seen in immunocompromised patients, and this 40-year-old HIV positive male who presented with multiple lytic lesions, which makes us get confused with the multiple myeloma. However, the workup for the rest of the workup for multiple myeloma was negative. And here you can see the plasmablastic kind of morphology of these FNAC, which was done from the supraorbital mass in this patient. And what is interesting to note here is that the cells here are positive for CD138, which is a plasma cell specific marker. So despite being positive for 38 and 138, the cells do not show expression of CD27. They're not positive for 56 and rest of the markers, and they do not express the kappa and lambda light chains, show absence of cytoplasmic kappa and lambda. Here in this case, based on the morphology, the clinical features, and the immunophenotype, this case was labeled as plasmablastic. So we covered all these entities. Now moving on to the T lymphoproliferative disorders as shown by Dr. Nupur. This is the development pathway. So till the cortical lymphocytes, or an early medullary thymocyte, the precursor T cell lymphomas, which have already been discussed with the previous speakers. So in the late medullary thymocytes of the peripheral T cells give rise to peripheral T cell neoplasms or the T lymphoproliferative disorders. So as you can see, these will be positive for 7, 2, 5 and surface CD3. They will be negative for CD1A. They will be either positive for 8 and 4 and will be negative for TDT. So absence of TDT in 1A is taken as a post-thymic origin of the T cell neoplasm or the mature T cell neoplasm. So the common, there is a slightly different approach to the T cell PD as opposed to the PCLPD, where we were going down marker by marker and dividing them into different categories. Here, the common immunophenotypic abnormalities which are seen in TCLPDs are the alteration in the ratio of CD4 and 8, an abnormal expression or loss of one of the pan T cell antigen, abnormally elevated expression of other T cell associated markers, some of the NK cell markers like 56, 16, and 57. There may be an abnormal expression of 1038 and Ki67, which is a proliferation marker. Now, for the monoclonality in the mature T cells, we have a new marker called TRBC1, where the altered ratios of the TRBCs, one, help you decide on monoclonality, or you can also see the restricted expression of the V beta repertoire of the T cell receptors. So the common TCLPDs that I'm going to discuss today are large granular lymphocytic leukemia, the aggressive NK cell leukemia, ATLL, and the hepatosplenic gamma delta T cell. So the TLGL is a heterogeneous disorder, and it is characterized by cytopenia and a modest amount of lymphocytosis. And it is associated with autoimmune disorders in up to 1/3 of the patients. It has an indolent course, and because of the indolent course association with autoimmune disorders and only a modest lymphocytosis, these patients come to attention a little late during the course of their disease. So morphologically, you just see an expansion of granular lymphocytes in the peripheral spleen, which is easily overlooked. The immunophenotype is that they're positive for the mature T cell markers, they're negative for TDT and 1A. Most 80% of the TLGLs are CD8 positive, but various combinations of 4/8 can be seen. So in this 50-year-old male who presented with fever and generalized lymphadenopathy, you can see there is, we did not encounter any lymphocytosis. However, there were 45% lymphoid cells on the peripheral blood smear. There was slight anemia and the thrombocytopenia was there. So on the peripheral blood smear, we noticed the large majority of the lymphoid cells were of the lymphogranular lymphocyte morphology. So when we did the immunophenotyping, we found that these cells were three positive. There is an expansion of these 3 positive cells, which are positive for 2 and 7, as well as 5. And there is a swing of the CD4/8 ratio. So it's in the favor of CD8 positivity, and these cells were positive for 56. So we made a diagnosis of TLGL in this case. So apart from these, the other markers that you can see is the absence or restricted expression of the KIR antigens, which are 51, 58A, B, and E. So in this particular case, there is an absence of all the 3 KIRs. And in addition, you can see a restricted expression of B beta 3 in this case. So that helps us clinch the clonality in this T cell compound. So the aggressive NK cell leukemias present with the acute features of fever. They can present with the organomegaly. There is essentially a leukemic blood picture with increased counts, anemia, thrombocytopenia. The patients may present with coagulopathy and multiple organ failure. So here you can see their larger cells with the granular lymphocytes. The immunophenotype here is that these cells, although positive for cytoplasmic CD3, they may be negative for surface CD3. They show expression of 56 and an expression of variable amounts of 1657 and other NK cell associated markers. So this 25-year-old male who presented with fever, body aches, and lymphadenopathy, I'm afraid the picture is not very good. As you can see that this looks a little immature kind of morphology with opened up prominent nucleoli. So we found such 25% of normal cells in the peripheral spleen, and when we did the immunophenotyping, we saw that these cells have moderate amount of some granules because the side scatter is high. They are bright 45 positive, dual negative for 4 and 8. They do not express CD5 or 19. They are positive for 7 and show bright expression of 56. They also express CD2. They have moderate amount of moderate to negative CD16. So here we are dealing with an NK cell leukemia. The next entity in this group is an adult T-cell leukemia lymphoma, which is related to the HTLV-1 infection. Patients present with generalized lymphadenopathy, hepatosplenomegaly, there can be hypercalcemia and lytic bone lesion. The blood picture varies, and that is why it is difficult to diagnose initially. The cells tend to have pleomorphic nuclei with irregular contours, and normally we feel that we sometimes tend to think that probably because of the sample has been kept or the blood has been kept for too long, there are degenerative changes. So in such cases, a finger prick smear should be made. And the T cell markers, these ATLs are characteristically CD25 positive. They may show expression of CD30. The negative is CD7, and the HTLV1 positivity clinches the diagnosis. Another important entity in this group is the hepatosplenic gamma delta T cell lymphoma. Although it is a very rare disorder, but 86% of the patients are males. They present with hepatosplenomegaly and B symptoms. It is important to diagnose this condition because it is an aggressive form of TCLPD. And in this 16-year-old male who presented with fever and malaise, you can see that there is a leukocytosis. The platelet counts are reduced. On the peripheral smear and the bone marrow aspirate, abnormal lymphoid cells were seen. And when the immunophenotyping was done, you can see that there is an expansion of CD3 cells, which are positive for 7, negative for 56, and they show restriction for gamma delta. So there is an expansion of gamma delta. Normally, more than 95% of the cells are alpha beta positive and less than 5% of gamma delta. Here you can see a clear reversal. These cells are negative for CD5. They do express CD2, and they're negative for 4 and 8. So here we are dealing with a hepatosplenic gamma delta T cell. So the third part of the talk is the immunophenotyping in multiple myeloma. So normally the diagnosis of multiple myeloma is based on the clinical features, the radiological evaluation, and the evaluation of the molecular and protein. So for diagnosis, you really don't require immunophenotyping in myeloma as opposed to acute leukemia. But how does immunophenotyping is found a place in the evaluation of multiple myeloma? And we'll see some of the scenarios where it is useful. So FCMI essentially helps us in assessing the size of the clonal plasma cell compartment, as you would realize that morphologically it is different to differentiate between the normal, that is the polyclonal, and the clonal plasma cells, because there may not be much differences morphologically. So flow cytometry immunophenotyping is essentially required to assess the clonality in the plasma cells. So how does the size of the clonal plasma cell compartment helps us by evaluation of this in the peripheral blood? If we see the circulating plasma cells, we'll see what is the connotation of finding circulating plasma cells, and how does the size of the bone marrow plasma cell compartment helps us in assessing plasma cell proliferative disorders. And in addition, flow cytometric immunophenotyping is also used for monitoring response to treatment in myeloma patients. So there have been a number of studies where people have evaluated the circulating plasma cells in myeloma as well as in the plasma cell proliferative disorders. So the study very nicely showed that the increased number of the presence of the clonal circulating plasma cells with that we are able to predict myeloma patients who are likely to have a relapse in disease. So here they very nicely showed that patients who have circulating plasma cells of more than 100 per microliter predicts worse survival in the relapsed multiple myeloma. So in addition to predicting relapse, it also helps us predicting survival in multiple myeloma. So the presence of circulating plasma cells is also associated with high-risk multiple myeloma. Recent studies have shown that the cutoff of 2% CTCs helps identify a very ultra-high risk of plasma cell-like multiple myeloma in newly diagnosed patients of myeloma. So this parameter is important, and thus one can use the flow cytometric immunophenotyping to assess the circulating plasma cells and predict outcome in myeloma patients. So currently, the next generation flow cytometric assay, which is a very sensitive method, has been applied on peripheral blood. for the assessment of circulating plasma cells. So now let's see how the size of the clonal plasma cell compartment is useful in assessing risk of progression to multiple myeloma and various plasma cell-derived disorders. So as you know that with the progression from the state of MGUS to smoldering myeloma to multiple myeloma and plasma cell leukemia, there is a consistent increase in the clonal plasma cell load. So in tune with that, the presence of the increase in the clonal plasma cell compartment, we are able to predict the transformation in the cases of MGUS or solitary plasmacytoma or smoldering multiple myeloma to multiple myeloma. So various studies have identified various cutoffs. So in MGUS samples, it is believed that the normal plasma cells constitute at least more than 20% of the total plasma cell compartment. And patients who have more than 90% PCs with CD19 negativity correlates with potential for disease progression in MGUS patients. So this is in another study from the Spanish group who very nicely showed that in the presence of more than 95% of aberrant or the clonal plasma cells of the bone marrow plasma cell compartment correlates with progression-free survival in smoldering multiple myeloma. So thus, risk of progression in MGUS and smoldering multiple myeloma is related to the size of the clonal plasma cell compartment, and thus the flow cytometric immunophenotyping is useful in this instance. Similarly, for plasmacytomas of the solitary plasmacytomas of the bone, where the clonal plasma cells are identified in the bone marrow compartment, the presence is associated with poor outcome. So similarly, this is another study where presence of the clonal plasma cells in the bone marrow has been identified as a criteria for risk of progression to multiple myeloma. So now in the recent 2017 studies, the cutoff of more than 150 circulating plasma cells in smoldering multiple myeloma has helped us identify patients with high risk of progression to multiple myeloma. Now, the second aspect of the flow cytometric immunophenotyping in plasma cell proliferative disorders is to assess the depth of response. As the slide very clearly shows, as the depth of response increases, it has a direct connotation in time to next progression in myeloma patients. Since flow cytometry is a very sensitive technique for identification of small numbers of plasma cells, it has been shown that with each log depletion of the clonal plasma cells, there is a superior progression-free survival and overall survival in myeloma patients. So based on various studies, on all these studies which have shown superior survival outcomes in MRD negative or flow cytometric immunophenotyping absence of clonal plasma cells, the International Myeloma Working Group has defined the MRD criteria used as the flow MRD negative criteria as one of the response criteria for multiple myeloma. So how do we do the immunophenotyping? First, we identify the plasma cells on the bone marrow using plasma cell associated and specific marker. So plasma cells typically have very high expression of CD38 and CD138. They show dim to negative expression of 45, and a combination of these three markers is used to gate the plasma cells from the rest of the bone marrow cell compartments. Apart from this 138, the newer markers which have been identified, which are plasma cell associated, are CD229 and CD319, which can also be used to gate the plasma cells. Now, once you have gated the plasma cells, you look at the expression of markers which are expressed on the normal plasma cells and those which are expressed apparently on the abnormal plasma cells. So the normal or the polyclonal plasma cells are typically positive for shown in green here, and the aberrant or the clonal plasma cells are shown in orange here, as you will appreciate that although here both the cells are expressing similar level of 27, the aberrant PCs are positive for 56, whereas normal are negative for 56. The normal plasma cells are moderate, dim to moderate expression of 19, whereas the aberrant plasma cells are dim to negative for CD19. And here the expression of AT1 is variable. The aberrant plasma cells may show higher or lower expression of AT1. In this case, they almost have similar expression of AT1 as the normal plasma cells. And the normal plasma cells, if you see at the cytoplasmic kappa-lambda plot, are polyclonal, whereas the aberrant, the orange colored plasma cells are monoclonal and show kappa light chain restriction. So some of the immunophenotypic aberrancies are present in this case in the aberrant plasma cells, but not all. So that means we need to use a combination of different markers to help us identify the aberrant plasma cells, and then we can look at the clonality in these aberrant plasma cells. So this is what is used to identify the residual disease or the MRD. First, we gate the plasma cells. Then we, based on the aberrant immunophenotype, we try to identify the aberrant plasma cells, which are in this case 56 positive, negative for 27, whereas the normal plasma cells, as you can see, is the 80% of the plasma cells here are normal plasma cells, because this is the case of myelotherapy. The normal plasma cells are positive for 27, negative for CD56. And here they are showing polyclonality on kappa lambda plot, whereas the aberrant plasma cells show kappa light chain restriction. So just imagine if we had not used the immunophenotypic aberrancies and just looked at the light chain restriction on the total plasma cells, the kappa lambda ratio of 1.41 in this case, we wouldn't have been able to identify the residual clonal plasma cells in this case. So hence it is important in myeloma immunophenotyping to combine the immunophenotypic aberrancies with the light chain restriction. In the second case here, you can see that the normal plasma cells are constituting 82% of the plasma cell compartment. The aberrant PCs are 17%. They show a light chain restriction and if you look at the total kappa lambda light chain ratio, it is within the normal limit at 0.29, but the lambda restricted population based on the we have been able to identify based on the immunophenotypic aberrancies. So with this, I end my presentations, and any questions are welcome now.
The cancer of marrow and blood. Again, acute myeloid leukemia is characterized by clonal neoplastic proliferation of myeloid precursors in the marrow and arrest in their maturation. The incidence increases with age. From 30 to 40 year, it is about 1 case per 1 lakh population. To the age of 65 to 69 year, it is about 10 cases per 1 lakh population. The median age of presentation is about 67 year. Coming to the etiology, in 90% of cases, the AML etiology is unknown. The most common, in rest of the cases, the genetic factor, the radiation exposure, drugs like alkylating agents, platinum like cisplatin and carboplatin, and topoisomerase 2 inhibitors, and ionizing radiation may cause acute myeloid leukemia. In genetic factors include chromosomal abnormalities and instability, like Fanconi anemia, ataxia telangiectasia, Bloom syndrome, Diamond-Blackfan anemia, Down syndrome, Swarman-Diamond syndrome, Leaf-Ferman syndrome, neurofibromatosis type 1, and severe congenital neutropenia, etc. The most common symptoms, signs and symptoms of acute myeloid leukemias are fever, pale complexion due to anemia, signs of bleeding due to low platelet count, like black and blue marks and bruises occurring without any reason or with minor injury, an appearance of pinhead-sized red spot in the skin called petechiae, or prolonged bleeding from the minor pores. It can cause swollen gum, like due to gum hypertrophy. Frequent minor infections such as perianal sores may occur. Loss of appetite and weight loss are also very common cause. Commonly occur in acute myeloid leukemia. Discomfort in bones or joints and hepatosplenomegaly may associated with acute myeloid leukemia. And fever is the most common symptom associated with acute myeloid leukemia. Coming to the common investigations we're doing in acute myeloid leukemia, the most common one is the complete blood count. Because the acute myeloid leukemia may be presented with cytopenias like anemia, leukopenias, or thrombocytopenias, and the differential count in which from the peripheral smear we can detect blast, and further we can evaluate those blasts on bone marrow, and we can stamp it as a myeloid lineage. Peripheral smear examination is very crucial. Along with that, bone marrow aspiration with bone marrow biopsy and flow cytometry, cytogenetics, and molecular studies are the essential tests which are required for in the diagnosis of acute myeloid leukemia. And cytogenetics and molecular studies are predominantly required in stamping it as proper AML with recurrent cytogenetic abnormality, and also for the further prognostication of the AML cases. This is the recent WHO classification of myeloid neoplasm. The myeloid neoplasm defining genetic abnormality includes acute promyelocytic leukemia with PML RARA fusion, acute myeloid leukemia with RUNX1 and RUNX1T1 fusion, acute myeloid leukemia with CBFB MYH11 fusion, acute myeloid leukemia with DEC214 fusion, acute myeloid leukemia with RBM15 MRTF1 fusion, acute myeloid leukemia with BCL-ABL1 fusion. It's a newly added entity. Acute myeloid leukemia with KMT2A arrangement, MLL rearrangement with AML, acute myeloid leukemia with MECOM rearrangement, acute myeloid leukemia with LUK98 rearrangement, acute myeloid leukemia with NPM1 and SEPA mutation. These are provisional entity in the previous edition, but now these are the entity included already in the classification. Acute myeloid leukemia, myeloid splash related changes, and acute myeloid leukemia with other defining genetic alteration. Along with that, therapy-related myeloid neoplasm and myeloid sarcoma and myeloid proliferation associated with Down syndrome is also included in AML classification. And the other, which are not fitting into this, that is the acute myeloid leukemia with not otherwise specified, include acute myeloid leukemia with minimal differentiation, acute myeloid leukemia without maturation, with maturation, acute basophilic leukemia, acute myelomonocytic leukemia, acute monocytic leukemia, acute erythroid leukemia, which include only the pure erythroid leukemia part, and acute megakaryoblast leukemia. Coming to the FAB classification, which is based on the morphological classification of the acute myeloid leukemia. M0 includes undifferentiated acute leukemia. M1 is AML without maturation. M2 is AML with maturation. M3 is acute promyelocytic leukemia. M4 is acute myelomonocytic leukemia. EO is the myelomonocytic leukemia with eosinophilia. M5 is monoblastic and monocytic leukemia. M6 is acute erythroid leukemia. And M7 is the acute megakaryoblast leukemia. AML with maturation is the most prevalent type of acute myeloid leukemia. Coming to the diagnosis of the acute myeloid leukemia, morphology is the primary for the diagnosis. The bone marrow aspiration and peripheral blood smear examination, we have to found the myeloblast or the myeloblast equivalent like acute promyelocytes or promonoblast or promonocytes to stamp it as acute leukemia. If the percentage of the blast or the equivalent cells are more than 10%, then we can subjected those patients to the cytogenetic and molecular studies to evaluate further. If any recurrent cytogenetic abnormality detected without more than 20% criteria of acute myeloid leukemia, we can stamp it as acute myeloid leukemia. Or else, if it is more than 20%, then we further evaluate the lineage of the blast, like these are myeloblast or monoblast or megakaryoblast or erythroblast, to further classify these cells. For further lineage classification, flow cytometry is the best method and widely available method to evaluate in acute myeloid leukemia diagnosis. For stem cells, we can use a marker like CD34 and CD117. For myeloblast, the common markers are CD117, CD13, CD33, HLA-DR, CD15, and CD16. For monocytic marker, CD13 and 33 are very bright in monocytic cells. Along with that, 36, CD64, CD14, and lysozymes are important monocytic markers. Erythroblast markers are CD71 and CD235A, that is glycophorine. Along with that, CD36 is also positive in erythroblast. In megakaryoblast, CD41, CD42B, and CD61 were important markers to ascertain the lineage. For basophilic lineage, for diagnosis of acute basophilic leukemia, the important markers are CD123, CD203, and CD9. Along with that, CD34 may be positive in those acute basophilic leukemia, and it is also positive. It can be also positive for CD13, 33, and HLA-DR. Sometimes CD22 may also positive in acute basophilic leukemia. Along with these lineage-related markers, some aberrant other lineage markers may become positive in acute myeloid leukemia. The common markers are CD7, CD2, CD19, CD79A, CD56, and CD4. CD7, 2, and CD4 are T lineage markers, but these markers can come in acute myeloid leukemia. 19 and 79 are B lineage markers, which can we can observe these markers in acute myeloid leukemia with translocation 821 21, and CD56 is also an important aberrant marker in acute myeloid leukemia. Flow cytometry is not only helpful in diagnosing the acute myeloid leukemia, it is also helpful in prognostication of the cases, like CD56 is a poor prognosis marker. CD7 positive AML is also diagnostic poor. So these are also poor prognostic markers. And along with that, these markers may indicate a particular cytogenetic abnormality. Like as I said, CD19 and CD79A positivity may indicate 821 translocation in AML. So this indicates something. Like HLA-DR and 34 negativity can also indicate NPM1 positivity in AML. So this flow cytometry, along with diagnosis, prognosis, it can indicate the genetic aberration. Along with that, lastly, it can also help in minimal residual disease assessment. The flow cytometry overall is a very essential investigation in acute myeloid leukemia. So here I'm giving you few examples of acute myeloid leukemia. This is the case of AML M2. As I've discussed morphologically, acute M0 is with minimal differentiation. In this case, the blast population is predominantly medium to large size of cells with somehow condensed chromatin and inconspicuous nuclei and very scanty amount of cytoplasm. They may mimic lymphoblast. And these cells are negative for MPO and Sudan black B and NSC. All of these markers, cytochemistry, are negative for in M0 blast. In M1, that is with minimal differentiation, without maturation. The maturing cells are less than the MPO positivity is less than 3% of cells, and the more than 3% of cell. In M0, it is less than 3% of cells. In M1, it is more than 3% of cells, but the maturing cells are less than 10%. That the granulocytic maturing cells of granulocytic series are less than 10%. This is M1 without maturation, and M2 is with maturation. In these cases, the blasts are less than 90%. That is, the maturing cell is more than 10%. These blasts are medium to large size with granular cytoplasm. Orod is also visible, like in this cell. In this blast, the orod is visible. There are 3 to 4 inconspicuous nuclei with granular cytoplasm and presence of orod. This is a flow cytometric evaluation of of this case. The blast, the red color indicate the blast. After getting the viable cells, when we get the blast, these blasts are 34 positive with 117 positive, 11B negative, DR and 33 positive, 38 positive and 13 positive, 16 negative and 123 negative, 56 negative, 7 negative. These blue cells are are normal T cells which are positive for CD7. It's a control. It is a control for CD7. These cells, these blasts are also negative for 64 and 36, 14 and 4. So in this case, the blasts are mostly positive for CD34, 117, 1333, DR, and CD38. And these are also positive for moderately positive for CD45 with high side scatter. The high side scatter is due to granularity of the blast. So this is a case of AML. This is another case of AML with monocytic differentiation. Here the abnormal cells are very large with moderate to abundant amount of cytoplasm, which are finely granular. The cells show a convoluted nucleus with folding. So these are monoblast and promonocytes. From the morphology itself, we can guess this is a type of AML with monocytic differentiation. So in AML with monocytic differentiation, according to the morphological classification, we have predominantly two categories. That is M4, that is myelomonocytic leukemia, and another one is M5, that is acute monocytic or acute monoblastic leukemia. In myelomonocytic leukemia, there is two components. One, 20% of the cell is myeloblast, and 20% of cell is monocytic cells. Monocytic cells may include promonocyte and monoblast. In M5, that is monoblastic monocytic leukemia, more than 80% cells are of monocytic lineage. If there is prominence of monocytes and promonocytes, then it is a monocytic leukemia. And if there is prominence of monoblast, as we have seen in this case, then it is a acute monoblastic leukemia. So these blasts are CD45 positive, 34 negative, 34 usually negative in acute monoblastic leukemia. 117 is very dim, but as we can see, it is very good bright positive for 1333. 11B is also heterogeneously positive, 16 is negative, 123 is positive, 64 is positive, 14 is negative. If it is monocytic, 14 is positive because it's a mature monocytic marker. But in monoblast, predominantly CD64 is positive and CD14 is negative. This case is also shows positivity for CD56, which is a prognostic marker for acute myeloid leukemia. So this, in this case, the blast lie in the blast region with high scatter, which are positive for brightly positive for 1333, 11B, and 64. On the basis of that, we can stamp it as acute monoblastic leukemia along with the morphology. This is another case of monocytic. I've shown here to see so that the scatter may be high and that may overlap with the monocytic region. This is also positive for 33 and 64 and DR and 123, and 11C is also a very important marker to stamp it as monoblastic leukemia. This is another case which overlie the position of the blast is overlying the monocytic region with the similar markers. Coming to acute promyelocytic leukemia, these are promyelocytes seen in the peripheral blood and bone marrow. These cells are showing bilobed nucleus, very huge cells with abundant amount of densely granular cytoplasm with a buttock-shaped nucleus, bilobed nucleus, and multiple orders called faggots. Faggots are very pathognomonic of acute promyelocytic leukemia. This is a bone marrow picture of the similar case. Where we can see heavily granulated promyelocytes along with faggot cell with multiple orders. In this case, the promyelocytes overlie in the region of maturing granulocytic cells because of its high granularity. These cells are mostly 34D, the 34DR negative, but 34DR may come positive in acute promyelocytic leukemia. The flow is not that diagnostic of APML. APML diagnosis is primarily based on the morphology and the molecular or fish analysis for PML RARA, that is diagnostic of acute promyelocytic leukemia. But flow can be a supportive marker for in the diagnosis of acute monocytic leukemia. In cases in which those are with very high scatter with 34 negativity, as we have seen in this case, the DR is also negative. 34 is very dim positive. It's not totally negative. It's a very dim positive. Along with 13 and 33 homogeneous bright positive. That is also a characteristic of acute promyelocytic leukemia. 117 positive. Monocytic markers are 11B negative, 38 positive, CD15 negative, 9 positive, 18 negative, 64 is dim, which can come in acute promyelocytic leukemia. So in this case, though the cells are CD30, the blast are CD34, promyelocytes are CD34 dim positive, along with HLA-DR negative, 1333 bright positive, CD9 positive, which is also an important marker in acute promyelocytic leukemia. Apart from the acute promyelocytic leukemia, other acute myeloid leukemias are predominantly CD18 positive and CD9 negative, which is reverse in acute promyelocytic leukemia. So it is also supportive of acute promyelocytic leukemia diagnosis. This is the case of acute promyelocytic leukemia. But the HLA-DR negativity can seen in AML with NPM1 mutation. Here I am showing another case. This is a case of AML with NPM1 mutation. This blast mimics promyelocytes with bilobed nucleus with granular cytoplasm and also with 2 to 3 odd dots in this blast. These blasts are also MPO strong positive and the MPO positivity in these odd dots. But as we can see, these blasts are not that strong positive, which can indicate this may not be a acute promyelocytic leukemia. The flow cytometry again show this blast with very high scatter with similar kind of positivity. So we have to be cautious at the time of AML with NPM1 mutation to misdiagnose it acute promyelocytic leukemia. So morphology is very important. As I have said, the definite diagnosis is totally dependent on the cytogenetic and molecular study, the first diagnosis of PML-RA or the molecular diagnosis of PML-RA presence. Coming to acute pure erythroid leukemia, this is a case of pure erythroid leukemia. The blasts are very large with a high NC ratio. The cytoplasm is with cytoplasmic bleeding and vacuolations. Very bizarre looking cells with cytoplasmic vacuolations. And these blasts are present in CD45 blast region. These are blasts are negative for 13, 33, 34, 79, A, 19, cytoplasmic 3 and surface 3, CD117 and CD38. All the lineage markers are negative. A very small fraction of cell is positive for CD34. CD7 is also negative. CD56 is also negative. But the cells are positive for CD71 and CD235A and CD36. As I have said, in erythroblast, there may be presence of myeloid marker like 1333, but those may be absent in erythroblast. 34 may be present or may be absent, but the important markers which stamp it as erythroblast are CD71, CD235 and CD36 is also an important marker in diagnosis of M6. It's the AML with basophilic blast. The blasts are present in CD45 moderate positive blast region, but there is a population of blasts which are positive for CD123 and negative for 117, positive for CD33, and it's also positive for CD9. As I previously told you, the basophilic markers, important basophilic markers are CD203C, CD9, and CD123. There may be a fraction of blast or all the blast may be basophilic blast. These blasts show irregular nucleus with very coarsely basophilic granules. When coming to acute megakardioblastic leukemia, this is a case of acute megakardioblastic leukemia with micromegakaryocytes and very variable size of platelets. That is platelet anisocytosis. These are megakaryoblast with pseudocytoplasmic processes. These blasts are predominantly positive for CD41 and CD61. So this is a case. The blast red color blast are present in the CD45 dimer area, which are negative for 11B, 16, 13, 33. 13 is a dim positivity for 13, but 33 it's clearly negative. These are the normal monocytic cells. The control for the 13 and 33. The 34 is also negative. 117 is also negative. DR 123 negative. 16 and 16 is also negative. 16 and 11 are also negative. But these cells are positive for 61 and 41. And so the in acute megakardioblastic leukemia, the blasts are may be positive for CD34, may have CD13 or 33, but the important marker is CD61, CD41, and CD42B, and these are characteristic of megakardioblasts. And to stamp it as acute megakardioblastic leukemia, at least more than 30% should be a megakaryoblast. This is another interesting case of AML with RAM phenotype. AML with RAM phenotype is an entirety with poor prognosis, which is characterized by positivity of CD56, moderate to bright positivity of CD56, with CD45 negative, CD30, 45 and CD38 negative to dim, and HLA-DR negativity. This is the morphology of the AML with RAM phenotype. The cells are looking bizarre with scanty to moderate amount of decorated cytoplasm. They form cohesive clusters. They are very hypercellular smears. The cells show cytoplasmic bleeding and vacuolations, and it may mimic a metastasis. So, summarizing the types of FAB classification of acute myeloid leukemia, the M0 is with minimal differentiation, which shows less than 3% MPO positivity. Then without maturation, more than 3% MPO Sudan black B positivity, MSC negative or maybe VP positive. With less than 10% of the maturing cells, maturing granulocytic series of cells. M2 is with maturation with more than 3% MPO positivity, with more than 10% of maturing cells. M3 is not included in the FAB. It is in the AML with recurrent cytogenetic abnormality. This shows promyelocyte and with positivity of PML-DARA. Then M4 is myelomonocytic. 20% of myeloblasts and 20% of monocytic cells both may be present. There may be more than 3% of MPO positivity with monocytic cells showing MSC positivity. Then monoblastic or monocytic cells, monoblastic and monocytic leukemia M5, which include more than 80% of monocytic cells. If those cells are more than predominantly monoblast, that is monoblastic leukemia. If it is monocytes and promonocytes, then it is monocytic leukemia. Then M6 is the pure erythroid leukemia. More than 80% are erythroid series of cells, which include more than 20% of proerythroblast. And then M7 is the megakardioblastic leukemia, which include at least more than 30% of blast showing megakardioblastic differentiation. So the response assessment of the AML is evolving, and it's very important to measure the minimal residual disease for the assessment of the for the prognostication and further management of the AML patients. So these are the different method we have done for the MRD assessment, in which flow cytometry is the most cost effective and widely available method. And it is also applicable in more than 90% cases of acute myeloid leukemia. For flow cytometry, we require the fresh sample. We have to acquire at least 1 million of sample, and it's a very rapid test. We can a rapid and cost-effective test in comparison to the allele-specific PCR and next-generation sequencing, which are expensive tests and it's take longer time, and it's not also applicable in every patient of AML. So, evaluation of the number of events acquired is a key step in the interpretation of MRD. The numerator is the blast followed by the identification of LAIP, and the denominator is the total bone marrow cells. In AML MRD evaluation, we mostly use the two methods, like different from normal approach and the LAIP method. We should know the normal myeloblast maturation, so that we can detect if it is deviate from the normal myeloblast maturation. In LAIP method, we can detect the aberrant markers, or we can see the over or under expression of some normal markers. Like normally the blast are CD34 positive, but we can evaluate the overexpression of 34 or underexpression of something. The CD117 or CD117 may be underexpressed or overexpressed. Likewise, CD13 is a very known underexpressed marker, which we can evaluate at the time of MRD evaluation. In aberrant marker, as we said, the common aberrant marker are CD7, CD56, CD4, CD2. These are important marker. If these are common, there is a positive on the blast, which can take it as a LAIP. And we need at least two marker to stamp it as a MRT positive thing. To call this a MRT positive, we need at least two marker to be positive. And in AML, in clinical setup, at least 0.1% is the cutoff for the positivity to be clinically significant. In contrast to the BALL and DLL, which are 0.01%, in AML it's 0.1%. The minimum event we required is 1 million cells per diagnosis and per tube. The FCMI data would be analyzed using sequential gating strategy with Boolean gating and evaluated by presence of LAIP or different from normal approach. So this is the gating approach. First, we see in the time plot there is no interruption in the flow of the sample. Then we gate the singlet cells by forward area versus height. Then we gate the viable cells. We can use a viable die to get the viable cell, but here we are using forward versus side scatter to evaluate the viable cells. Then these are the cells on which we can calculate the MRD levels. Then the mononuclear cells can be gated from the CD38 plot, and these are the granulocytic cells, and the CD38 bright is the plasma cells, which we can explain. This is a diagnostic case in which the blast are 34 positive, 117 positive, 13 33 positive, 19 dim heterogeneous positive, CD7 is also positive, CD38 positive, negative for CD3 and cytoplasmic CD3, CD56 positive, and CD1333 positive. These are HLA-DR positive and 11B negative. So these are very bright CD34 positive cells. So if you want to see the LAIPs, so in this case, the CD34 bright positivity is an LAIP. Along with that, 19 positivity in AML is also we can take as important LAIP. Then CD56 positivity is also an LAIP in this case. And CD7 positivity, dim positivity, we can also take it in LAIP. CD14 is negative in this case. 6414, the monocytic marker, 36, 6414 are negative. This is at the time of diagnosis. We gated the cell similarly. After time plot, we gated the singlet, then the viable cells, then the mononuclear cells in CD38 plot. Then we can see the CD34 gate. There are two population of cells. One population is moderate positive, and another population is very bright CD34 positive, which are slightly negative for the CD45. The normal blast, the normal blue blast are CD34 positive, which are 34 positive. And these are moderate positive for CD45, whereas the brighter CD34 positive cells are negative for CD45. These both of these population are similarly positive for CD117 and CD33, and 11B also negative. The blue blast, we can see these are negative for CD19, whereas the red color residual cells are positive or heterogeneously positive for CD19, as you can see in the diagnostic case. And this 56 positivity also same in the diagnosis, which is positive in the in this MRD level also. And the other markers are similar. For DR is slightly brighter than the normal myeloblast, blue color myeloblast. So in this case, the important LAIPs are CD434 bright positivity along with 45 negativity, CD19 heterogeneous positivity, and CD56 positivity, and HLA-DR bright positivity. So these are the LAIPs we can extract from this case to stamp it as a MRD positive case. Lastly, coming to the risk stratification of the acute myeloid leukemia, these are the recent risk stratification: favorable, intermediate, and adverse. The 821 is in the favorable group, along with inversion 16, mutated NPM1 without FLT3 ITD, and BG in the frame mutation SETPA. In the intermediate group include mutated NPM1 with FLT3 ITD, wild type NPM1 with FLT3 ITD, and 911 cytogenetic abnormality not classified as favorable or adverse group. In the adverse group, we include cytogenetic abnormality like translocation 69, MLL translocation 922 BCR-ABL1, inversion 3, translocation TQ26.2, MECOM rearrangement, deletion 5, deletion 7, 17, abnormal 17p, complex karyotype or monosomal karyotype, mutated ASXL1 before EZH2, RUNX1, SF3BA, SRFS2, STAT2, U2F1, ZRSR2, and mutated T53. These are the important risk stratification group. To conclude my talk, in AML, the diagnosis of AML, the most important investigation is peripheral smear and bone marrow examination, in which if in any of the peripheral blood or bone marrow, the blast percentage is more than 10%. We further evaluate this case with cytogenetic or molecular study. We cannot stamp it as the myelodysplastic syndrome with 10%, because with 10% blast count with recurrent cytogenetic abnormality, this may be categorized in the group of AML with recurring cytogenetic abnormality. We have to evaluate the cytogenetic and molecular study in these cases. If it is more than 20%, we have to further classify into lineage of the acute myeloid leukemia. In all cases, we have to do peripheral smear bone marrow examination. In cases with bone marrow acetate dry tape, we can use bone marrow biopsy for lineage detection. Bone marrow biopsy with ISC can also help in those cases. Because in dry tap, we cannot do the flow on bone marrow aspirate, but we can try on the flow cytometric thing. The flow cytometry is the most important key diagnostic test in acute myeloid leukemia, which can help in diagnosis the lineage like myelomonocytic or monocytic, monoblastic, or megakaryoblastic or erythroblastic lineage or basophilic lineage. Along with that, it can help in prognostication of the cases. Along with that, it can indicate certain cytogenetic abnormality, and in the follow-up also it can help in minimal residual disease evaluation. So global cytometry is the must in acute myeloid leukemia diagnosis. Then next is cytogenetic evaluation. And cytogenetic evaluation is very important to re-stratify the acute myeloid leukemia. To classify it into normal cytogenetic abnormality, if it is normal, then it comes into the intermediate group. If it is any abnormality, according to the abnormality, like if it is 821 or in person 16, then it can into the favorable, and if it is complex or any other related to the adverse group cytogenetic abnormality, it can into the adverse group. So cytogenetic study is also a must in the diagnosis of acute myeloid leukemia. Along with that, molecular studies, at least for NPM1 and FLT3 ITD, are very important at the time of diagnosis to re-stratify this acute myeloid leukemia cases. So, thank you.
It's in the PowerPoint presentation mode. Okay, so good morning, everyone. I thank the organizing team for inviting me for this talk on myeloproliferative neoplasms. Now, myeloproliferative neoplasms were first described as myeloproliferative disorders in 1951 by William Dambek, and they grouped together these conditions which resulted in production of more cells, one or more type of blood cells which are derived from the myeloid lineages. Although they did not know the pathogenetic common link between these disorders, but they still could make out based on the bone marrow and the blood findings that they are somehow related to each other. So what are the common features in the classical myeloproliferative neoplasms, that is the chronic myeloid leukemia, essential thrombocytosis, polycythemia, and primary myelofibrosis? Most of these disorders are usually seen in adults, although subtype may be seen in children also, with a peak incidence in the 4th to 6th decade. Although in Indian patients, the prevalence is more decade younger if we see the prevalence age-wise. Now, splenomegaly and sometimes hepatomegaly is common in most of these patients, especially for CML and polycythemia and myelofibrosis patients. They present with the spleen enlargement because of the extramedullary hematopoiesis as well as the splenic sequestration of the abnormal cells in these organs. Now, bone marrow is very hypercellular, involving one or more lineages. And because this hypercellularity is leading to effective proliferation of cells, most of these cells will come out in the peripheral blood. So we will find increased blood counts in myeloproliferative neoplasm. This is opposite to the myelodysplastic syndrome, where the bone marrow may be cellular, but it is ineffective proliferation. So the blood counts are reduced in peripheral blood. In myeloproliferative neoplasm, the counts will be increased. And in addition to the increased count, we may also find increase in basophils and eosinophils. If we see the pathogenesis, all of these conditions will have mutated constitutively activated tyrosine kinases in majority of the cases, although some cases are negative for all the known tyrosine kinases. Most of these conditions, MPNs, present as chronic phase disease, and with time they progress to myelofibrosis, or some of these patients may convert into blast phase, that is acute leukemia with more than 20% blast. So this is the common theme for all myeloproliferative neoplasm, that there is effective proliferation in the bone marrow with hypercellularity, leading to increased counts in the peripheral blood. So this is the WHO classification of myeloproliferative neoplasm in 2022. These are the 4 classic myeloproliferative neoplasms, which was there in the earlier classification also. Then some uncommon ones, the chronic neutrophilic leukemia, chronic eosinophilic leukemia stays the same. The main change in the current classification is addition of juvenile myelomonocytic leukemia. Juvenile myelomonocytic leukemia earlier was in the MP and MDS overlap group, But just to emphasize the proliferative nature of this disease, now it has been included as an MPN, and this is mainly seen in children. And then we have MPN, not otherwise specified. In the older classification, JMML was not there. In the place of JMML, it was mastocytosis, which was there in the old classification. Now mastocytosis is an independent entity, so it is not there in the current WHO classification. So next 45 minutes, I'll try to give you an overview of these conditions which are included in the latest classification of MPNs. Starting with the chronic myeloid leukemia. CML is the commonest adult leukemia in India, constituting 30 to 60% of adult leukemias. This is in contrast to Western world where chronic lymphocytic leukemia, CLL, is the most common adult leukemia. CML is the commonest one in our country with slight male predominance. Exact etiology is not known, but there is more incidence after radiation exposure, like in atomic bomb survivors, it has been seen with higher prevalence. The origin is pluripotent bone marrow stem cell. So we find that in all the myeloid cell lineages, megakaryocyte, myeloid, and erythroid cells, we can find the characteristic translocation, that is translocation 922, which results in a BCR-ABL fusion gene. And there is a Philadelphia chromosome which gets formed on chromosome 22. So this was first detected in Philadelphia city by Novell and Hungerford. So the name came Philadelphia from there. And then Janet Rowley showed that this Philadelphia chromosome gets formed because of the translocation between chromosome 9 and 22. So that was in 70s, it was known. Now, in the clinical presentation, most of the CML patients will come in chronic phase with gradual onset, symptoms of fatigue, night sweats, fullness of abdomen after meals because of the splenomegaly. And many cases may just be detected because of incidental detection of hyperleukocytosis. And then patients progress from chronic phase to accelerated phase. Around 10% every year will progress, and then 1% of them may progress to blast phase every year. But this was when tyrosine kinase inhibitors like imatinib or dasatinib were not available. In the pre-TKI era, it was a triphasic course. But now with TKI therapy being available and careful disease monitoring using the real-time PCR, now the progression to advanced disease has decreased, with most of the patient living like normal chronic disease. So 80 to 90% patients have a 10-year overall survival. And many patients have now been tried to stop the tyrosine kinase inhibitors also after sustained deep molecular response. So what is the change in the latest WHO classification? That accelerated phase is removed now, because now this is not a triphasic disease anymore because of the tyrosine kinase inhibitor. So there is no relevance of accelerated phase. The more relevant features are the development of resistance to the tyrosine kinase inhibitor due to ABL kinase mutation, or additional cytogenetic abnormalities like second Philadelphia chromosome or trisomy 8 or trisomy 19, or development of blast phase. And the criteria for blast phase are also redefined in the latest classification. So we diagnose blast phase if there are more than 20% myeloid blast in blood or bone marrow, if there is an extramedullary proliferation of blast, that is the chloromas, or presence of increased lymphoblast in the peripheral blood or bone marrow. Now, we don't know exact percentage of lymphoblast which defines the blast phase, but increased lymphoblast itself is indicative of an imminent blast crisis. Now, generally, we don't use flow cytometry in myeloproliferative neoplasms, but this is one indication in CML to use flow and check if the blasts are of lymphoid lineage, then it will indicate a blast crisis. So when we look at the peripheral blood, we find there is a hyperleukocytosis, increased TLC, and there is a left shift of WBCs. As we see here, a lot of myelocytes, metamyelocytes are there along with the mature neutrophil. So there is a myelocyte bulge. So a lot of myelocytes are there along with few blasts. In chronic phase, it will be like less than 5% blast can be there. In addition, we can see the eosinophils, and there is increased basophils also. So basophilia, eosinophilia, left shift, hyperleukocytosis, these are the common features in peripheral blood CML patient. So in blood, we have leukocytosis with myeloid bulge and basophilia. If we look at the bone marrow, we will find there is a hypercellular bone marrow. There is loss of fat spaces. It is full of cells. The ME ratio may be 10 to 50:1. So it is mainly the myeloid proliferation. So ME ratio is very high. The normal ME ratio is 2 to 3:1. Then we have the small megakaryocytes. Dwarf megakaryocytes are increased in the CML, as we see here on the aspirate. Less than 5% blast in chronic phase. Now, because of the very high cell turnover in the bone marrow, the histiocyte ingest a lot of dying cells, and so these membranes give rise, in the histiocyte, give rise to a pseudo-Gaucher type of appearance, this bluish cytoplasm with the crumpled appearance. These are not the true Gaucher, but pseudo-Gaucher cells in CML. And there is a variable degree of bone marrow fibrosis in CML. Now, coming to the molecular pathogenesis, unlike the other MPNs which have overlapping driver mutations, which we will see, CML is unique, that it has a unique genetic characteristic, reciprocal translocation between chromosome 9 and 22, leading to fusion of BCR-ABL on chromosome 22 and development of a Philadelphia chromosome on 22. So this has a tyrosine kinase activity, and that leads to uncontrolled proliferation of cell, because this BCR-ABL fusion with tyrosine kinase activity activates the RAS, JAK-STAT, and AKT pathways. And this can be targeted with tyrosine kinase inhibitors like imatinib, which binds to the ATP binding site in BCR-ABL. So how to do the genetic diagnosis of CML? We can do either a conventional cytogenetics, that is karyotyping, FISH, or RT-PCR. So on cytogenetics, we find there is a reciprocal translocation between chromosome 9 and 22. So this 22 has become even smaller after the reciprocal translocation. This is the Philadelphia chromosome. 9 has become longer after the reciprocal translocation. So cytogenetics, the advantage is that if there is additional cytogenetic abnormality, that can also be detected. Like there is a second Philadelphia chromosome or trisomy of 8, trisomy of 19, which are the major root abnormalities indicating the progression of disease. So that can be seen in this photomicrograph when we do the cytogenetics. But the limitation is it is a labor-intensive process, and we need dividing cells. So unless we have dividing cells, we cannot spread out the chromosomes, arrange them in decreasing order of their length, and check. So then if we don't have dividing cells, especially, then we can do interface FISH. So this is the scheme of doing interface FISH using the probes for BCR and ABL. So here the green color indicates the probe for BCR and the red color indicates the probe for ABL. So a normal cell will show two BCR foci and two ABL foci. If there is a reciprocal translocation between BCR and ABL, there will be generation of this fusion signal, because we have used dual color, dual fusion probes. So there will be two yellow signals. Like in this cell, there are two yellow signals indicating BCR-ABL fusion and one normal BCR and ABL signals. So the resolution is much better here. Sensitivity is more than the conventional cytogenetics. We can do in non-dividing cells, but the limitation is you will be able to detect only the thing which is targeted by the probe. The additional findings, if they develop during the course of disease, they will be missed, other than this BCR-ABL fusion. The third technique, which is very commonly used, is to use RT-PCR. And for that, we should know that there are different breakpoints in BCR breakpoint cluster region gene. And that is how we should include the primers, which include all the common breakpoints. Like the most common breakpoint in BCR is the major BCR region between exon 12 to 16. And the fusion of this breakpoint and ABL gene leads to the protein of 210 kilodalton molecular weight. This is the most common in CML with B2A2 and B3A2 transcripts. But if the breakpoint occurs in the minor BCR region, then the protein formed is slightly smaller, 190 kilodalton, and these cases may have slightly more monocytosis. Then the third breakpoint region is the micro BCR region, from where if there is a breakpoint, then the protein is 230 kilodalton, and these cases may have more neutrophilia. So even in the 210 kilodalton, depending on the transcript, the prognosis is slightly different, and we can follow the same transcript as we find at diagnosis. So this is how we can do the qualitative PCR, the RT-PCR for detection of the 210, 190 or 230 kilodalton protein. And for follow-up of therapy and minimal residual disease detection, we use quantitative PCR, that is a real-time quantitative PCR after the diagnosis is done and patient is started on TKIs. So after the therapy started, we can look for hematological response by looking at the platelet count, WBC count, absence of any immature myeloid cell, basophil should be less than 5%, and there should not be any palpable spleen. The cytogenetic response is also followed, and the complete cytogenetic response will mean that there is no Philadelphia positive cells on cytogenetics or FISH. But the most commonly done test is to look for the molecular response to therapy in CML. That is to look for the ratio of BCR-ABL transcripts to ABL transcripts, or we can use another internationally accepted control like GUS-B, GAPDH, beta-actin, and then show this ratio that how much is the reduction from the baseline. Like less than 0.01% means that there is a reduction, 4 log reduction from the baseline, that is MR molecular response 4. 4.5 log reduction will mean the transcript level is now less than 0.0032%, and less than 0.001% will mean that there is a 5 log reduction from the baseline. So these are counted as the deep molecular responses. And as I said, the clinical trials are ongoing to check if the patient with prolonged deep molecular responses, we can stop imatinib and the patient can live even without any therapy. So that was about CML diagnosis, especially the genetic diagnosis. But after CML, the other 3 classic myeloproliferative disorders, Ph negative MPNs, polycythemia, essential thrombocythemia, and primary myelofibrosis, have overlapping driver mutations. So distinction between these entities is difficult clinically also, molecular genetic profile wise also, and based on the blood and bone marrow finding also. So alone, any one parameter cannot give us the diagnosis. So we have to combine the peripheral blood findings with molecular data along with bone marrow morphology and clinical features also to reach to a correct diagnosis in Ph negative MPNs. So as I said, the molecular drivers in Ph negative MPNs are quite overlapping. Like JAK2 V617F is seen in majority of cases, 95% cases of polycythemia vera, and other cases may show JAK2 exon 12 mutation, but this is not the driver mutation specific to polycythemia. It is also seen in 50 to 60% cases of essential thrombocytosis, as well as 50 to 60% cases of primary myelofibrosis. Similarly, in essential thrombocytosis, we can find 30% cases showing calreticulin mutation, and that is common in primary myelofibrosis also. Similarly, the myeloproliferative leukemia mutation may be seen in some cases of ET as well as primary myelofibrosis. So there is quite an overlap between these driver mutations, and 10% cases may not show any of these 3 known driver mutations. They are known as triple negative cases. So now the question comes, how can the same driver mutation lead to different disorders? The exact mechanism is unclear, but the possible theories are that it may depend on the allele burden of the mutation in a particular case. For example, in polycythemia vera, the JAK2 allele burden is much higher in as compared to cases with essential thrombocytosis. Then what stage of stem cell the mutation is happening, that will also decide the clinical phenotype. What are the epigenetic changes which are happening, like the TET2 mutation, DNMT3A mutation? What are the microRNAs involved? What is the genetic background of the host? Like how many mutations are already existing before these driver mutation happened? And just the pre-driver mutation molecular event, that just before the acquisition of driver mutation, what is the myeloid gene changes? For example, if there is a TET2 mutation before JAK2, the chances of essential thrombocytosis phenotype is more as compared to if JAK2 mutation happens first, followed by TET2, then polycythemia vera chances are more likely in clinical phenotype. So these are the factors which may be affecting the phenotype. So coming to the most important Philadelphia negative MPN, that is the polycythemia vera. This is characterized by increased red cell mass in the peripheral blood. We have mainly high hemoglobin. Other counts may or may not increase, along with panmyelosis in the bone marrow. That is a trilineage hyperplasia. So all the cell lines, including the granulocytic series, myeloid, megakaryocytes, and erythroid series, they all show hyperplasia. The presenting phase is the polycythemic phase, but after some time, the patient may go into the spent phase, that is the post-polycythemia myelofibrosis. And 5 to 15% patients may also develop AML or MDS. And as we know, the driver mutation mainly is the JAK2 point mutation V617F in majority of the patient, and remaining patient will also show exon 12 mutation. But we can have patients where we cannot detect any of these 2 mutations. Even then we can diagnose polycythemia vera. So coming to JAK2, it is a common driver mutation in the myeloproliferative neoplasm. This name Janus kinase comes from the Roman god of gates, and it has a active kinase domain as well as inactive pseudokinase domain. So there is an active kinase and pseudokinase domain. In V617F, there is a point mutation in this pseudokinase domain. This is a guanine to thymine replacement, resulting in a valine to phenylalanine amino acid replacement at codon 617F in this JH2 pseudokinase domain. So what happens is, normally this is a receptor on binding of the cytokine. There is a phosphorylation of JAK2. There is a phosphorylation of STAT, JAK-STAT pathway. There is a dimerization of STAT, which goes to the nucleus, and there is a transcriptional response, and it is under some control. But when there is a mutation of JAK2, there is a constitutively activated JAK2 receptor, even without ligand. There will be a phosphorylation of STAT, and there will be an automatic transcriptional response even without any ligand. And what happens is that the activated JAK2 interacts with the intracellular regions of several cell surface cytokine receptor, like the erythropoietin receptor, also thrombopoietin receptor, also GM-CSF. So that is why JAK2 mutations can lead to proliferation of all the cell lines, including the RBCs, WBCs, as well as platelets. Now, coming to the clinical features, again, the age group is 5th to 6th decade. Most patients will have splenomegaly, and some patients may have hepatomegaly also. The clinical findings will be because of very high red cell mass, which is leading to increased blood viscosity. So the patient will have cyanosis, reddening of skin, conjunctival reddening. The CNS and visual disturbances because of the microvascular occlusion, digital ischemia. There will be blockage of the gut microvessels, also leading to bowel infarction. So thrombosis and thromboembolism are the most common causes of death in polycythemia vera. Patient may also have bleeding problems because of the platelet function defects, and the release of histamine from basophil can lead to symptoms like pruritus and peptic ulcerations. Now, it is important to rule out all the causes of relative polycythemia and other causes of absolute polycythemia whenever we see a patient with very high hemoglobin. So conditions like diarrhea, vomiting, or stress can lead to relative polycythemia with relative concentration. The absolute rest mass is not increasing, but hemoglobin may increase. In the absolute polycythemia also, it may be primary like polycythemia vera or erythropoietin receptor mutation, or it may be secondary, which is very common because of hypoxic conditions like lung disease, high altitude cyanotic heart disease, which will lead to low saturation of oxygen, leading to secondary polycythemia. Or it may be paraneoplastic syndrome with release of erythropoietin by renal cell carcinoma, hepatocellular carcinoma, or cerebellar hemangioblastoma. So it is important to rule out these secondary causes and relative polycythemia causes before we reach a diagnosis of polycythemia vera, especially if we don't have clonal markers like JAK2. So on peripheral blood examination, we see there is a crowding of red cells, which are usually normocytic, normochromic. The criteria to diagnose polycythemia nowadays is more than 16.5 gram% hemoglobin in males and more than 16 in females. The WBC and platelet count may or may not increase in certain cases. Saturation is normal, so there is no hypoxia. Erythropoietin is not increased, it is normal or reduced. And basophilia, if it is present, will help in indicating that it is a myeloproliferative neoplasm. Bone marrow is hypercellular. We see it is full of cells. There is no fat space. There is a trilineage hyperplasia, which is panmyelosis with erythroid, granulocytic, and megakaryocytic proliferation. And there is a pleomorphism in the megakaryocyte, although they are mature with normal chromatin. And later on, when there is a spent phase, there may be a development of fibrosis in the polycythemia vera patients. These are the WHO criteria, which were 2016 criteria. There were 3 major and 1 minor criteria. The hemoglobin criteria, the bone marrow findings suggestive of panmyelosis, and JAK2 mutations. The minor criteria is the subnormal erythropoietin level. So for diagnosis, we need all 3 major criteria or first 2 major and the minor criteria. Means even if we cannot do JAK2 mutations in our setup or JAK2 mutations are absent, still if we have high hemoglobin, bone marrow findings which are suggestive, and reduced EPO level, one can diagnose polycythemia vera. Can we do diagnosis without doing bone marrow biopsy also? Yes, we can diagnose polycythemia if we have sustained hemoglobin of more than 18.5 in males and more than 16.5 in females if we have JAK2 mutation positivity and low serum erythropoietin. So that means we can skip bone marrow biopsy if we have the other three features, and we can skip JAK2 mutation if we have the other three features, hemoglobin, biopsy, and the erythropoietin. And so JAK2 is not specific to polycythemia, and we can diagnose polycythemia even in the absence of JAK2 mutations. Now, what is the change in the latest WHO classification? That in addition to the hemoglobin and hematocrit, the red cell mass was also a criteria to diagnose polycythemia. That criteria has now been removed because red cell mass estimation is not a very commonly done investigation now. So it is either demonstration of high hemoglobin or hematocrit along with the biopsy findings, JAK2 mutation, and reduced erythropoietin level in the same combination as previously. So that was about polycythemia. Now coming to the second pH negative MPN, that is essential thrombocythemia. Here the main cell line which is involved is megakaryocytes with increased platelet count. So this is characterized by more than 4.5 lakhs platelet per microliter and abnormal increase in hypermature megakaryocytes in the bone marrow. The driver mutations we have already seen, 50 to 60% patient will have JAK2 V617F mutation, 30% patient will have calreticulin, and around 3% patients have myeloproliferative leukemia receptor mutations. The age group is similar, 4 to 7 decade with equal incidence in male and female. Now, despite so many platelets, still the patients may have bleeding problems because these platelets are functionally abnormal. So there is a platelet dysfunction which leads to thrombosis as well as bleeding manifestation. Patient may or may not have splenomegaly. Around 20% cases have mild splenomegaly, essential thrombocythemia. Now, the main finding is the increased platelet, which may be present in clumps. There is platelet anisocytosis. As we see, the size of platelet is very variable. These are hypogranular platelet with platelet function defect. The other counts may be normal or mild increase. Similarly, in the bone marrow, it may be normocellular or mildly hypercellular with mainly the megakaryocytic hyperplasia. Now, unlike the CML and polycythemia, we see there is a presence of fat spaces here. So there is a preservation of fat spaces in essential thrombocythemia, which are mostly absent in polycythemia and CML. And these megakaryocytes are large, hypermature, hyperlobulated, which are known as staghorn megakaryocyte, resembling these horns. They may be present in loose clusters, or they may be scattered. The myeloid and erythroid series may be normal or mild hyperproliferation may be there. So the WHO criteria for diagnosis has 4 major and a minor criteria. That is a platelet count more than 4.5 lakh. Bone marrow biopsy should show megakaryocytic proliferation with no significant increase in granulopoiesis or erythropoiesis, and mild increase in reticulin may be there. The other myeloid neoplasm WHO criteria should be absent. There should be a driver mutation like JAK2, CALR, or MPL mutation. And if there is a clonal marker other than these minor criteria, presence of clonal marker other than these driver mutations like ASXL1, DNMT, TET2 mutation, or absence of evidence for reactive thrombocytosis. So we can diagnose ET if all 4 major criteria are present. But if we haven't got the JAK2 or any other driver mutation, then first 3 major criteria and the minor criteria. That in place of the driver mutation, we should show some other clonal marker, or that is also absent, then at least we should rule out the reactive thrombocytosis before reaching a diagnosis of ET. So what are the reactive causes of thrombocytosis which should be ruled out? Like we can have increased platelet count even with iron deficiency anemia. Because if there is a severe anemia, there is a stimulation of thrombopoietin and the platelets increase in iron deficiency also. After splenectomy, after hemorrhage, after hemolysis, in other myeloproliferative disorders also we can find increased platelet count. And as a reactive condition to infections, then some collagen vascular disease, inflammatory bowel disease can also show platelet count increase. MDS5Q deletion syndrome is also associated with thrombocytosis. And rebound, when the patient is recovering from thrombocytopenic condition, there may be a rebound thrombocytosis. So all the reactive conditions need to be ruled out, especially if we don't have the driver mutations or other clonal markers before we reach a diagnosis of ET. So JAK2 we have seen. The second most common mutation in Ph negative MPN is the Cal reticulin mutation. The details we will see in the next session on molecular diagnosis also, but this is basically an endoplasmic reticulum chaperone protein. And this mutant CALR interacts with the thrombopoietin receptor, driving the thrombopoietin independent activation. Now, there are two major types of CALR mutation which are seen in MPN. Type 1, which are the large deletion, 52 base pair deletion in exon 9, and type 2, which is 5 base pair insertion. So both of them are frame shift mutation, either large deletion or small insertion in exon 9. Now, what is the significance of these is that type 1 CALR mutation is associated with a better survival in primary myelofibrosis compared to JAK2 mutation. And there will be cases where the deletion is large, but it is not exactly 52 base pair, then it will be known as type 1 like. So both CALR type 1 and type 1 like mutations are better prognosis in PMF as compared to JAK mutation. So they have been included in the prognostic systems also. Similarly, if there is a insertion which is not exactly 5 base pair but small insertion, they will be known as type 2 like CALR mutations. And the third driver mutation is the myeloproliferative leukemia MPL, which is a thrombopoietin receptor. And there may be mutations at position 505 or 515 in essential thrombocytosis. In PMF, mainly it is the 515 L or K mutations, leading to a constitutively activated thrombopoietin receptor. And these are seen in nearly 3% cases of essential thrombocytosis and 8% cases of primary myelofibrosis. So those were the three driver mutations which are seen in three Ph negative MPNs. Coming to the primary myelofibrosis. So here in the early stages, there is a trilineage hyperplasia. It is a prefibrotic primary myelofibrosis and the fibrotic phase of myelofibrosis. These are two stages. In the early phase, we will see the hyperplasia of granulocytic, erythroid, as well as megakaryocytic series, mainly the granulocytic and megakaryocytic. And in the later stages, there will be marrow fibrosis. The driver mutations we have seen, JAK2 mutations in 50 to 60%, CALR mutations in 30%, and MPL mutations in 8% patients. Again, this is of old age, equal in males and females. Patient will have moderate to massive splenomegaly because after the development of fibrosis in marrow, there is extramedullary hematopoiesis which starts in spleen and liver. And the blood counts will fall in the later stages, leading to low hemoglobin, low platelet with fatigue and bleeding and infections. So we'll see that TLC and platelet will be high in the early stages. They may be normal or high, but as the fibrosis sets in, the TLC and platelets will fall. And there will be development of leukoerythroblastosis. Here we have nucleated RBCs in the peripheral blood. We can see these teardrop cells, the cryocytes. When there is a development of fibrosis, there is a distortion of red cells when they come out of the sinusoids. And there is a leukoerythroblastosis, immature RBCs and WBCs in peripheral blood. When we look at the bone marrow in the prefibrotic phase, there will be megakaryocytic and granulocytic proliferation. In the later stages, there will be fibrosis leading to dry tap on bone marrow aspirate. And the important finding on bone marrow biopsy is to look at the disc megakaryopoiesis. So here we have the condensed nuclei with clumped chromatin as compared to the essential thrombocytosis or polycythemia where the chromatin is normal. There is no clumped chromatin. There is no NC, and the nucleocytoplasmic abnormalities are more common in primary myelofibrosis. So there is anisocytosis, abnormal NC ratio, condensation of nuclei with clumped chromatin. Sometimes they look like cloud-like nuclei. And there is a cohesive megakaryocytic clusters. So in primary myelofibrosis, there are tight clusters of megakaryocytes which are commonly seen. And once they release the fibrogenic cytokines, there is a fibrosis with dilatation of sinusoids and osteosclerosis in the bone marrow. So the megakaryocytic morphology is very important to differentiate PMF from other myeloproliferative neoplasms. And that is emphasized in the WHO criteria also for diagnosis. Like the major criteria are based on the megakaryocytic proliferation and atypia. So in the prefibrotic stage, there should be reticulin fibrosis not more than grade 1, along with increased cellularity with granulocytic proliferation, often decreased erythropoiesis. The WHO criteria for other myeloid neoplasm should be absent. The third major criteria is the presence of JAK2, CALR, or MPL mutation. Or in absence of these mutation, we should have other clonal markers. If that is not there, then absence of minor reactive bone marrow reticulin fibrosis. So either driver mutation or other myeloid gene mutation or absence of reactive causes of fibrosis. The minor criteria include anemia, leukocytosis, palpable spleen, and increased LDH. So the diagnosis of prefibrotic PMF requires all three major criteria and at least one minor criteria out of these four. And these are the criteria for overt fibrotic stage given in 2016, but the latest classification also has similar criteria. That is, there is no change. The major criteria are the megakaryocytic proliferation ATP accompanied by reticulin and or collagen fibrosis grade 2 or 3. Now, if the grade of fibrosis is 2 or 3, it becomes overt fibrosis. If less than 1, then it is prefibrotic. The other criteria for myeloid neoplasm absent, the presence of driver mutations or other myeloid gene mutations or absence of reactive myelofibrosis, any one of these should be there. And in the minor criteria, there is an additional criteria of leukoerythroblastosis. So again, we should have all three major criteria and at least one minor criteria. This is how the myelofibrosis grading can be done. 0, 1, 2, 3 based on the reticulin or collagen stain. So in the grade 0, we don't have any intersections of the reticulin. There are intersections, especially in the perivascular area in the grade 1. Then there will be dense increase in reticulin with extensive intersections in myelofibrosis grade 2. And there will be dense coarse bundles of these thick fibers, which can be seen on the collagen staining also along with the reticulin. That is grade 3 fibrosis. So based on the grade of reticulin staining, we can grade into prefibrotic or overt fibrotic stages of primary myelofibrosis. Now, in addition to the driver gene mutations in myeloproliferative neoplasm, we also have these additional myeloid gene mutations, which we saw on the diagnostic criteria also. These includes the additional sex-chrome like 1, enhancer of ZES2, the chromatin modifier, mutations in the DNA methylation gene like the 1011 translocation 2, DNA methyltransferase 3A, isocitrate dehydrogenase 1 and 2. Then we have spliceosome complex gene like the splicing factor, which are serine arginine rich, U2 small nuclear RNA auxiliary factor 1, and splicing factor 3B subunit 1. Tumor suppressor gene TP53 mutation and transcriptional regulator RUNS1 mutation. So these mutations may present in variable proportion in MPN patients, and that also affects the outcome in the various MPN patients. For example, here we see the JAK2 mutation is seen in more than 95% patients of polycythemia vera. CALR mutation is the second most common driver mutation. The color of the bar indicates the type of mutation. So JAK2 is a point mutation, whereas the CALR mutations are the frame shift mutations. Then we have TET2, AXL1, and DNMT being the other common mutation. All these are less than 5% in the prevalence in MPN. And in myelofibrosis especially, there are certain gene mutations which are associated as an independent marker of survival and fibrosis. For example, these AXL1, SRSF2, EZH2, they have been shown in different cohorts to have an independent marker of survival in myelofibrosis patients. And so these are certain mutations which are associated with more leukemia risk, like the TET2 DNMT, and they are also associated with fibrotic risk. And overall independent survival is indicated by presence of AXL1, SRS2, EZH2 in some of the cohorts. In one cohort, IDH2 is also an independent marker of survival. So that is why all these myeloid gene mutations are now being included, the information on the driver genes as well as the myeloid gene mutations are included in the various prognostic systems like the Dynamic International Prognostic Scoring System, Molecular IPSS, Genetic IPSS, and Molecular IPSS version 2. So we see, just to have an overview, that there are different prognostic systems, especially in myelofibrosis, and these prognostic system include the information from karyotype as well as the mutation profile, like CALR type 1 mutation is present or not, high molecular risk mutations are present or they are absent, presence of ASL1, SRF2 in the genetically inspired mutation, then the myelofibrosis transplant scoring system also takes into account these mutations, and secondary myelofibrosis. So there are different prognostic systems which takes into account all these myeloid gene mutations also. Now, some points about the uncommon myeloproliferative neoplasm. The chronic neutrophilic leukemia is characterized by sustained peripheral blood neutrophilia with WBC count more than 25,000, with more than 80% segmented neutrophils and bands. There are less than 10% immature cells, unlike the CML. The bone marrow is hypercellular due to neutrophilic proliferation, and there may be hepatosplenomegaly. And the most important genetic feature in these patients, more than 60% cases will show CSF3R mutations. So these are the WHO criteria based on the peripheral blood increase in 80% neutrophils with more than 25,000 counts, hypercellular marrow. The WHO criteria for other myeloid neoplasm should be absent. There should be absence of PDGFRA, PDGFRB, etc. And the main finding is the presence of CSF3RT618I or other activating CSF3R mutation. Then another uncommon myeloproliferative neoplasm is chronic eosinophilic leukemia, which is a multisystem disorder characterized by sustained clonal proliferation of morphologically abnormal eosinophils and precursors with persistent hypereosinophilia in blood and bone marrow. So now the eosinophil will show some vacuolation or some degranulation. They should be present at more than 1500 per microliter level. The WHO criteria for other MPN should be absent, and the rearrangements which are commonly associated with eosinophilia should also be absent. So these are the WHO criteria, more than 1500 eosinophils in absence of other mutations and other features of acute myeloid leukemia. And there should be a clonal cytogenetic or molecular genetic abnormality which should be able to demonstrate, or the blast cells more than 2% in peripheral blood, more than 5% in bone marrow. This was in 2016. But in the latest WHO classification 22, what is changed is that the time interval required to define sustained hypereosinophilia has been reduced from 6 months to 4 weeks. So now any patient having more than 1500 eosinophil for 4 weeks or more, we can say there is a sustained hypereosinophilia. And now we need both clonality as well as abnormal bone marrow morphology. Like we need to show megakaryocytic or erythroid dysplasia along with the abnormal eosinophil. And the criteria where the clonality could be altered with the increased blast in peripheral blood or bone marrow, that alternative has been removed. So in the 2016, we see that there is a clonal molecular abnormality, or we can demonstrate the blast cells. This criteria is removed now. So we have to demonstrate both clonality and abnormal bone marrow morphology. So this way, we can improve the distinction between chronic eosinophilic leukemia and other conditions with eosinophilia like idiopathic hypereosinophilic syndrome and hypereosinophilia of known significance. Now, the addition in the current classification is juvenile myelomonocytic leukemia, which is usually seen in children less than 4 years. This is also a stem cell derived MPN of childhood with activation of RAS pathway in more than 90% cases. And again, for JMML also, we need to combine clinical lab and molecular criteria. So the clinical and hematological criteria include persistent monocytosis more than 1000 per microliter, less than 20% blast, splenomegaly, and absence of Philadelphia chromosome. The genetic criteria are important. We need to show the somatic mutation in PTPN or RAS pathway, or there should be a clinical diagnosis of neurofibromatosis type 1 or NF1 mutation should be there, or germline CBL mutation should be present. If the genetic criteria are not there, then we should have some chromosomal abnormality like monosomy 7, or increased hemoglobin F for age, myeloid or erythroid precursors, that is immature cells on PS, GCSF hypersensitivity, and hyperphosphorylation of STAT5. So this is again 2016 criteria. Now there is some change in the latest 2022 criteria. So what are the updates? That there is an exclusion of KMT2 rearrangements in diagnosis of JMML. Monosomy 7 has been eliminated as a cytogenetic criteria. And there is an emphasis on significance of diagnostic molecular studies, particularly those aimed at demonstrating RAS pathway activation, because more than 90% patients will show RAS pathway involvement. And in the end, if we have features of MPN in a patient, but we cannot classify into one of these well-defined conditions, then we can, or there is an overlap between two or more different MPNs, then we will say this is MPN, not otherwise specified. So these cases will fall into one of these three groups. Either there will be very early phase of polycythemia or primary myelofibrosis, that is a prefibrotic, in which the characteristic features of MPN are not yet developed. Second group will be where the features are so advanced that the development of fibrosis or osteosclerosis or increased blast or myelodysplastic changes has taken over. So now we cannot find the baseline findings of MPN. Or the third group can be where there is a coexisting neoplastic or inflammatory disorder, due to which we cannot see the usual diagnostic features of MPN. So when we strongly feel that there is a MPN case with organomegaly, high cell counts, but we cannot pinpoint any one category, especially in the absence of driver mutation, then it will fall in MPN NOS. So these are the criteria. Features of MPN should be present with high counts. WHO criteria of well-defined MPN and other myeloid neoplasms are absent. There should be some driver mutation like JAK2, CALR, or MPL, or if they are not there, then some clonal marker is there indicating MPN, or we have ruled out all the cases, causes of reactive conditions, reactive fibrosis. Then we can say it is MPN NOS. So to summarize, MPNs have many overlapping clinical lab and molecular features. The driver mutations are detectable in majority of MPN cases with a lot of overlap, but still 10% cases don't have known driver mutations. And we saw that additional myeloid gene mutations affect outcomes and are useful in establishing clonality and in various prognostic scoring systems. Thank you so much for your patient listening. Happy to answer any questions.
Yes.
Afternoon to all, to the organizers. And today I will be sharing with you my experience on molecular diagnostics in hematological malignancies at our lab oncology unit in Thames. So the objectives of today's talk would be applications of molecular technologies in diagnosis, prognosis, disease monitoring, and therapeutic decision making. How, I think my slide is not moving forward from my...
Not moving.
Not moving, right? Just a second. Just I should. Sorry about that glitch. So, just an overview. Since morning, we have been listening to the various malignancies involved with the bone marrow. They're primarily divided into the myeloid and the lymphoid lineage. And as these cells differentiate, they acquire various mutations. And as we are seeing that the classification of hematological malignancies is moving and transforming towards more of molecular entities, as we will see along this in the next few minutes. So just to give an overview, the two major broad groups are the myeloid lineage, which give rise to MDS, which has recently been retermed as the myelodysplastic neoplasms instead of syndrome in the 5th WHO edition. Then we have the myeloproliferative neoplasms, MDN, MPNs, AMLs. Actually, this has 9 sub-entities, which I haven't really listed for simplicity, but the WHO reference has all the details of it. And in the lymphoid lineage, we have the precursor acute lymphoblastic leukemias, and we have the mature cell lymphomas and proliferative disorders. Now, so as the talk is about molecular diagnostics, we see within the myeloid, now each entity has been further acquired sub-entities. So the main, based on the BCR-ABL fusion, chronic myeloid leukemia, the others which lack this fusion translocation carry unique mutations as listed here, and these are some of the examples. Similarly, for AML, BLL, and CLPDs, as I will show you in the next few slides, how so many molecular entities have been incorporated and have formed the basis of classification of these neoplasms and malignancies. So Dr. Smitha has very well described the WHO classification of AML and related neoplasms. Newer entities have been added and some have been removed, like RUNX1 was a provisional entity which has been removed. BCR-ABL was a provisional entity but now has been incorporated based on greater than 20% blast with BCR-ABL detection. And similarly, others, for SEPA, this is also a very important subcategory, although detected in 5 to 8% of AML, where the biallelic is implicates favorable category. Then the other, the major change has been seen in AML with MDS related, where either gene mutations have formed the, so there are like 33 mutations, as we will see in the prognostic scoring later, and also cytogenetic abnormalities, which then categorize them into MDS AML or MDN AML. And then there are the AML NOS, which Dr. Smitha covered very well. And then also some other qualifiers are therapy-related myeloid neoplasms, and germline predisposition has also been incorporated. So why do we need these classifications? Because several of these alterations have been correlated with their outcomes. So, for example, again, I won't go through the detail, but Dr. Smith has already touched upon, in case of AML, how certain fusions, especially the core binding ones, make it a favorable risk. SEPA, biallelic SEPA, mutated NPM without FLT3. And we will see a major change of how FLT3 has been shuffled from like in a favorable based on certain values which have been removed from the newer classification. So then the importance of knowing and having a confirmatory test of these recurrent abnormalities also helps in prognostication. So this is for CMML, several mutations and different signaling and methylation, tumor suppressors, so different categories have been, functional categories have been defined for CMML. Then ALL again has a subcategory where further based on genetic recurrent abnormalities are defined entities have been, which are associated with, again, favorable, intermediate, adverse, other molecular genetic alterations in BLL, and how we will detect them is the goal of this presentation. So, and CLL, again, so we have these unique mutations, but the thing is that even if certain, they're definitive for certain subcategories, they're also detected in other entities. So one has to correlate with clinical findings. Now, coming to the various types of tools that we have today for diagnostic purpose in hematological malignancies. So any suspected case, bone marrow malignancy, morphology, immunophenotyping, raises a suspicion, and that is then further tested based on using certain molecular techniques. So the chromosomal abnormalities, gene rearrangements, what are the tools that are used are karyotyping. You have the fluorescent in situ hybridization, RACGH, RT-PCR, real-time PCR, droplet digital PCR, and next-generation sequencing. And for single nucleotide variants, insertion deletions, copy number variations, we have the polymerase chain reaction, fragment analysis, Sanger sequencing, MLPA, digital MLPA, real-time PCR, and next-generation sequencing. So I will touch upon, by solving cases, how we approach using molecular. So the first entity that I would start with is the classic chronic myeloid leukemia, which is linked to a single genetic abnormality in the BCR-ABL fusion, which is created between chromosome, the BCR. So the ABL on chromosome 9, an exon of part of it has a breakpoint, which then translocates and fuses to BCR, creating a Philadelphia chromosome. And this encodes a fusion protein with tyrosine kinase activity, for which inhibitors are available and several generation of inhibitors have been developed because of a resistance that has been generated. So what are the main tests which will help us identify this BCR-ABL and also the resistance that is causes? In the next few slides, we will review that. So these are the types of BCR-ABL fusion transcripts. So on chromosome 22 is the BCR gene, chromosome 9 is the ABL gene. So the breakpoints on BCR gene are in this region, the exon 2, and ABL is exon. So these are the different fusions. If you see at the bottom, E1, A2 refers to the exon 1 of BCR fuses with A2 is the ABL exon 2. So the breakpoint is in between exon 1 and exon 2 of BCR gene, and ABL 1 and for ABL exon 1. And this goes and fuses to the BCR ABL, creates a BCR ABL fusion, which is a novel aberrant transcript. And depending on where this breakpoint is and where the fusion occurs, you see these four major, the major isoforms that are detected are the E1A2, which is the minor one. Then we have the E13A2, E14A2, and then there is a minor, the micro isoform E19A2. So in CML, 95% of cases harbor the P210, which is the major isoform, E13A2 or E14A2. But the 5% of cases which do not harbor these and are at the baseline, so the problem there is that it could be a cryptic fusion or it could be some other rarer translocation, which if missed can be false negative at later time points, because it is important to establish at baseline. So quantitative PCR is not mandatory. A qualitative reverse transcription PCR is sufficient to establish the isoform at baseline, because that helps in the monitoring for assessing response to TKIs. So this is the workflow in our lab, which we are using for quantitative versus qualitative. So I'll just review the steps quickly. So we take EDTA blood in a suspected case of CML. So this is a standard protocol of RBC lysis. The pellet is washed, RNA isolated. This RNA is then our template, which in 2 steps is converted to a product which amplifies the BCR-ABL, region of BCR-ABL fusion. So the first step is called reverse transcription, where RNA is converted to cDNA in a test tube where we mix the RNA template with oligo-DT, which is a primer, DNTP, and an enzyme, which is converts this to a complementary DNA. This complementary DNA then serves as a template for the PCR reaction, where a primer, forward and reverse primer for detection of BCR and ABL fusion are added. But here we're doing a TACMAN-based chemistry. So TACMAN PCR is where the probe has a label, a fluorescently tagged label, which I will review in the next slide. And these are single-plex tests that we do in one tube. We detect the BCR-ABL, and also it is important to have a reference gene, which is ABL, and both carry the same fluorochromes. This can be multiplexed by changing the fluorochrome on one of the probe, and it can also be performed in a single tube. But for MRD assessment, it is recommended to have a single tube assay. What you see here is the amplification condition, which is standard for TACMAN probe, primer probe assays, where the amplicon size is less than, it's from 50 to 150 base pair, and it's a 40 cycle reaction where 40 is the last cycle of the PCR amplification. So here, the elongation, annealing and elongation is merged into one step. Generally, PCRs have denaturation, annealing, extension, but here you have a denaturation step followed by elongation, annealing and elongation as a single step. So this is important because the primer designing is governed by the TM of this annealing extension. Now, so this is the amplification is carried out, and then further how we read it. So this is a brief chemistry of the TACMAN probe, how it works. So you have the forward primer on the left and the reverse primer on the right. The TACMAN probe binds or hybridizes to a region between this primer, the forward and the reverse primer. The chemistry of Tachman probe is that it carries a fluorochrome at one end, like we saw FAM, and this is a list of fluorochromes that can be used, and a quencher, but one has to make sure that the PCR machine we're using carries the detection laser, which can excite this fluorochrome. The quencher ensures that when the reaction has not started, the fluorochrome is bound and it will not fluoresce. Once the polymerization cycle initiates, then as the elongation happens, this probe is cleaved. It releases the fluorescence into the test tube, and that fluorescence is a direct indicator of the amount or concentration of the PCR product in the tube. And so this correlates with the thermal cycle. So how this is read is, so this is the threshold cycle, which correlates with the initial target concentration. What you see at the left is the amplification plot. Now, in this amplification plot, on the x-axis are the number of cycles, the y-axis is the fluorescence. So, so what you see here is that the detection happens at the exponential phase. This is real-time monitoring of amplification. So, for example, in this tube, which is one reaction indicated by the blue, is like 24 cycle, you start detecting the signal in this tube. So lower the CT value. Earlier the CT value, that means there is more abundant target present in the tube. So it's an inverse correlation. Now this can be reported just based on CT value as a qualitative test. So which indicates that if the CT value is in the detectable range, because a control is also used like a reference gene, if it is a detectable range, usually below 32, 33 CT value, we can report it as positive, negative, qualitatively. To convert this into a quantitative assay, we need standards. So we run parallel standards, and the standard curve is created, which is shown on the right. And these values of the standard also have CT values which correspond to its concentration. So relative quantification of these unknown samples can be derived using a standard curve. So this is like a way how which and the efficiency of the assay can be tested using certain values, which are the slope and efficiency. There are values for the efficiency of the assay as well as the slope, which should be minus 3.3. That corresponds to a 10-fold change, and which indicates these are to compare between runs. These parameters are important to monitor. And then why are these values important? So once we have the quantitation of BCR-ABL and ABL in parallel, we normalize it, and then there is an international scaling, which is like a global value for each assay. It has been tested using certain standards, reference targets, to ensure that the values derived in any lab using an IS scale can be compared anywhere in the world. And this is important for monitoring. So at diagnosis, a qualitative test or a quantitative test is assumed to be 100%. With every log-fold reduction, what you see is one log-fold reduction indicates complete hematological response. Then a two-fold reduction is a complete cytogenetic response. A major molecular response, MMR3, which is 0.1% reduction. And then MR4, which is a deep molecular response, is indicated by the copies of ABL, which is your reference gene. 0.01 indicates if there are 10,000 copies in the tube, MR4, and no copy of BCR-ABL indicates MR4, whereas for 32,000 copies of ABL, no BCR-ABL indicates deep molecular response of 4.5. And further, like higher ABL and no BCR-ABL is like the deep molecular response. So this is important for whether the treatment given to the patient is optimal, or there is an indication of warning, which helps in discontinuation of the medicine or of chemo versus the or change to a different drug, which is based on these values. Now, the same test which I just walked you through, which is a real-time quantitative PCR, can also be achieved using a droplet digital PCR or digital PCR, where one can determine absolute copies of the BCR-ABL without a standard curve. That is the principle of digital PCR is briefly overviewed here. So the reaction conditions remain the same as a real-time PCR. What is additional here is that the reaction carries DNA template, which is distributed or partitioned into oil droplets. And each droplet indicates one molecule of the DNA template. Oh, sorry, here the cDNA, because we have a BCR-ABL fusion, RNA is converted to cDNA, and now the cDNA is being amplified. Now, when these droplets are subjected to PCR, each droplet will amplify one target. And the positivity versus the negativity of the droplets indicates the copies. So this is the workflow of a droplet digital PCR. The reaction mix remains the same. The additional thing that is a little more infrastructure that is added is this cartridge, which is a special cartridge for generating droplets in a special instrument, which is a droplet generator. And these droplets are then transferred to a 96 well plate and then PCR in a normal machine, a PCR machine. And then you also need a special reader for this, where these droplets are read. So what you see at the bottom is a plot where all the gray dots are the negative signals and the blue is a positive. These are droplets. The blue droplets indicate positive, and the amplitude or the intensity of these, which is then correlated with the concentrate, the copies. Now, another important assay that we also do for CML is the IRMA testing, which is imatinib resistance mutation analysis. Now, in the BCR-ABL, the ABL domain is the kinase domain, as shown in the this linear structure, where the common mutations are seen in the active pocket of the where the drug binding imatinib binds. And there are almost 90 mutations that have been reported so far. And so this becomes an important test to see if the patient is not responding based on that chart that I just discussed. So here we perform Sanger sequencing. Now, what is Sanger sequencing? Sequencing of each nucleotide in that domain, which is like one can go up to 600 to 800 nucleotides of that region can be sequenced. So it's a process of nested PCR. I won't go into that detail, but basic principle of Sanger sequencing is based on the chain termination or dideoxy sequencing. Now, dideoxy sequencing, as the name indicates, deoxynucleotides are the main building blocks of DNA. There's a synthetic analog which Sanger designed, where the elongation is blocked by replacing the hydroxyl group at the 3' end with a hydrogen. So when this dideoxy is incorporated in an elongating chain, the chain will not extend. This is a terminator. So that's the principle of Sanger sequencing, and a very simple principle, which won him the Nobel Prize too. So if you see now this has been automated. The whole process has been automated, where it's a one tube, one reaction, one tube, one gel. What does that mean now? The reaction cycle sequencing. In the reaction tube, there is, you have the target, the DNA template, DNA polymerase, a primer, which the polymerase needs to extend to sequence. And then you have DNTPs. What is additionally added to this is a big dye terminator, which is currently like a newer version of a cocktail of all the dideoxys with different fluorescent labels. All right, so in this mixture, when this is subjected to cycle sequencing, each cycle, so the ratio of the dideoxys to DNTPs is such that dideoxys are 1/10 or even less 100 in that range. It's an optimized concentration, so that when the chain extension of a template DNA is occurring, some of the fragments will terminate depending on the corresponding nucleotide. And at the end of the reaction, what one gets is a mixture of fragments differing by single nucleotides. And these fragments are then resolved on a capillary gel electrophoresis. This is a genetic fragment analyzer and sequencer. It does both. So when this sample after the PCR cycle is loaded onto the capillary, as it passes and the laser excites that fluorescence depending on the length, and then reads to its corresponding dideoxy, what was incorporated in that fragment. And the readout is this electrophotogram. What you see is a plot of DNA fragment, which we get as a readout. This electrophotogram, this is a classical example of the T315I mutation in the ABL kinase domain. And this is the most prevalent variant in the ABL domain. And then what is the implication of this finding? Now, once this resistance is established, the drug is changed from imatinib to ponatinib. Similarly, other mutations are also implicated to change the treatment. Now, the major advantages of Sanger sequencing are its high accuracy and the read length. One can read up to 700 to 800 bases. But major limitations are its sensitivity, because you need the mutation or the alteration you're trying to detect as at least to 15 to 20% of that mutant burden should be there in the sample of interest. So its sensitivity is low, but still this is considered to be gold standard when it comes to confirmation of sequence alterations. So that was CML, where we saw RT-PCR based qualitative detection, followed by IRMA testing, which is Sanger based. So another test that we also perform when BCR-ABL is negative and MPN is the JAK2 mutation. And this is the DNA-based test, single tube test, simple PCR, and resolving on an agarose gel. We have replaced this by qualitative PCR using other TACMAN probe also. But this is our functional test. So what you see is the end product. These controls are important. You have like a no template control. When you put a reaction to detect JAK2 mutation, the red one is the sample. So in addition to that sample, you also need a no template control to ensure that your PCR, there is no contamination. You need a positive control as a reference to compare if the mutation is present, a negative control to rule out any false. So this patient has a JAK2 mutation. So next I move on to the diagnostic workup in a suspected case of AML. We've already seen the CBCs and immunophenotyping details. So I will start off directly with screening for gene mutations. And based on the WHO classification, the key ones in cytogenetically normal AML, and also for gene rearrangements which are implicated, and then other gene fusions if available. So as we've seen, that newer entities are being added. So what is recommended is error-corrected targeted myeloid panels for screening all the mutations, because there are other entities that are also evolved into AML, plus for RNA sequencing for novel fusions or translocation in novel gene rearrangements are also indicated, but that requires infrastructure. So I will just review a case, which it's a 56-year-old male, presented with high fever, pallor, no other signs, and deranged CBC. Classical features of APML with a bilobe nuclei, as Dr. Smith has already covered this, and then immunophenotyping, the teardrop pattern. So all these immunophenotype morphology was indicating APML. But when the karyotyping was performed, the karyotype was normal. There was no T1517 translocation. This was normal. And this is how it looks, but in the case it was a normal karyotype. So FISH assay also using the dual color FISH probe for 1517 was also negative. So what are the possibilities? Most cases do harbor the classic PML-RARA fusion, but there could be variants also, and that can be detected using break-apart probe, and that was also negative in this case. So why this case is important here is that whenever there is a clinical or morphological suspicion for APML, after the immunophenotypic and flow cytometric analysis, it is indicated that PML-RARA FISH as well as RT-PCR is performed in karyotype. If it is positive, then the diagnostic workup for APML is followed, the treatment. But if it is negative, then there are some other rare variants which should not be ignored. And for that, FISH is implicated, like the break-apart probe. And if not, then one follows towards the AML testing algorithm. APML is important because 10 to 15% of all AML cases diagnosed in India are like APML, and it's considered a medical emergency owing to the risk of coagulability. And these are the tests which one has to perform. Now, in this case, what was eventually detected was NPM and FLT3 mutation. Allelic ratios are highlighted in red because they've lost their significance, which I will just review in a few minutes. Now, this is the workflow for fragment analysis, which we do in a multiplex assay for detection of NPM and FLT3 mutations. So if you see, it's a DNA-based test, it's a PCR-based test, and the same sequencer, which we use for IRMA, is also used as a fragment analyzer here. So capillary electrophoresis and data analysis. So this is a simple overview in a PCR mix. What is different is that the primers in this case for detection of NPM mutation and FLT3 are fluorescently tagged. Now here, NPM is tagged with WIC. The reverse primer for detecting NPM is tagged with WIC, and for FLT3, it is tagged with PAM. So once this PCR is performed, now when there are two approaches. If we resolve these amplified products on an agarose gel, we cannot distinguish the NPM mutant because the size is only 4 nucleotides, tetranucleotide insertion. Whereas on an agarose gel, you need at least to see a visually contrasting or a different, to be able to differentiate and resolve, you need at least a 20 nucleotide difference in the two fragments. So the ideal approach is using capillary electrophoresis. What you see here at the bottom, NPM, green peaks. The first one is 170 base pair, which is the wild type, and the mutant is the 170. So these are the two peaks differing by 4 nucleotides to be resolved in a fragment analyzer. And also there is a FLT3 mutation detected, the wild type and the mutant, what you see in the blue peaks. So allelic ratio was important, but I will skip this because now what has been revised is what we should, the updated, I will just share that with you. So other molecular techniques for detection of NPM mutations, apart from fragment analysis, are Sanger sequencing, also allele-specific PCR, next generation sequencing. Also targeted panels have NPM because it's a WHO entity. Then also RQ-PCR and ddPCR are more sensitive methods when and are indicated for monitoring, MRD assessment. So same for FLT3, fragment analysis. Again, the sensitivity of this is low, 80%, because it's like fragment analyzer based. So the burden or tumor burden or the mutation burden VAF has to be at least 20% in the sample, 10 to 20%. And also another thing of FLT3 is that on an agarose gel, you will miss the smaller insertions because the range of the FLT3 IDD insertions are from between 3 to 400 base pair. So just a quick overview of the hotspot mutations. NPM1 gene, most mutations are in exon 12. And the most common one in 80% cases is the isoform A, which is the TCTG duplication. But there are other variants also detected, which are insertions like the isoform D and B with a different kind of insertion, CCTG and C8TG. And less than 1% exon 12 could have other insertions, and reported are up to 50, more than 50. Now, some main features of AML with mutated NPM1. This is a phosphoprotein that is expressed in all tissues. 1/3 of all adult AML carry from frameshift mutations in NPM1 gene. Higher incidence in females associated with normal karyotype, cytogenetically normal. 15% cases carry secondary chromosome aberrations. It's mutually exclusive as it's a separate entity. It has reduced to negative CD34 expression. NPM1 is a nuclear chaperone that performs diverse functions, molecular chaperone of histones, genomic stability, ribosome biogenesis, and the mutations in it result in cytoplasmic dislocation of the protein. FLT3, on the other hand, is a receptor tyrosine kinase that regulates hematopoiesis, and the mutations are primarily in exon 14 and 15, juxtamembrane and TKD1 domains. And these internal tandem duplications result in constitutive activation of this receptor. And other less than 5% are also mutations are present in the TKD2 domain, which are the D835 to tyrosine, and other changes, amino acid changes also have been reported. Now, what is the significance of the 3-IDD allelic ratio? Any specific treatment protocols, prognostic impact, and methods for MRD already reviewed. So if you see a comparative of the 2017 ELN risk versus the revised 2022 ELN risk classification, all AMLs with FLT3 ITD are categorized as intermediate risk now. Earlier, it had a LELEC ratio of less than 0.5, had FLT3 ITD low, was considered FLT3 ITD low and was in a favorable category, whereas now this has been revised. So updated. FLT3 is a targetable molecule. There are several generations of FLT3 inhibitors available. Since it's mutated in 30% of AML, this test is very important. And this drives the cellular proliferation and resists death. And high FLT3 is an indicator of high relapse in AML. Now, the prognostic impact of NPM and FLT3 mutations in AML. Both are important clinical predictors. FLT3 ITD mutations are twice as frequent in NPM mutated AML. They co-occur more frequently. NPM mutations precede FLT3 ITD, a secondary mutation aiding in leukemiogenesis. The VAV so FLT3 is apparently a secondary mutation which is acquired. So it could be a subclone of NPM positive mutation. NPM are frequent and very stable. So this is like an MRD assessment time points. NPM and CBF AML fusions are both indicated as clinical biomarkers and are can be monitored using qPCR, whereas in others, so these two are the main markers which have been implicated in clinical biomarkers, but in other AMLs, multicolor flow cytometry is indicated. So some key points from ELN recommendations: qPCR and digital PCR should reach a limit of detection of at least 10 to the minus 3. PB is generally lower in its sensitivity, so marrow is the sample to test, especially in follow-up. So leukemia-related abnormalities suitable for qPCR monitoring include these, and validation is most robust. I've already indicated that NPM, PBF. NGS error-corrected targeted panel-based approaches are preferred. Care must be taken to recognize and exclude germline mutations. Mutations consistent with pre-malignant clonal hematopoiesis should not be considered as MRD. So this is the next topic I would just like to touch upon. And NGS-based strategies currently lack standardization as a standalone technique for MRD assessment. So next, what is CHIP? Clonal hematopoiesis of indeterminate potential or age-related clonal hematopoiesis is the term coined to describe the presence of clonal somatic mutations with low oncogenic potential in leukocytes obtained from healthy individuals or patients with normal blood counts or minimal blood count abnormality, a minimal allele burden of 2%, absence of persistent cytopenia, and exclusion of any underlying pathology associated with the somatic lesion is how it is defined. Why is this important? Because it's an age-related phenomenon and it is acquired with no cytopenias. So these are the examples of various CHIP mutations. The DAT mutations, as they're popularly known, the DMT3, ASXL1, TET2, and their frequency is very high in with age, it increases. So detection of one or more somatic mutation with VAF and DNA from blood or bone marrow cells involving these genes, and the list has increased. 21 common clinically significant genes and 33 additional genes are now indicated. So that's where the role of targeted NGS is becoming more important. And this is just to show the frequency of these mutations and how in the background of CHIP, the outcome of AML, if it progresses to AML, is very poor. So these are important in terms of prognostic factors. Now, what you see here are a few new terms, which is ICOS, CCOS, and MDS. So we've seen what CHIP is like no cytopenias, only clonality. These are mutations, genetic aberrations. The ICOS is indeterminate. So I'll just, yeah. So here, what is important to understand is that there are idiopathic cytopenia of undetermined significance as well as clonal cytopenias of undetermined significance. Why are these two important? Because these can be differentiated based on 3 parameters: cytopenia, clonality, and dysplasia. MDS has all 3. CCUS has a clonality, cytopenia with no dysplasia, and ICUS has only cytopenias of and idiopathic cytopenias. So individuals with idiopathic cytopenias progress at a very low rate of 0.1 to only 1% per year to AML, but CCUS mutations can progress to up to 10 to 20% per year to AML, MDS, MPN. Also, the type of CCUS is important. So these are all taken care of in an NGS panel. So these are the Molecular International Prognostic Scoring System, which is revised for MDS now, and with 31 genes implicated, which need to be tested. And these are the examples of chip-chop mutations. So the clonal nanopores of oncogenic potential, these targets that are listed have FDA-approved drugs available, so they're therapeutic targets. Now, a quick overview of the next generation sequencing. So Illumina dominates the field, second generation. Now, this is like a multi-gene targeted myeloid panel for NGS, which has 141 targets, which covers all MDS, CCUS, all the listed implicated gene mutations can be covered using these panels. This is just a workflow of how a library needs to be prepared using a DNA as a sample. And you fragment the DNA and add some. So error-corrected NGS is based on these molecular barcodes which are added, which ensures that the false positivity rate is low. And then Illumina adapters are added at both the flanking ends. And this is how a final library is made of DNA sample that is isolated from the PBMCs, which carries the 5' and the 5' adapter and the 7' at both the ends. And these adapters are important for the sequencing purpose. So the Illumina sequencing is based on the sequencing by synthesis, which is based on the reversible terminator chemistry. So this library is loaded onto a cartridge, which then flows through on a flow cell. This is the structure of flow cell in the center. On this flow cell, the clusters are formed for each target, and these clusters are amplified using bridge amplification. So each molecule in the library is now a cluster, a clone, and is amplified to make several copies of it, which you see in the lower panel here. And these clusters are now sequenced using sequencing by synthesis. And how they are synthesized is using reversible terminator chemistry. Now, what is this reversible terminator chemistry? Similar to Sanger, but the reversible terminators, the chemical analogs that are used for sequencing, these are fluorescently labeled. Each cycle, they are incorporated depending on their complementarity, whatever nucleotide is, the terminator is incorporated, it creates an image and then blocks that cycle. The next cycle, before the next cycle, this terminator, the reversible terminator is reversed. It's like it's like modified so that it can grow the next cycle. So each base is now sequenced using this strategy of with each cycle an image is created. What you see, this is like a zoomed in flow cell, how these images indicate the colors are corresponding to the nucleotides, the reversible terminators that are indicated in this cycle. So so this way, the whole library sequence is created as images, which are now converted to a bioinformatic file, which is a BCL file converted to FastQ, and this is a long bioinformatic protocol. It takes like several steps to convert them into a variant calling file, which is now used for calling variants. And this is important. The cluster density is important when those clusters are generated on the flow cell and should be overpopulated because then the run is failed. If you have too many clusters not spaced out well, then their passing filter is poor. These are some important terminologies to know in sequencing, which is the Q30 score. Is the percentage of bases that have a quality score of greater than 30, which means the probability of error is 1 in 1,000. So these are that's a cutoff to take how many reads have passed the sequencing. So just a brief summary of sequencing workflow. We've seen DNA isolation for NGS sequencing, subjected to library preparation, cluster generation or bridge amplification, sequencing by synthesis of single base at a time is imaged, data is analyzed, and these images are transformed into base calls and reads. And some important terminologies to know are read depth, coverage. So for NGS, like targeted panels, we do generally 3,000 to 5,000 X coverage, which indicates that each base is read at a depth of an average 5,000, but it varies. So this is just a case report of a myeloid targeted sequencing panel where how this report is read are these 3 mutations were detected, SNVs. There are amino acid changes indicated in the second column. The third column shows you the codon at which this is then, and then the read depth at which each of this like G to A conversion was read 975 times. And the variant allelic frequency of 13%, which indicates it's a subclone. DNMT3A is a subclone, whereas 50% VAF of EZH2 indicates it to be a heterozygous mutation, which is the main clone. And the VAF is also indicator of subclonal. So these are important to also follow up for clonal evolution. The locus, the transcript variant, the consequence. The cosmic IDs is a catalog of somatic mutations where one can find information of these mutations, and there's a pathogenic scoring. Again, this is based on these guidelines by AMP, ASCO, and CAP, the standards and guidelines for interpretation and reporting of sequence variants in cancer. So these are divided into 4 tiers: variants of strong clinical significance, variants of potential clinical significance, then unknown and benign. So these are the main, the tier 1 and the tier 2, because they have FDA-approved therapies as well as powered research, which supports them in terms of their prognostic implications. And in tier 2, FDA-approved therapies for other tumors, which can also be investigational therapies, can be used for AML, for example. And preclinical trials is level D. So this is a reference for how the variants are identified and then assigned their pathogenesis scores. So between DNA and RNA, DNA as a source, like identifying single nucleotide variants, small insertions, deletions, duplication, whereas for gene fusions, RNA sequencing is, and also for identifying splice variants, RNA sequencing is suggested. So this is just to show how this field is heading towards precision medicine, where using NGS testing, one can identify actionable variants as well as help in classification and also prognostication. So if I have more time, I could quickly review this MLPA with the permission of the organizers. Okay, so this is another how we work up a diagnostic workup for a suspected case of BLL. So these are the markers that you see, which are routinely tested, the fusions, BCR-ABL. So minor variant, P190, the BCR-ABL minor isoform is detected in several cases of BLL, and others are there. So, and there are mutation analysis. So the workflow for this remains similar to what I showed you for AML also, like, for APML like we've seen already. So you karyotyping FISH and then RT-PCR for these fusions. These are the common ones. And the workflow remains the same. It's a 2-step PCR like we saw for BCR-ABL. So these fusions are also detected based on 2-step PCR where RNA is converted to cDNA to PCR. And then, so these are, this is an example of detection of these 3 common fusions that are then confirmed. This particular patient that I'm showing you has a TEL-AML fusion. Now, other recommendations for genetic testing in AML, ALL, BLL, are determining the ploidy status and the copy number alterations for certain selected genes with prognostic value and therapeutic management. So this is a chart showing like a high hyperdiploidy indicator of favorable outcomes. Hyperdiploidy, on the other hand, is poor. Now TEL-AML, because this patient had TEL-AML, so that indicates a good outcome. But we will see as we go forward how that prognosis is changed by detection of co-occurring mutations. So the commonly used technique for this is the MLPA, multiplex ligation dependent probe amplification. Now in this, again, the starting material is DNA from PBMCs, could be marrow from marrow, and the DNA that is isolated then is hybridized to pre-designed probes. It's a mixture of probes that can detect deletions and duplications in gene regions, and chromosomal deletions can be detected using this. Larger regions can be detected. So the probes are designed such that they are flanking the region where we want to monitor the deletion. So the next step is to ligate these probes. If the ligation occurs, if they are in proximity, there will be ligation, but if they are not, then if there's a deletion, there will be a loss. And this is then amplified and then again analyzed on a genetic analyzer. So an advanced version of MLPA is the digital multiplex ligation dependent probe amplification, which is DMLPA, and that combines the utility of NGS with MLPA, where one can now, instead of doing smaller number of targets, one can go up to like 56 to 60 targets along with karyotyping all in one tube. And one NGS sequencing can give you all these answers. So this is like a digital MLPA mix target probes covering 323 regions of these different genes listed, as well as it carries karyotyping probes that identify regions of centromeric and telomeric regions. So this is the workflow, and it's a simple way to analyze the gain and loss. For example, if you see in sample 3 here, so this is, so one needs to run control samples to do a relative like quantification based on the copy number gain or loss, which is indicated in the chart at the bottom. So a normal range of value of 0.8 to 1.2 is no gain, no loss, whereas a reduction in this dosage quotient distribution, if there's a single copy loss, then these values are a chart to indicate, and one can easily now read these charts based on whether there's a deletion, homozygous deletion, heterozygous deletion, or a duplication. So this is an example of gain or loss of chromosomal regions. I am 21. And then partial chromosomal deletions. So here, chromosome 21, you see like this region of the target is normal. This is a slight loss, and then there is a duplication. The whole region has, so these are different probes that have now aligned to give you an the region that of the whole IAM21 duplication is happening. And also the ploidy status, for example, this patient, which I initially showed tele-ML positive, has a diploid, but then how a plot of hyperploidy looks is when there is a gain of chromosome. So this is an example of hyperploidy. Again, the reference remains 1, and whatever is above that read ratio indicates gain of chromosome. So this is another example of gain and loss. Intragenic, also intragenic copy number variations can be determined. And what we found was that in this patient with tele-ML, there was a CDKN2A2B deletion. So what are the other methods for detection for this and the prognostic significance? So one can detect the CDKN2A deletions by FISH, PCR, MLPA, digital MLPA, SNP mapping array, and there are the other methods. And so this is like the summary of how patients with high hyperploidy, ETV6, RUNX1, or they have low rates of deletion, and CDKN, the presence of CDK2N deletion here, so deletions of CDKN increased from 38 at presentation to 76 and relapse, suggesting that cell cycle deactivated contributed to mutations. Now, so this clonal origin of relapse in ETV6, RUNX1, ALL, as this is a reference showing an example of ETV6, RUNX1, which otherwise is a favorable out category with CDKN2A like deletions. Makes it alters the prognosis because it is associated with inferior relapse-free survival in pediatric BALL. And I would like to summarize here that with the current molecular techniques that are available for identification and newer entities being added in like the prognostication, therapy, targets for therapeutic intervention. So an integrated multimodal approach where, in addition to morphology, flow cytometry, now targeted NGS is also becoming routine genetic-based testing using RT-PCR for the more sensitive for monitoring, and NGS for and chromosomal analysis. These are becoming routine in molecular diagnostics of hematological malignancies. I would like to stop and thank you very much. I would like to take questions.
Okay, hi, good afternoon, everyone. First and foremost, I am very thankful to Dr. Neeraj Jain for giving me this platform and to talk on this burning topic in microbiology. Right, I'm audible to everybody, and good afternoon once again, everyone. And I'm Dr. Upasana Bhumla. I'm professor and head at Department of Microbiology, Adesh Institute of Medical Sciences, and I'm also the member secretary for the Hospital Infection Control Committee at Adesh Institute, Bathinda. I would like to thank Dr. Neeraj Jain and Melap for giving me this opportunity to talk on this healthcare-associated infections, which is a prevalent and a very burning topic nowadays. So very quickly, because already a lot of time has been wasted because of this screen sharing. You mind if at all I just close the video because I'm quite comfortable with it. One second, let me just move the screen one side. Okay. Talking about what are these hospital-acquired infections or the healthcare-associated infections, or what do we call as the nosocomial infections, which has been throughout. These HAIs are the infections which are acquired in the hospital by a patient who is admitted for a reason other than the infection in content. Infection should not be present or incubating at the time of admission. Most importantly, how we portray this as एक patient अगर हमारे पास X disease के साथ आया है, so when patient is developing a Y disease in the hospital setup when he or she is available with us for almost 48 hours, so some infection which has been given added to the infection which is already present with the patient is nothing but a nosocomial infection or a hospital-acquired infection or a healthcare-associated infection. And prevention of such of these nosocomial infection is the responsibility of all the individuals and the services which are being provided by the healthcare setting. So as we talk about the history of infection control, as we know, it is as old as mankind, and since 19th century, we have the pioneers who have been talking about for the infection control practices. We have Louis Pasteur, we have Semmelweis, Joseph Lister, who framed the word antisepsis, Robert Koch, who worked extensively for TB, and one of the renowned Nobel laureate, and Florence Nightingale. How can I miss the achievements? So in short, if at all I talk about the infection control includes all the policies, the procedures, and it is designed to minimize the occurrence of infection in the healthcare, minimize the occurrence of infection in the healthcare setting. Right? Very quickly, if at all, I can just brief you what are these infection control, what is Hospital Infection Control Committee, HICC जब हम बात करते हैं, so it is at, this whole thing is one infection control program. It operates at two levels. One is the infection control team, that is the executive body, and the other one is the advisory body, which is the infection control, Hospital Infection Control Committee, which adopts the legislative role of the policy. So talking about this ICP, we have the HICC, the committee, we have the infection control team, which works on day-to-day daily basis, and we definitely have an infection control manual. Us manual ke andar, we have all the policies and procedures, the SOPs, how to proceed for the infection control practices in a healthcare setting. Very quickly, I'll address you about the Hospital Infection Control Committee. There are bigger setups, there are tertiary care hospitals, there are very small centers. In that context, I need to address out here what are the committee members and who all can be there in the committee, in the Hospital Infection Control Committee. So first and foremost, we should have a hospital administrator who has to be a chairperson, because all the financial, all the professional related problems, you have to address it to the higher authorities. One administrator has to be there as a chairperson in the committee member. The member secretary of the HICC is mandatorily a person from microbiology department who can address at the level of the chairperson, who can address at the level of the committee, and who can address at the level of day-to-day practices also. Then comes the clinical microbiologist or the infection control officer. This plays a very pivotal role because they are the ones, along with the infection control nurses, who works on a daily basis. Fourthly, we have the infection control nurse. There has been questions many times which has been aroused that kitne hone chahiye ICNs? 1 is to 250. One infection control nurse over 250 patients is mandatory for any setup to work on. Then we have a team of general physician, general surgery, director of nursing or the nursing superintendent, who's very important because beyond their help, this infection control practices cannot be implemented. Then the occupational health physician or the ID specialist, other representative from the other areas of your hospital can also be a part of this infection control committee, whosoever is interested and knowing and to have the knowledge of infection control. Additional to this, we should have the representatives from the operations, some person from pharmacy, some person labeled for CSSD, the maintenance team, and the housekeeping team. They all play a very important and a crucial role when we build up a strong infection control team, infection control committee in a particular healthcare setting. This was all about HICC. So moving on to infection control team, who comprises of ICTs? ICTs, infection control team, they work on daily basis. ये report करेंगे member secretary को, and member secretary reports on weekly or monthly basis to the chief administrator or the hospital administrator or the chairperson of HICC. So we have to have a microbiologist, we have to have a ICN who works on the procedures and the policies, whether it are being implemented properly at every particular setting or not. टॉकिंग अबाउट द इन्फेक्शन कंट्रोल मैनुअल, एक बुक है आपके पास, उस बुक को आपने एक साइड पे रख दिया, will not carry value till the time you are not putting up the effort to read it and to implement the things, the policies and the procedures which are given in that to follow in a healthcare setting. How the manual has to be implemented? Firstly, it should carry the organogram of the hospital, that who is the administrator, who is the member secretary, who is the ICO, and who are the other representatives from different areas. Secondly, you should be having the risk categorization of hospital areas, then surveillance mapping of risk areas. For example, the world was dealing with COVID. So what all surveillance measures we have taken? Then we talk about hand hygiene practices, which is very important. Nowadays, from a nursery child, he or she knows what are the hand hygiene, what are the hand washing steps. Then standard precautions, isolation precautions, what are the high risk areas, what are the occupational exposure to blood and body fluids, about the spills and all. What are the recommendations of cleaning and disinfection? That is exclusively the work of infection control team to implement at the areas where it is desired, whether it is ICUs, whether it is cath labs, whether it's operation theaters, dialysis, critical or non-critical areas. Importantly, then we should have a vaccination policy of hospital about the swine flu vaccination, about the COVID vaccination, which was lately 2 to 3 years back. It was so much at a boom. Apart from that, what healthcare workers, and apart from that, what are the food handlers they should be vaccinated with? Outbreak management. I think I just repeated the word saying that COVID has been an outbreak in our lives, and it has been managed well at a national level, at a healthcare setting level. At every point, every doctor and a nurse and the other healthcare staff has worked enormously while during managing this outbreak. And lastly, word about the mortuary, that where it is located, what are the important steps, and what are the infection control practices which are being implemented in mortuary. All these points should be inculcated in your infection control manual. So as we speak, a hospital infection control program comprises of 3 parts. One, it formulates a hospital infection control committee. Then we have the infection control team. And thirdly, we have the infection control manual. All these 3 things comprises of the infection control program. We're talking about what are the functions of HICC. First and the utmost importance, HAI surveillance, healthcare associated surveillance. जिसके बारे में हम बात करेंगे, there are 4 parameters enormously. One is catheter associated UTI, the other one is central line associated bloodstream infections, then we have the ventilator associated pneumonias, and lastly we have the surgical site infections. Then what are the systems? Develops a system for identification, reporting, analyzing and controlling of HAIs. आपने एक ऑर्गेनिज्म को आइडेंटिफाई किया, उसकी रिपोर्टिंग हो गया, एनालिसिंग वेयर दिस हैज बिकम अ हॉटस्पॉट, या कहाँ पे हमें इस ऑर्गेनिज्म का मैक्सिमम आउटब्रेक मिल रहा है, उसकी एनालिसिस करने के बाद हाउ यू हैव कंट्रोल्ड दिस इज अ पार्ट ऑफ फंक्शन ऑफ HICC. Making policies or for proper antibiotic usage. Nowadays, too much of irrational use of antibiotics we have heard about. It is one of the challenging factors, and that is what implementing of antibiotic stewardship program is mandatorily. Now that with medical colleges especially, I can state here that ICMR has lined up a national stewardship program, which medical colleges especially all over the ground has, since I come from a medical college. So we have been forcefully asked to make the policies and make an antibiotic stewardship program so that it is well implemented in a healthcare setting. Then next one again for the outbreak management, HICC is important, and reviews and HICC meetings should be very oftenly happen. Why? Because every monthly or every quarterly, if at all we are having this committee meetings, we know what are the parameters we are lacking and where we can have a space of improvement. Moving on to what is surveillance, हम बात कर रहे हैं कि हमें 4 parameters का surveillance करना है. तो surveillance होता क्या है? आपने एक डाटा का systematic method of collecting, consolidating and analyzing a data. And इन सब की analysis के बाद आपने इसके improve करने के लिए क्या preventive measures लिए? What are the things you have taken up for the improvement in the healthcare setting, so that the outcome is good, so that we have the lesser rate of HAIs in our system. That is the utmost importance of surveillance. So since we start, we have spoken about the functions, we have spoken about what surveillance is. अब surveillance हम किन किन parameters का करता है, उनका एक एक बारी हम discuss करेंगे. So when we talk about catheter associated UTI, yes, it is important, and CDC has been talking about it on a very larger scale, that it is one of the, as per NHS standards, the rates have increased from 0 to 5.3% in critical care areas and 0 to 3.1 in IPD patients. This is the CDC data. But when we talk about India, the COTI ranges from 1.63 to 2.1 per 1,000 catheter days. What exactly is this COTI? Catheter associated UTI is nothing but when you have inserted, there is a catheter in situ, indwelling urinary catheter, which was placed for more than 2 days, that is more than 48 hours, on the date of even with the day of device placement to be day 1. Or it can be more than 2 calendar days and then removed. The date of event for the UTI must be the day of discontinuation or next day of the UTI to be catheter associated, right? So this defines the COTI. Isme bhi there are 2 points. One is systematic catheter as so urinary tract infection. The other one is asystematic, symptomatic and asymptomatic UTI. SUTI and ABRUTI is called. So in symptomatic, as the word itself, it is saying that the indwelling catheter has to be placed for more than 2 days, with device placement day as being 1, and at least one of the following signs and symptoms. So either the patient can develop fever or a costovertebral angle pain or a culture positive should be there. So that labels a symptomatic urinary tract infection. Moving on to asymptomatic bacteremic urinary tract infection, the word itself it is defining, it is asymptomatic. कोई symptoms नहीं है patient को, but randomly it has been picked up कि हाँ patient is developing fever, patient might have any bradycardia or any other मतलब frequency or urgency कुछ ऐसा नहीं भी है patient के अंदर, just random आपने एक urinary sample भेजा and it came out to be culture positive. So since it is positive, with or without an indwelling urinary catheter with no signs of UTI, you can think about as asymptomatic bacteremic urinary tract infection. What are the most commonest organisms which causes COTI is E. coli, mainly from the Enterobacteriaceae family, E. coli being the predominant one, gram-negative bacteria, Pseudomonas being the second most important one, and in gram-negative we have more of Staph aureus and Staphylococcus epidermidis in ANC patients which is seen. So why it is recommended that जब हम catheter, when I talk about surveillance, I think I'll tell in detail about the catheter insertions also. So how do we calculate the surveillance of COTI? COTI rate is calculated as number of urinary catheter associated cases in that particular month, and the denominator has to be the number of urinary catheter days in that particular month multiplied by 1,000. What are the core and supplemental strategies to prevent this catheter associated UTI? So core strategies include insert catheters only for appropriate indications. अब हम जब catheter insertion की बात करते हैं, सबसे पहली बात क्यों हम कर रहे हैं? What is the reason? What can be the possible indication why the patient is labeled to be catheterized? So is it a high risk? Is it a elderly woman? It is a immunocompromised patient. In all those places, you can think of inserting a catheter. If the patient is mobile enough, you don't have to. And beyond that, how you are addressing it, how you are putting up this catheter in situ in a patient. So while using sterile gloves, sterile field should be there, periurethral dressings, cleaning should be there, 2% of lignocaine jelly should be used, and during catheter insertion, aseptic non-touch technique. So it has to be done by some trained person, balloon inflation, whether the dressing after that was done properly or not, and the drainage. The bag must be below the level of the bladder to prevent reflex of the urine. And lastly, Secure with the plastic tape, catheter plastic tape. It will be easy for you to line up things. और ये एक चेकलिस्ट है आपके सामने. You just need to what is the time of catheter insertion, what is the date, name of the patient, पूरे उसके vitals के बारे में आप बताएंगे. What is the ID number, what is the IPD number, age, sex, bed area, location. Then you tell out what is the date, what is the time, who is inserting. This is very very important because who, whether it's a trained person or not, or whether it's just training who has actually inserted the catheter. And these are some of the prerequisites before the procedure, during the procedure, and after the procedure. As I said that gloves use करे थे कि नहीं किए थे, sterile area था कि नहीं था, periurethral cleaning हुई थी, lignocaine jelly use करी गई थी कि नहीं की गई थी. During the time of procedure, whether the urethral meatus was again clean, lubricated, and balloon inflation was done or not. And after the procedure, proper the drainage has been इसको आपने लेवल ऑफ द ब्लैडर, बिलो द लेवल ऑफ द ब्लैडर पे रखा है कि नहीं रखा है, सिक्योर किया है इसको पेरीयूरेथ्रल टेप के साथ कि नहीं. These all these steps are very very important for any catheter insertion, right? These are the further parameters. So first was how you have actually proceeded. That is the core supplement strategy what you are using to insert a catheter. Leave catheters in place only as long as needed. Don't put up the catheters for more than 48 hours. Preferably, agar post-operatively hai, after 24 hours, you should remove the catheter and ask the patient to void the urine by themselves. Ensure that only properly trained persons, I am emphasizing on this point because it is very important. Some intern, some student, if at all they are doing, who are not even trained properly, should not insert the catheter. They are the major reasons for a patient to develop clot. Insert catheters using aseptic technique, I think we have already dealt about it, right? So these are the core supplemental strategies to prevent catheter-associated UTI. This is one of the infection control daily surveillance data that is similar for urine catheter, for central lines, for ventilator patients. This is the parameters we have been using for a complete month, right? And this is the COTI data form, surveillance form. So again, if we have labeled somebody as catheter associated UTI, fill up the whole form with name, patient's age, sex, when patient was admitted, is the urinary catheter in place for more than 2 days? अगर less than 48 hours है तो हमें label ही नहीं करना चाहिए. कब डाला था, कब insert हुआ था, कब remove किया गया था. So were there any signs and symptoms of UTI, or the culture was positive or not for the patient? To label it as either it was symptomatic or asymptomatic, right? This is one of the performers for COTI in our setup. Moving on, next we have the second parameter as ventilator associated pneumonias. This is very very important and the second largest reason for mortality in India in healthcare settings in causing healthcare associated pneumonias. So this picture itself speaks normal chest and how a VAP patient looks like. So to define VAP, what is a VAP? It is defined as the pneumonia that occurs 48 to 72 hours or thereafter following the endotracheal intubation, which is characterized by presence of new or progressive pulmonary infiltrates, the signs of systemic infection, which is either a fever or an altered WBC count or TLC count is there. Changes in the secretions, endotracheal secretions, or changes in the sputum characteristics. And lastly, the most important one, as a microbiologist, there is a detection of a causative agent or not. This is very, very important. So, as I said that pneumonia, which is occurring beyond 48 to 72 hours, presence of any progressive infiltrates, signs of any systemic infection, any worsening oxygenation, changes in the secretions or the sputum characteristic, and the presence of a microbiological agent are all comprising to form the VAP. And what is the VAP rate in Asia, if at all we talk, it is like 3.524 per 1,000 mechanical ventilator days. And in India, it has been considered as more than that. That is why in India, it is the second most common healthcare associated ICU infection, what we have come through. So what are the reasons, what are the microorganisms which are involved in VAP? So there is early onset VAP, there is late onset. One is beyond at 48 hours what you are developing, and beyond 48 hours is late onset. So Klebsiella pneumoniae, and very challenging organism, multi-drug resistance Klebsiella pneumoniae is very important to cause early onset VAP. Then we have gram-negative bacilli like E. coli, Enterobacter, and Serratia species. Then methicillin sensitive Staph aureus is also one of the reasons for early onset VAP, and Streptococcus pneumoniae and Haemophilus influenza. Not largely we get it in a healthcare setting, but yes, MDR Klebsiella is very predominant to cause early onset VAP. Talking about late onset, we have methicillin resistant Staph aureus, we have Acinetobacter, we have Pseudomonas aeruginosa labeling many patients and leading to mortality in patients. Also, VAP from fungal and viral causes also has a low to moderate incidence, especially in the immunocompetent patient, especially in the terminal patients when we lead to, these are also one of the parameters to rule out. So how do we diagnose? There is one thing called as CPIS scoring, Clinical Pulmonary Infection Score. So it is based on six parameters. One is the temperature, then the TLC count, tracheal secretions, radiographic findings, culture results, and oxygenation status. So when we talk about temperature, whether the patient was febrile, afebrile, and febrile hai to what is the temperature? So based on that, we give the scoring 0, 1, and 2. Then we talk about the leukocyte count. Is it normal? It is less than normal, or it is more than normal with 500 band cells are present. So based on that, we give the scoring. Then we talk about the tracheal secretions. जब आप पेशेंट को मैकेनिकली आपने वेंटिलेट किया है, इंट्यूबेशन किया है आपने, कोई सिक्रीशंस आया था? नहीं. Mild or non-purulent था, we can label it. If it is purulent, it is definitely. One word out here, चाहे आप कैथेटर एसोसिएटेड यूटीआई की बात करें, चाहे आप वैप की बात करें, चाहे आप एसएसआई की बात करें, चाहे आप central line associated bloodstream infection की बात करें, everywhere you have to look out whether the patient was, उसके जो सैंपल्स जब हमारे पास हॉस्पिटल में एडमिट हुआ है, at the time of intubation, at the time of insertion of catheters and central lines, whether the patient sample was sent to microbiology lab or not, because you are sending after 48 hours. There is no comparison. If there is a comparison, you definitely know there. One second. If you have the comparisons in your hand, so you know whether the patient was already labeled from somewhere or the patient definitely had carry infection from somewhere else. So all these parameters are very important for you to know. Okay, then next up we have this, we spoke about tracheal secretions. Then we talk about the radiographic findings. No, अभी मैंने आपको एक chest X-ray दिखाया है, whether there was infiltrate, it was a diffuse or patchy infiltrate, or it was a localized infiltrate. Fifthly, the culture results. As I said, quantitative measures हमारे बहुत ज़्यादा ज़रूरी हैं. हम microbiology lab में जब quantitate करते हैं, so the threshold values of 3 kind of samples is very important. आपने patient को intubate कर दिया. So endotracheal aspirate, if it is more than 10 to the power of 5 colony forming unit, it is pathogenic for us. अगर ये bronchoalveolar lavage है, तो हमारे पास 10 to the 4 colony forming unit, 10 to the power of 4 colony forming units हैं. That is important. And अगर ये protected specimen brushings हैं, more than 1000 colony forming units हैं, we should look for. So mild or no or mild growth, we label it as 0. Moderate or florid, 10 to the power of 3. Moderate to florid, 10 to the power of 4. Or it is consistent with the gram staining, we should think about it as more than 10 to the power of 4 or 10 to the power of 5. So please, in that context, look into it. Is there anything I need to be addressed? I don't know. Okay, and up next is the oxygenation status, less than 250 or more than 250, whether the patient is in ARDS or there is absence of ARDS. So based on all this clinical pulmonary infection score, CPIS score, we label the patient to be for VAP. Okay, so scores can range from 0 to 12 and score of more than 6 is a good correlation with the presence of VAP. Now what are the surveillance parameters? हमने पहले कॉटी को सर्वेलेंस देखा, अब हमें वैप का सर्वेलेंस देखना है. सो वैप रेट इज नथिंग बट नंबर ऑफ वेंटिलेटर एसोसिएटेड निमोनिया केसेस पर मंथ. वहां हमने क्या देखा था? कॉटी के केसेस देखे थे पर मंथ. डिनोमिनेटर वाज नंबर ऑफ कैथेटर डेज थे, यहाँ पे नंबर ऑफ वेंटिलेटर डेज पर मंथ है मल्टीप्लाइड बाय 1000. सो दैट इज हाउ यू कैलकुलेट द वैप सर्वेलेंस. दिस इज VAE, वेंटिलेटर एसोसिएटेड इवेंट का हम लोग जब ट्रैकिंग करते हैं. अगेन नेम ऑफ द पेशेंट, व्हाट इज द ID नंबर, बेसलाइन कल्चर. यहाँ पे मैं आई सेड दैट पेशेंट को जब इंट्यूबेट करा था टू हैव अ क्लियर पिक्चर, ट्रेकियल सिक्रीशन या TLC काउंट या कल्चर के लिए हर जगह पे ये पॉइंट आता है कि वो सिक्रीशंस आपने पहले भेजी थी व्हेन द पेशेंट वाज इंट्यूबेटेड या आफ्टर 48 आवर्स ही आप सैंपल भेज रहे हैं. देयर विल बी नो कोरिलेशन, देयर विल बी नो कंपैरिजन देन. व्हाट इज द डॉक्टर नेम? सो वी बेस्ड ऑन दिस, P वैल्यू कितनी है, FiO2 वैल्यू कितनी है, TLC टेम्परेचर, व्हाट आर द एंटीबायोटिक्स वी आर गिवन. and एक organism था या दो organism से, whether the antibiotic was tapered at the third day or the fourth day, all these things has to be tracked well. This is the same infection control surveillance parameter जो हम लोग define करते हैं. So what is the treatment of VAP? When we talk about late onset VAP, it requires a broad spectrum, right? And there is a limited area when we talk about MDR Klebsiella. Now that with MDR Klebsiella, multi-drug resistant है, so it has been resistant to colistin, it has been resistant to carbapenemase, so the next entity becomes a ceftazidime avibactam. आज की डेट में अगर ceftazidime avibactam भी है, अगर resistant आ रही है, then we give a combinative therapy. So colistin estronam we can give a combinative of carbapenemase and ceftazidime avibactam. When we talk about the early onset PrEP, we can give third generation or second generation cephalosporins. We can give a combination of fluoroquinolones, beta-lactamase inhibitors, carbapenemases, aminoglycosides, and the most important, अगर pseudomonas suspected है तो anti-pseudomonal drugs, that is ceftazidime and fluoroquinolones. And one point about the coverage of MRSA, vancomycin and linezolid are the drugs of choice. But अगर वो भी resistant है, visa, we have vancomycin resistant, we can think about daptomycin as one of the drug of choice. What is the prevention of VAP? This is very important, this 5-element VAP bundle. हम जब भी बात करते हैं VAP के बारे में, VAP को हम कम कैसे कर सकते हैं? From our Indian setup, how can we just reduce it? The burden has to be reduced by, not by itself, you have to work on this. So first and foremost, oral care with chlorhexidine. So morning gargles and morning cleaning of the oral mucosa with the proper chlorhexidine, and washing should be done. Oral health care should be taken into consideration. That is one point. Stress ulcer prophylaxis, because आधा से ज़्यादा patients ये लेटे ही रहते हैं. They are more prone to develop stress ulcer. So इसके prophylaxis के लिए either you give PPI inhibitors or you can give sucralfate. And intubations are at the risk of stress ulcer leading to upper GI hemorrhage भी कर सकते हैं. So this is very very important to look for stress ulcer prophylaxis. Then motivating the patient for daily sedation assessment and spontaneous breathing trials. Since the patient is lying, the patient is intubated. That does not mean you every time have to sedate the patient and just make them lie off. No. So slowly and gradually the sedation therapy should be reduced or eventually to none, so that they are able to breathe up properly and they can be extubated. The next point is deep venous thrombosis prophylaxis. As I said, patient is lying in a supine position only, very prone for DVTs. So in that case, more of the movement should be done. And lastly, physiotherapy people play a very, very important role in this. So the head end of bed elevation is very much required. And physiotherapy, पीछे back पे हम अगर what do you say that pat करें बहुत अच्छे से, so at that point of time it is very very helpful for the prevention of that. So this 5-element VAP bundle. Please remember oral care, stress ulcer prophylaxis, daily sedation assessment, and inculcating the habit of spontaneous breathing trials, DVT thrombosis prophylaxis, and head of the bed is elevated and physiotherapy relaxation should be given. So respiratory physiotherapy, which will help to increase drainage of the secretion, and thereby it will prevent the development of VAP, and manual lung hyperinflation, body positioning, and chest wall vibrations. What I'm saying is patting at the back. It is very important for prevention of VAP. We have just already discussed. So this is ventilator bundle checklist. These are the days, whether ये सब कुछ checklist है. आप जो भी कह रहे हैं, ये हुआ है कि नहीं है, किसने किया है, at the end of it, it has to be signed by the particular person. This is the VAE form हमारे पास. अगर हमारे पास कोई patient 48 hours के उसके बाद label हो जाता है ventilator associated pneumonia, so how do we track it? We write the patient name, gender, date, age, when was the event happened, when was patient intubated, what was this FiO2 values, PEEP values, temperature was increased or not, any new antimicrobial agent was added. And these are the 3 criteria. Criteria 1, culture positive था, secretions कैसे थे, and one of the following positive tests, that is either of lung pathology या pleural fluid culture या diagnostic test for any viral pathogen has been considered or not. So in that way we fill up this VAE form. This is almost similar. What was the kind of organism and what was the antibiotics given? And lastly, of course, hand washing. ये cotting में भी important था, clepsy में भी important है, and we talk about VAP. It is also important. Hand washing, hand washing, hand washing. Since the world has dealt with COVID, I think hand washing is the biggest answer to all half of your healthcare associated infections problem to be removed out. Moving on to, I have the central line associated bloodstream infection, right? So there are two terminologies. One is CRBSI, one is CLEPSI. अब आप बात कर रहे होंगे कि मैम आप जब कहते हैं CLEPSI, when do we say it as CRBSI? So for laboratory diagnosis and treatment purpose हम इसको label करेंगे catheter related bloodstream infection. But जब हमें surveillance करना होगा as a parameter for HAI, we label it as CLEPSI. And what is the CLEPSI rate? It is bloodstream infection. Then again, the number of central line cases. Denominator is again the total number of central line days multiplied by 1000. So three of the terminologies. कितने cases हुए हैं उस महीने में? How many days in that particular month it was kept on and multiplied by 1000. To label it as laboratory confirmed bloodstream infection, when do we call it as LCBI? So pathogen होना चाहिए from one thumb rule of central line bloodstream infections. First and the foremost, paired blood cultures have to be sent. आपने कॉटी की बात करी, यूटीआई की बात करी, एक यूरिन सैंपल से चला जाएगा. वेंटिलेटर एसोसिएटेड निमोनिया की बात करी, एंडोट्रेकल सिक्रीशन एक चली जाएगी. बट अगर आप ब्लड की बात कर रहे हैं, आपको दोनों तरफ से, अगर सेंट्रल लाइन डली है, दोनों तरफ से आपको ब्लड भेजना है. अगर एक जगह सेंट्रल लाइन डली है, यू आर सपोज टू सेंड द सेकंड. पेयर्ड ब्लड कल्चर इज अ थंब रूल फॉर सेंट्रल लाइन ब्लड स्ट्रीम इन्फेक्शन. And patient has at least one of the following symptoms, which is fever, hypotensive, and positive laboratory are not related to any infection at any other site. सिर्फ ब्लड में ही वो कल्चर पॉजिटिव आ रहा है, किसी और साइट में सेम ऑर्गेनिज्म नहीं आ रहा है. So these are the prerequisites to label the patient as laboratory confirmed bloodstream infection. Now moving on, what are the risk factors? तीन तरह की चीजें हो सकती हैं, पेशेंट रिलेटेड, डिवाइस रिलेटेड, हेल्थ केयर वर्कर रिलेटेड. यही बात मैंने कॉटी में करी थी, यही बात मैं वैब में कर रही हूँ. अब हम जब क्लेप्सी के बारे में बात कर रहे हैं, पेशेंट रिलेटेड, ऑफ कोर्स इधर इट इज इम्यूनोडेफिशिएंट पेशेंट, सिवियर अंडरलाइंग डिजीज है, टर्मिनल पेशेंट है, या कोई बेडरिडन पेशेंट है, एंड लॉस ऑफ स्किन इंटीग्रिटी रहा है. तो मतलब दीज आर द predominant indications when a patient should be central line should be placed. When we talk about device related, what is the catheter composition? उसकी क्या है? लेटेक्स का बना हुआ है, टनल्ड है, सेमी implanted catheters है, कौन से वाले हैं? Then we talk about the construction and the thrombogenicity and the flexibility, right? कितना देर हमने रखा है सेंट्रल लाइन को? As long as 72 hours भी रख सकते हैं, lesser than 72 hours भी रख सकते हैं. What is the most predominant site we use? Subclavian site, then the jugular vein, subclavian vein, then the jugular vein, and the least interested one, least preferable one is the femoral vein. If both the places are not available, you are not able to find the central line, think about, yes, you can. What is the type of catheter? Implantable device है, non-tunnel catheter है. They are very, very prone for high risk of this central line associated bloodstream infection. Right, silicone catheters हैं, number of lumens अगर उसमें बहुत ज़्यादा बने हुए हैं, it is at a very high risk to create the central line associated bloodstream infection. Lastly, we have the healthcare worker related, poor hand hygiene, hand washing, hand hygiene अगर नहीं की, dressing अगर properly नहीं हुई, lack of sterile practices नहीं है, and poor personal scheme. Because central line is such a thing, if it is not done by a trained personnel, especially a doctor, think of having CLEPSI in your setup. What are the most common etiological agents? In gram negatives, we have Pseudomonas aeruginosa being the predominant one, and in gram positives, we have Staphylococcus aureus. Also, we have the GERD for Burkholderia and Enterobacteriaceae family. Pathogenesis, foreign body है, central line is a foreign body. Cotty catheter is a foreign body. Ventilator associated में mechanical में intubate अगर कर रहे हैं तो वो they are all foreign body. They will produce a reaction. There is lining of the microorganism, biofilm formation हो जाएगी, that can act as a colonizer also, and this will lead to local sepsis or septic thrombophlebitis. Moving on to CLEPSI. एक पॉइंट मैं आपको यहाँ पे बताना चाहूंगी, जब हम कैथेटर रिलेटेड ब्लड स्ट्रीम इन्फेक्शन की बात करें, ओनली पेयर्ड वी हैव स्पोकन अबाउट, बाकी जगह पे एक एक सैंपल चलेगा, बट व्हेन यू टॉक अबाउट ब्लड इट हैज टू बी 2 ब्लड कल्चर्स. टिप कल्चर का जो एक सिनेरियो बना हुआ है, उस चीज को आपको रिमूव करना है. इट इज कंप्लीटली कॉन्ट्राइंडिकेटेड. वेदर वी टॉक अबाउट कैथेटर एसोसिएटेड यूटीआई, यूरिनरी कैथेटर डाला हुआ है, उसका टिप कल्चर अगर आपके पास कभी आए माइक्रोबायोलॉजी लैब में, वेंटिलेटर की अगर ईटी सिक्रेशन की आपको मतलब वहां से टिप भेज रहे हैं, नो इट इज नॉट considered to be considerate. And अगर blood central line से भी अगर आप catheter tip काट के दे रहे हैं, जैसे कि culture that many a times it is a colonizer and it is misreported, this habit only should be removed from your healthcare setting to have the lesser rate of HAI parameters. One word about differential time. These are the automated blood culture methods. Backtech is one of the systems what I use in my thing, and these are the blood culture bottles. इसमें हमारे पास aerobic culture के लिए भी है, anaerobic के लिए भी है, pediatric के लिए अलग blood bottle है. So all these are labeled. So what is the collection time? When the sample was arrived at our microbiology lab, when was it entered into the backtech, ये positive signal कब हुआ है, and finally इसकी reporting कब हुई है. So when we talk about differential time to positivity, transport time से लेके time to positivity तक, that is nothing but your differential time to positivity. आपने सैंपल 9 बजे लिया है, 9:30 तक आपकी लैब में आया है, आपने उसको immediately आते ही अपने बैकटैक में डाल दिया. When it has flagged, so time between these two, from sample taken to the time it has flagged, it is nothing but the differential time to positivity in a backpack system. And it is very important for a clinician to know it. कि ये late हुआ है, ये पहले हुआ है, and it is basically done on semi-quantitative methods. So you look for the colony forming units, how it is formed, and which is a typical bacteria which is being shown. And this is one of the central line associated bloodstream infection ka bundle checklist. Same way, just like the other parameters. This is how we calculate. कब लगाया था, कब सेंट्रल लाइन पड़ी थी, who has supervised it, टाइप ऑफ कैथेटर कैसा था, सीवीपी था, डायलिसिस था, पीआई पिक लाइन था, कौन सा था, whether the new lines, whether the safety precautions were taken pre, during the procedure and post procedure, what all the measures were taken. So these are one of the good practices from the foreign countries we generally inculcate. Yes, proper with dressing, proper with, once it is done, it is not that you have to keep the central line out there only. So catheter side dressing is also very, very important. गॉज की ड्रेसिंग एवरी सेकेंड डे होनी चाहिए. सेमी परमिएबल ड्रेसिंग्स अगर हैं तो आफ्टर 7 days होनी चाहिए. एंड टर्नल एंड इम्प्लांटेड कैथेटर्स हैं, once a week it is very much mandatory to be done. And chlorhexidine is a recommended disinfectant to clean the particular area. So this is the maintenance checklist for central line. It's important for you to know this. What are the daily parameters we look for? Strategies, quality assurance and continuous education. ये नहीं कि आपने एक system में किसी को ले लिया है अपने and you just can go on and on and on. You need to educate them on daily basis. That is what infection control team does. And if not weekly basis, there should be some training, hand washing trainings about how to do the procedures. That training about how to keep the dressings and the catheters and mechanical ventilators in place. उनकी training होनी continuous way में, it is very, very important. So as I said, subclavian site is used instead of jugular or femoral. Hand hygiene is a bigger example, bigger setup to give many answers to reduce the HAIs in a system. Changing administration sets or at appropriate intervals, as I said that कि अगर एक हफ्ते के बाद change करना, कोशिश ये होनी चाहिए not more than 72 hours, it should be kept in situ. Remove catheters after intended use. Chlorhexidine containing cutaneous antiseptics are used, and transparent semi-permeable polyurethane dressings will help you to reduce the infection rate in your setup. This is one of the event form how we fill up. Again, patient name, gender, event type, clepsy, कब हुआ था, कब central line डली थी, who did that, whether the signs and symptoms are positive, and either of the two blood cultures जो हमने भेजे हैं उसमें positive आया है तो क्या आया है, which organism, and what is the line of treatment which we have given. Right? Very quickly and taking not much of your time, I'll talk about surgical site infections. अभी तक आप बात कर रहे थे everything after 48 hours. Patient आया आपके पास, उसके 48 hours के बाद अगर कुछ in situ है, whether it is urine catheter, whether it is endotracheal intubation, whether it is your central line, 48 hours के बाद, पहले नहीं था at the time of admission, 48 hours के बाद अगर line up हो गया, it can be these three things. But when you talk about surgical site, it is basically divided into two types, incisional and organ, and incisional is further divided into superficial and deep. So when we talk about SSI, superficial incisional SSI, it occurs within 30 days. आपने पेशेंट को लिया, पेशेंट ऑपरेट हुआ, ऑपरेट होने के 30 डेज के बाद या ड्यूरिंग दैट 0 to 30 days, 1 to 30 days, if the patient has come on 15th day and some serious fluid is running through the stitch line, think about it can be one of the superficial incisional surgical site infections. So within 30 days after the surgery and involves only skin and subcutaneous tissue, And at least either a purulent discharge and the laboratory. When you send the purulent discharge to us, there is an organism present, or there can be pain or tenderness, localized swelling or fever. Any of the signs and symptoms is there, label the patient as SSI. What is not to be reported as SSI? Stitch abscess? No, it is not. Infection of an episiotomy or a newborn circumcision site? No. Infected burn wounds are also not surgical site infections. Then talking about deep incisional SSI, superficial था within 30 days में, deep है because it will be involving the deep soft tissues also. So between 30 to 90 days अगर के day of surgery 1 से लेके either 30 days और maximum up to 90 days के अंदर अगर आपके पास patient आ रहा है, stitch line से ooze है, there is a purulent discharge, there is laboratory confirmation of the purulent discharge with some of the organism, any signs and symptoms are there, label the patient as deep incisional SSI. Up next, we have the organ or the space. The word itself is defined. It involves any part of the body deeper than the muscle. Again, one, purulent discharge. Second, the laboratory confirmation with any of the organism and any signs and symptoms are present. Think about it as an organ space SSI. Risk factors are almost the same, patient related, device related, anything, any suture line, any surgery which has been done, whether it was clean or contaminated, everything is important. The nutrition status of the patient, how much is the hospital stay, or pre-op nasal colonization staph aureus. MRSA is a nightmare to any surgeon. MRSA clinic and MRSA ward, I think the right side picture is showing it, depicting it very well. There are likely chances to have such events. So this is one of the SSI pointers. हमारा same surveillance का बना हुआ है पूरा हमारा checklist, and we have this form. So patient ID, सर्विलेंस कैसे उस पे आप करेंगे, इंसिशनल था, सुपरफिशियल था, डीप था, एंड व्हाट आर द साइंस एंड सिम्टम, लेबोरेटरी ऑर्गेनिज्म कंफर्म है कि नहीं है, एक ऑर्गेनिज्म है, दो है, what is the kind of infection, which is the organism, these are the SSI surveillance pointers. So all these data we have to fill, then only we can label the patient to be as SSI. So when we talk about standard or universal precautions, hand hygiene is your answer, PPEs पहना जा सकता है, safe injection practices, and medical or equipment, environmental equipment cleaning is utmost. So when we talk about okay, very quickly, बहुत बड़ी हमें ये जवाब मिलता है saying that कि हाथ धोना ही तो है, इसमें इतनी बड़ी बात क्या है, it's not that a big deal. हाथ धोने के लिए इतना मतलब हमें शोर नहीं मचाना चाहिए as microbiologists, but no, till the time we are not banging and we are not saying them again and again, they will not hear it. So very quickly, if at all I can ask all of you, I can't see the picture, where are the participants? Can anybody hear me? All of you can share this screen with me, and we'll do immediately the 6 steps of hand washing. All of you, can you please on your cameras? This is a small 1-minute event. If at all of you can be a part of it. No? Okay, only 2 of us are there. So very quickly, if at all we can do the 6 steps of hand washing. All together. I can just 4-5 of you just rotating. Okay, let's start. The first one, we have taken the soap, they are not the steps. Soap, water. So first step, palm to palm. Second one, back of the palmar surface over the second one. Second step. Third one, interdigital spaces, right? Fourth one, you are closing the knuckles. That is the fourth step. Fifth one is the anatomical snub box area. The thumb area, you have to clean this. And sixth one, palmar surface of one over the other, that is the sixth space. So again, I'll repeat, hand palm to palm, one palmar surface over the dorsum, third interdigital, fourth knuckles, fifth thumb, and sixth one palmar over the fingertips. So these are the 6 steps of hand washing, what we generally perform, right? And 5 movements of hand hygiene very quickly. कब करते हैं हम लोग? Before touching the patient, after contact with any body fluids or the blood, or prior to perform any aseptic procedure. Fourth one is after touching the patient, and fifth one is after touching the surrounding of the patient. So these are the 6 steps and the 5 moments of hand hygiene, which is the utmost important thing, and you all need to follow if you can in your system. This is all about my today's presentation. If any questions, any doubt, please write it in the chat box. I'll be happy to answer your queries.
Good afternoon. Shall I start my presentation? Good afternoon.
Yes, start.
Can I start my presentation?
Yes, ma'am.
Okay. Good afternoon. My topic for today's presentation is on assessment of the key performance indicators proposed by NABH in a blood center of a tertiary care hospital. This is a comprehensive review. Quality management system in a blood center is very important to achieve near zero risk blood transfusion. So there are various autonomous external accreditation agencies. These agencies are helpful to monitor the various quality control parameters. We have something called quality indicators or key performance indicators. They've devised tools for assessing the level of quality control by defining certain parameters. In India, the accreditation program for blood banking is under NABH or NABL, which comes under the Quality Council of India. So performance is the extent to which a set objectives are achieved, and quality indicators are the measurable aspects of process outcomes that provide an indication of condition or direction of performance over a period of time. And it also shows us the progress that a blood center is making towards the stated quality goals or objectives. So the 5 mandatory key performance indicators in a blood center. The first one is the percentage of transfusion transmitted infection. The second is the percentage of adverse transfusion reactions. The third is the percentage of blood components wastage. Fourth is the turnaround time of blood issues. And fifth is the percentage of component QC failure. The percentage of transfusion transmitted infections is calculated by adding the total number of transfusion transmitted infection cases in whole blood donations and dividing it by the total number of whole blood donations. This is calculated as a percentage. So in our blood center, in our medical college, if you can see the benchmark value as per data is 4%, and our observed value is 1.54%. So we're well within the range. So we've met the benchmark value. This is same for HIV, hepatitis B, hepatitis C, and malaria as well. The observed value is 0.25%. Hepatitis B is 3%. For hepatitis C, it is 0.55%. For malaria, it is 0.01%. Only for syphilis, the value is 0.75%, whereas the benchmark is 0.11. So here we have not met the benchmark value. The second indicator is the percentage of adverse transfusion reactions. This is calculated by adding the total number of adverse transfusion reactions, dividing it by the total number of blood components which are issued or transfused. This will include all major and minor reactions, which will be classified as and should be reported to the National Hemovigilance Program of India. So here, the benchmark value is the percentage should be less than 2%, and in our institute, the observed value is 0.37%. And for hemolytic transfusion reactions, the benchmark value is 0%, which is the same in our hospital as well. the percentage of wastage rates. So wastage rates are calculated by the total number of blood or blood components which are discarded, divided by the total number of blood or blood components which are issued or prepared. So for this, for PRBC, the wastage rate should be for PRBC and FFP, it is less than 1%. And in our hospital, the observed value is 0.24 percentage for PRBC and 0.25 percentage for FFP. Whereas the benchmark value for platelets, the wastage rate should be less than 22%. But in our hospital, the wastage rate for platelets is 46.06%. The turnaround time for blood issues is also calculated based on the sum of the time taken and dividing it by the total number of blood and blood components which are cross-matched or reserved. So the unit for this is going to be in minutes. So every blood bank will have different set turnaround time for blood issues based on whether it is a routine cross-match or whether it is an urgent cross-match or it is an emergency issues. For us, for our calculation, we have taken urgent, and the benchmark value in our as per articles is 45 minutes. In our hospital, the observed value is 42.25 minutes. So here also we've been able to meet the benchmark. The fifth mandatory key performance indicator is the percentage of components QC failure. So the component QC failure is calculated by the number of component QC failures divided by the total number of components tested. This is calculated in the form of a percentage. So for this, we have to take 1% of units monthly, or 4 units per month should be taken. So this will be the number of units that are tested in order to check the QC. Whichever value is higher, if the 1% is higher than that value, or if the 4 units are higher, then that value should be taken. So the benchmark value for that, that is more than 75% should have met the QC, and for us PRBC 86.5% have met the QC, random donor platelets 79.6 have met the QC, and for FFP 84.5 have met the QC. So TTI syphilis, as we saw, did not meet the benchmark. The possible reasons could be false positivity. The younger donors who are coming are not aware about possible deferral and high risk, and increasing incidence of the disease can also be present. Corrective and preventive action taken can be the donor's test must be confirmed by microbiology. Donor screening should be stringent at the donation counseling level itself, and awareness creation activity should be done. Platelet wastage rates did not meet the benchmark. The possible reasons for wastage can be expiry, breakage or leakage of units, under-collected units, hemolysis, lipemic or indeterminate units. The corrective and preventive action should be first in, first out policy, and we should use only double bags if required. Triple bag should be used only if we have a shortage among platelets. Lab technicians should also be trained to improve component preparation. So to conclude, our study helped us to understand the flaws and problems faced by blood center in sustaining quality. We were able to capture, analyze the data, find out sections of non-conformance, do root cause analysis, self-assessment, and we were able to plan and carry out corrective and preventive action. These are my references. Thank you.
Recording in progress.
There are 3 lectures.
Oh, shall I continue? Okay. My second topic for today's presentation is a retrospective audit of fresh frozen plasma.
Yeah. Okay, start, ma'am.
My second topic for today's presentation is on a retrospective audit of fresh frozen plasma requisitions in a tertiary care center in South India. So component preparation from whole blood has led to increased efficacy and better utilization of the blood products which are available. Fresh frozen plasma, or FFP, is used to achieve hemostasis when in patients who have a deficiency of clotting factors, if there's an evidence of coagulopathy, or in patients who have ongoing bleeding. even though it's a very important component, it has limited indications as per the guidelines from the College of American Pathologists and the British Committee for Standards in Hematology. Inappropriate FFP transfusion can squeeze the limited blood bank resources and expose the patients to various risks which are associated with the transfusion of FFPs and should be avoided if not necessary. So aim and objective of this study is to retrospectively analyze the utilization patterns of FFP to assess the adherence to guidelines and suggest improvements for enhanced patient care. So this study was done as a retrospective descriptive study on 1,042 consecutive FFP requisitions. The period of study was 12 months from 1st January 2023 to 31st January 2023. The data that we needed was collected from blood request forms, issue registers, and from the hospital information system. So audit was done, and the usage of FFP was divided as to whether it was appropriate, inappropriate, therapeutic, or prophylactic, based on whether it complied with the existing guidelines, which were published by the College of American Pathologists and the British Committee for Standards in Hematology. So the dose is 10 to 15 ml per kg body weight of the recipient was considered as the optimal dose. And one FFP unit would consist of 0.7 to 1.0 international units of each coagulation factors and 1 to 2 mg per ml of fibrinogen. An increment of at least 30% of the baseline value in clotting factors is expected after adequate dosage if the patient does not have any rapid and ongoing consumption. So who are included in the study? So all the patients who received FFP transfusions were included in the study. Patients who received supplements such as whole blood and vitamin K were excluded from this study. So we'll see the results. First, the department-wise issue of fresh frozen plasma. So total of 1,042 units were transfused to 274 patients. And in this, 33% of the FFP units were given to general patients from general surgery, followed by 22% to general medicine, 11% to nephrology, followed by CTVS at 10% and oncology 9%. So among the units transfused, 456 units were transfused approximately. That is 44% of the units were transfused appropriately, and 56% of the units were transfused inappropriately. So among the appropriate usage of fresh frozen plasma, mostly among patients with liver disease, the transfusion of FFP was appropriate, followed by therapeutic plasma exchange at 27%. 18% patients with massive transfusion were appropriately transfused FFP. 4% of patients were warfarin reversal, and 3% with deranged coagulation profile. Among the inappropriate usage of fresh frozen plasma, 33% of the units transfused for surgery-related conditions were inappropriate. 25% were transfused inappropriately for patients with hypovolemia. 20% for patients who had a mild derangement in coagulation profile, followed by 14% of transfusion among patients with hypoproteinemia, 6% in Burns patients, and 3% was transfused as prophylaxis in dengue patients. So the guidelines proposed by FFP usage by the British Committee for Hematology and the College of American Pathologists are expert consensus, but the recommendations and their implementation on the clinical grounds is actually very minimal. Because of the lack of stringent transfusion guidelines, proper awareness about FFP transfusion, and a suboptimally functional hospital transfusion committee are common reasons for inappropriate FFP usage. So educational interventions in the form of CME, discussions in the hospital transfusion committee, periodic prospective audits can help. And one more thing which can help is point of care testing, like in the form of thromboelastography, must be available in order to reflect the current hemostatic status, should be available during cardiovascular surgeries and massive transfusions and ongoing DIC as well. So in conclusion, the findings of the study underscores the importance of ongoing education and implementation of efforts to promote appropriate evidence-based FFP utilization in clinical practice. So it is important for us to address the factors which contribute inappropriate usage of FFP so that the patient care is optimized and resource allocation is optimized as well. These are my references. Thank you. My third presentation is on the transfusion optimization and autoimmune hemolytic anemia, insights from a case series analysis. So autoimmune hemolytic anemia is a clinical condition where we have the IgG or the Ig and or the IgM antibodies binding to the red cell surface antigens, and they initiate red cell destruction through either through the complement system or through the reticuloendothelial system. Because of this, there's decreased survival of the red blood cells because there's increased destruction by the platelets, by the patient's own autoantibodies. In patients with AIHA, direct homeostasis is an essential diagnostic test. If the destruction in these patients is severe, the patient's marrow cannot compensate, which can lead to anemia. In severe anemia, the patient can also require PRBC transfusion. In patients who have AIHA, it can be challenging to find compatible units. In case if a patient is not, we're not able to find compatible units for these patients, then best match units must be transfused for the patients. The aim and objective of this study is the study was done in order to analyze the difficulties which are faced by the blood center during compatibility testing. Also to analyze the optimized transfusion strategies and provide transfusion support to patients with AIHA. So this study was carried out as a retrospective study in the Department of Transfusion Medicine in a tertiary care hospital. The period of study was from 1st January 2023 to 31st January 2024. The patient details were obtained from the hospital records. Laboratory values including ABO and RH typing, pre and post hemoglobin were also studied. Out of the 34 AIHA cases which required transfusion, 26 patients received 53 blood transfusions. This included 21 female patients and 13 male patients. So among this, 46.78% of the patients had, we were able to find cross-match compatible units, but for 53% of the patients, that is around 18 patients, the patients had incompatibility and we were not able to find cross-match compatible units. So for these patients, best match units were transfused. Following transfusion of best match units, there was no adverse reaction that was reported. So transfusion details. So the total number of patients who required transfusion were 26 and the total number of units to be transfused were 53. Among this, 8 patients did not require any transfusion. So among the 26 patients, 17 patients required only 1 unit transfusion, 6 patients required 2 units of PRBCs to be transfused, and 3 patients required 3 units of PRBCs to be transfused. Among the total units that were transfused, that is 53, 23 units were compatible units, but 30 units that we transfused were best match units. Transfusion requirement in patients with DCT. So DCT grade was also done, and there were 16 patients who had 4+ DCT grade, and among these patients, 9 patients required 1 unit to be transfused, 5 patients required 2 units, and 2 patients required 3 units to be transfused. Among these patients, median pre-transfusion hemoglobin level was 4.9 gram per deciliter. The range was from 2.3 to 7.5 gram per deciliter. Post-transfusion hemoglobin was also checked. It was 7 gram per deciliter. The range was from 5.7 gram per deciliter to 8.3 gram per deciliter. Among all these patients, DCT was positive. If there were certain patients who also had blood grouping discrepancy because of presence of autoantibodies, blood grouping discrepancy was also solved before the unit best match unit was issued to the patient. So transfusion support is essential until the patient improves clinically and hemoglobin increases after medical treatment. Sometimes it can be difficult to get compatible units because there are autoantibodies in the serum, but any patient should not be denied transfusion just because of incompatibility. So the clinicians should also be educated and counseled and encouraged to transfuse the best match units during emergency whenever there is a need for transfusion. Pre-transfusion testing of these patients can be difficult because the patients may have blood grouping discrepancy. They may also have an unexpected alloantibody along with an autoantibody. There's high cross-match to transfusion ratio, and the turnaround time is also increased. The decision to transfuse these patients will depend not only upon the hemoglobin and the laboratory testing, but also on the clinical condition, the comorbidities, and the extent of the patient's disease. So to conclude, providing transfusion support to AIHA patients can be tedious and it can be time consuming. Not all patients with autoimmune hemolytic anemia will have compatible units for transfusion, but no transfusion should be denied just because of incompatibility. Best match unit can be safely transfused. These are my references. Thank you.
Dr. Rowena, have you encountered any mismatch in these cases or any reaction, any transfusion reaction in your study subjects?
No, ma'am.
You are saying that even if the cross matches, show your conclusion once again that no patient should be denied transfusion even if there is
Incompatible units, ma'am. Even if we are not able to get compatible units, best match units can be safely transfused to these patients, ma'am.
That's what she's asking. In those patients, have you encountered any transfusion reactions?
No, ma'am. No, we've been able to safely transfuse these patients with the best match unit, and no adverse transfusion reactions have been. We've not had any adverse transfusion reactions following transfusion, ma'am, with the best matched unit.
What was your study size, Rowena?
My studies, ma'am, my sample was 36 patients, ma'am.
36 patients in AIHA.
34 AIHA cases. Among that, 26 patients requiring 53 transfusions, ma'am. The total number of cases were 34. In that, only 26 patients were transfused.
And this is a prospective study.
Oh, this was a retrospective study, ma'am.
Retrospective study. Okay, you
Yes, ma'am.
you saw all the details from the papers.
Yes, ma'am. We have an IT system in our hospital, ma'am. So we collected all the data from the issue register and from the cross-matching register, and then we were able to follow up the patient.
Fine. Okay.
Okay. Can you please tell me, was there any allo antibody patients besides auto antibodies?
There were 2 patients with allo antibody, ma'am. For this, we had done adsorption elution in order to find out what the allo antibody was from the allo. Yes, ma'am.
Allo antibody identification was done by which method?
We had done adsorption elution, ma'am, and then we had used
Adsorption
11 cell.
elution is done later on once you suspect or you see that there is some allo antibody, na? So what is the primary method?
Ma'am, we actually take the elevate, and from there we had done 11 cell, ma'am. We had used a 11 cell panel in order to find 11 cell panel to find the antibody match, and then we use an antigram to pattern match.
What is the basic principle of 11 cell panel? In 11, what is the basic principle? Which test we do in that?
ICT, ma'am.
Pardon?
Indirect Coombs test, ICT, ma'am.
Yeah, indirect Coombs test. Okay. And what is hemovigilance program?
National Hemovigilance Program of India is where we report in case if there's any adverse donor reactions or any adverse transfusion reactions, we have to report and tell what reaction in which patient and how it happened or that.
Okay, good. Thank you.
Thank you.
Dr. Preeti, shall we go ahead with the next presentation?
Yeah, we can go ahead.
Yeah, so next is Vijit. Vijit, you can go ahead with the presentation. Vijit would be presenting 3 papers at a stretch.
Okay.
Vijit, are you there?
Yes, ma'am. Yes, ma'am.
And if Vijit is not there, Monica is there. Monica, you have 1 paper. Monica, if you are there, you can start.
Hello, ma'am.
Yes,
Hello, ma'am.
Vijit. Please share your
Vijit
screen.
is here. Yeah.
Start, please.
How to screen share? No. It's coming. It's coming. Hello, ma'am. Can I start? Hello. Good afternoon.
Yeah, please start. Please start.
Okay. Good afternoon, everyone.
My presentation today is on my first topic is regarding an audit regarding appropriateness of the platelet utilization in dengue cases in a tertiary hospital. So first is introduction. So we all know dengue fever is an eminent health problem in India and Asia as a whole. It's a problem in recent times. It's a benign symptom caused by arthropod-borne viruses, and its bleeding is one of the most dreaded complications associated with majority of the mortality. Bleeding is highly variable depending on platelet counts and hepatic retention and other confounding factors which is related to the patients. Platelet transfusion is given to either bleeding or other hemorrhagic symptoms, and the practice and policy of transfusion vary among institutions and among clinician practitioners. This can lead to inappropriate use of platelets, which might increase the risk of transfusion-related complications to recipients and also lead to shortage of platelet stock as a whole. So the aim and objective of the study was to audit the appropriate usage of platelets in the management of dengue cases, review and analyze the medical records of the dengue patients who received the platelet transfusion, identify any deviations from the established guidelines or protocols regarding transfusions of the platelets, and analyze the resource utilization in the blood bank and blood center associated with the platelet stock. So methods. Retrospective descriptive study was done on around 572 platelet and 91 STP issues at our institute, Savitri Medical College. The period of study was 1 year from 1st January 2023 to 31st December 2023. The required data were collected from the blood requisition form, post-match registers, issue registers, and from the digital medical records of our hospital. So the data collection and the inclusion criteria for all cases of fever with thrombocytopenia with either dengue MSM positive or dengue IgM positive. Exclusion criteria patients which had other causes of thrombocytopenia or other causes of bleeding manifestations. So data collection, the data retrieved was analyzed as to the total number of platelets being used, the therapeutic indication of the rationale for each of the requests, the diagnosis, platelets counts, and the symptoms of each and every individuals, and the patient status post-platelet transfusion. The appropriateness of the platelet transfusion was assessed as per the published guidelines and literature and classified as whether it was appropriate or inappropriate as per the case details and case information. The data was analyzed, and each issue per patient usually ranged from 4 to 6 units of random donor platelets, RDP units, or single units of STP. Totally around 146 issues were done for dengue patients and dengue-associated thrombocytopenia patients, of which 35 of them were STP, single donor platelet issues. So in this pie diagram, we can see totally 333 patients were issued platelets from our blood center, of which 99% of them were for dengue patients. That is 30% of the cases. Of these 99 cases, 33 had bleeding manifestations. Mortality was 2, and transfusion reactions was 2, and both the transfusion reactions were allergic transfusion reactions. Of the 99 patients diagnosed with dengue, 65 were dengue fever as such, and 33 were dengue hemorrhagic fever, and 1 was dengue shock syndrome. So in this table, I collected all the data and made a tableau in a tableau column. So most of the cases had bleeding manifestations, especially in the count range between below 10,000 and between 10,000 to 20,000. Most of the bleeding manifestations were hematemesis melina, complete, menorrhagia, IC bleed, and petechial rashes. IC bleed, only 1 case was there. And the number of dengue patients which received the platelet transfusions below 10,000 were 48. Between the range of 10,000 to 20,000 was 44. So this is a month-wise split of regarding the appropriate and inappropriate usage of the platelets. So as you can see, during the months of July to December, there was a large number of inappropriate usage of the platelets. The inappropriate being the gray color and appropriate being the yellow color. And so of the 99 patients which were issued platelets, 64 of them had received appropriately. But again, 35 of the patients received platelet transfusion without any rationale, without any indication, any proper indications. So coming to the discussion, so this study was done to highlight the non-adherence to platelet transfusion guidelines among the clinicians. So for this is the problem which we saw in our hospital and from a blood center point of view. And regular audit of blood and blood components will be valuable to maximize the judicious utilization of the blood components and to avoid unnecessary transfusion, to prevent unnecessary exposure of the patient to blood products, and to maintain adequate stocks, especially platelet stocks. So now, since we found out the problem, now what do we do as a corrective action, preventive action? So corrective action will be to discuss the data obtained with the hospital transfusion committee, conduct regular CMEs, continuous medical education regarding the current transfusion guidelines of platelets and other blood products, prospective auditing, from the blood center can be done to prevent unnecessary transfusion and prevent stock depletion, and ensure that there is effective blood management from our blood center. So these are my references.
Can you please show the conclusion once again, Vijit?
Yes, ma'am.
Just repeat the conclusion. Just conclude your study.
And this study we actually did because we are having a lot of friction with the medicine and the pediatric departments regarding not keeping adequate stock of platelets. So this study was actually done to highlight the issues which we are having. So in this study, we just saw that there was there was actually a significant portion of inappropriate platelet transfusion be done from the clinical request being sent from the clinician side. So regular audits is to be continued from our department, and this data has to be discussed in the hospital transfusion committee, and from the hospital transfusion committee, regular CMEs, regular awareness among the clinicians has to be developed. The
Please on
latest
your
work that,
video while speaking so that we can see you.
oh, sorry, ma'am.
Okay.
Sorry, ma'am, sorry.
Yeah.
Okay.
Okay.
So
Fine.
so
So
regular.
you want to give a message to the clinicians mainly.
Yes, ma'am.
Fine. Dr. Preeti, you have any questions?
Yeah. What are the quality parameters which you look for platelets for quality control purpose?
So for STB, the quality control will be that the count should be more than 3.3 lakh count should be there. No blood stain, that RPC count should be less than 5 ml, and volume of the STB should be around 300 ml.
And regarding RDP random donor platelets?
RDB, again, no blood contamination less than should be less than 5 ml contamination, and then volume should be between 45 to 50 ml, 55 ml of the platelet.
Any other parameters?
Platelet count should also be done. WBC count should also be done.
What else? Which you can grossly inspect?
Any blood staining or any contamination of the RBCs.
Anything else?
Swirling.
Swirling. Anything else?
May any discoloration of the product, any lipemia or any
You look
bacterial
for
contamination.
pH of the platelets or no?
Yes, ma'am. Should not go less than 6, but it's usually done during the last day of the blood product of the platelet products. Should not go below 6.
And day of production of platelets is taken as day 0 or day
0, ma'am. Day 0.
Day 0?
Day 0, ma'am.
And what are the quality parameters for platelet incubator and agitator? What all you should do?
Ma'am, regarding the agitator, 72 movements per minute, 1.5 inches towards each side, 60 to 72 movements per minute actually, and 1.5 inches to each side. And regarding temperature, should be maintained between 20 to 24 degrees Celsius, and the temperature gram will be there, and it will keep an eye regarding any deviations has happened beyond the range.
Okay. Thank you.
Thank you, ma'am.
Go ahead with your next presentation, Vijay.
Yes, ma'am. Is it come? So my next case, all presentations regarding a case report is regarding a blood group discrepancy and due to anti-M. So regarding introduction, so MNS is a complex blood group system, and of which the M, N, and capital S and small s are the commonest antigens in that blood group system, and the anti-M is the antibody, which is actually relatively common naturally occurring antibody, and it has optimal reactivity at 4 degrees Celsius and weakly or mostly non-reactive at 37 degrees Celsius. That's a body temperature region. It is usually clinically insignificant, but can be active at 37 degrees Celsius because of the wide thermal amplitude of the IgM component of the antibody, or maybe there may be an IgG component in the among IgG component in the anti-M. So this is actually a case report. So 1-year-old female child presented with complaints of cough with fever, and the child is a known case of ventricular septal defect. On a certain child had pallor, respiratory distress, and global development delay. On investigations, complete blood counts were sent, and it was found hemoglobin level was found to be around 7 grams per deciliter. That is, the child was anemic, and blood grouping samples were sent to the blood center. Obviously, for after blood grouping, they were the pediatrician were planning for cross matching and transfusing 1 unit of PRBC for this child. So when the blood grouping sample was received and blood grouping was done, you can see in the card the forward grouping result came as B positive, but in the reverse grouping there was reactivity against the A1 cells and also against the O cells, which we use as a control. So basically there's an discrepancy in the blood grouping. So when we categorize the discrepancy, it was discrepancy type 4. Basically it's an excess of antibodies. That's unexpected antibodies were seen against cell lines B cells and the O cells. So we also repeated blood grouping in the test tube, and also showed the same results. So history was obtained from the pediatrician and the parents of the child. It was regarding whether the child had any transfusion history or any history which suggested of any immunization. There was no such history in the child. Direct anti-hemoglobin test was done, and autocontrol was also done. Both came out as negative. Indirect combinations with 3-cell antigen panel was done, and showed that there was reactivity against cell lines 1 and cell line 1 and cell line 2, but no reactivity in cell lines 3. So with this, we were able to narrow down the antibodies to possibly anti-P1 and anti-M. As you can see, the highlighted ones with the cell lines which got reacted, and both P1 and M are the antibodies which were coming out as, from this antigram reading as the possible antibodies. So the next step after the 3-cell was done was the 11-cell ICT with the 11-cell antigen cell lines, and showed the following pattern reaction. There's reactivity cell line 2, 4, 5, 7, 8, and 9. So when we transfer this data into the 11-cell antigram, we can see that the anti-M antibody was seen. That's a perfect pattern matching. Also, if you can notice in cell lines 5 and 8, the reactivity is only 2+, but in the rest of the cell wells, it was reactivity is 3+. So there's decreased reactivity in cell line 5 and 2. So it means when you check in the cells, you can see that there is both M and N antigen present in cell lines 5 and 8. So it just shows that there was dosage effect in these two cell lines. That's why there's decreased reactivity of the anti-M antibody. So when we continue the investigations, the antibody is confirmed by using M negative and M antigen negative cells and M antigen positive cells. Obviously, M antigen positive reaction cells were giving the activity. Phenotyping of the child's red cells was done, and it was negative for the M antigen. A group reagent cells, which was used for the reverse grouping, was positive for the M antigen. So reverse grouping was done again with the M antigen negative red cells, and this time it showed that reverse grouping showed as B positive. That hence the blood grouping of the child was confirmed as B. The child required 1 unit of PRBC, and compatible unit was obtained, but only after transfusing multiple units. And the sample, the child's serum sample was sent for immunohematology workup, and it was found that there was IgM-based antibodies in the child. So regarding discussion, the anti-M may be developed by transmission or by bacterial infection in children, but most of the time it is actually naturally occurring antibodies. So most anti-M antibodies are not active at 37 degrees Celsius and hence are not clinically significant. So most human anti-M are of IgM component, and sometimes some anti-M antibodies can be significant at 37 degrees Celsius. That is, if there is an IgG component to the anti-M antibody. Rarely, anti-M has been implicated in immediate and delayed transfusion reactions, and also a case of hemolytic disease of the newborn has also been seen, also been reported. Coming to the last slide, antibody screening and identification of the allo and autoantibodies. Autoantibodies is vital for evaluating and managing such patients. Such antibodies can present as bilirubin discrepancy or as direct or indirect Coombs positive or as incompatible during cross matches. These are my references.
You found how many studies of these anti-M antibodies in India?
Ma'am, in our hospital, at least now we have seen at least five cases in last 1 year, actually, ma'am.
5 cases with anti-M antibodies.
Yes, ma'am. But they had previous history of exposure. There was previous history of a transmission such patients, but this child had no such exposure, no such reason for such immunization to develop.
And how many published work you have got in India?
Ma'am, I read at least 2 or 3 reports, ma'am. So far. Actually,
Only
in
2 or
one
3 reports. There are
there are
number
many,
of
ma'am.
studies on allo antibody from India.
Yes, ma'am. But regarding anti-M,
Most majority of the people have found which allo antibody is the most common in India.
anti-D.
Anti-D, followed
Yes,
by any other.
Anti-E.
What about
capital E?
and in which patients allo antibodies are more frequent?
Which patients? Ma'am, patients who are getting chronically transfused patients. For
Like
example, thalassemia, sickle cell disease, those individuals will be having higher chance of getting immunization.
Okay.
And also in pregnancy, multiple pregnancies, history of abortions, and also.
Okay, for transfusion in thalassemia patients, what considerations are kept in mind? What points we consider?
Ma'am, for transfusion, any patient which require chronic transfusion therapy.
For thalassemics, which type of blood should be transfused?
Phenotypically matched blood should be given.
Any
Especially
other
for
specification?
especially for all of the RH and KEL.
RH KEL phenotype blood should be given, and anything else?
Leukoreduced blood also, ma'am.
Leukoreduced or leukodepleted? You would like to transfuse?
Leukodepleted blood.
Okay. You can go on to your next presentation.
Okay. Coming. So coming to my third presentation. So my third presentation is regarding presence of antibody in a 1-year-old thalassemia patient, and it's a case report again. So introduction, thalassemia is a genetically inherited group of disorders that result from reduced rate of production of one or more of the globin genes, and survival of thalassemia individuals is dependent upon regular blood transfusion therapy. So blood transfusion therapy improves the longevity, but also has complications like red cell and immunization. Also, immunization is non-complication in multi-transfused thalassemia patients, resulting in delayed issue of compatible units in such patients whenever the need comes up. Immunization remains a significant concern in thalassemia patients due to repeated transfusion, and incidence has been shown to be up to 24.7% when you take in worldwide. So this is a case report regarding a 1-year-old male child with complaints of failure to gain weight since birth with abdominal distension. On general examination, child was having pallor and with mild frontal bulging of the skull. Systemic examination revealed hepatosplenomegaly. Complete blood counts were sent following admission, and it was found that the child was anemic and HB was around 5 grams per liter. A liver function test was done and showed that serum bilirubin was 2.71 milligram per deciliter and diet bilirubin 0.85 milligrams per deciliter. Serum LDH was elevated at 332 units per liter, and child was suspected and deficient diagnosis of hemolytic anemia was arrived. DCT was sent following this, but it came out as negative. Peripheral smear was sent, which showed marked anisopoitrocytosis and microcytic hyperchromic RBCs, basically microcytic hyperchromic anemia in this child. was the Peltosny report, and high performance liquid chromatography was done and came in favor of beta thalassemia homozygotes. Since this report came out, the father and the mother of the child, HPLC was also done in them, and they showed beta thalassemia rate, both of them. The child hence was diagnosed as a case of beta thalassemia major. In view of the low hemoglobin, the child was planned for blood transfusion and blood grouping was done, and it was found to be AB positive blood group. During routine cross-match, incompatibility was seen with multiple PRBC units, following which we did indirect contests with 11 cell antigen 11 antigen cells to identify the alloantibody. And this is the 11th cell which we did in this child. And we can see that there's reactivity against cell line 3 and cell line 5, but in the rest of cell lines, there was no reactivity. And when we transfer this information to the antigram, we can see that just a perfect pattern matching for the capital E antibody. So history was taken regarding any possibility of alloimmunization, and that's when we got that there was 2 months back the child had a history of blood transfusion, and the child RBC phenotyping was done, for which RH and KEL was identified. Suppose that child had required further transfusion just in case. The child was referred to Thalassemia Center for further evaluation management, and for last when we inquired about it, the child was planned for bone marrow transplant. So regarding discussion of this case highlights the importance of red cell phenotyping in patients who require chronic transfusion therapy. Alloimmunization is due to the RBC antigen difference between the blood donor blood and the recipient blood. So matching of blood for at least RH and KEL antigen should be done, and it will reduce alloimmunization to a significant extent. Experts advise patients should have extended red cell antigen typing that includes at least ABO, RH, and KEL before initiating transfusion therapy. All patients with thalassemia should be transfused with at least ABO, RH, and KEL match compatible blood. But at the moment, expense and feasibility of such procedure may not permit and most of the blood centers. These are my references.
Nice presentation. I don't have any questions. Dr. Preeti, you can ask some questions.
Yeah, at your institute, you are doing RHKL phenotyping in all the donors?
No, ma'am. We don't do all donors. We did this for the child. Suppose the child required further blood units. Yes, for that we did.
For that you did.
Yes, ma'am.
Okay.
But the child was actually referred as soon as the thalassemia center as soon as we came to the diagnosis of thalassemia major. But we have the gel cards for phenotyping.
Okay. Suppose on 11 cell panel,
Yes,
alloantibody is detected, then how you confirm that?
Ma'am, we have to prove that that RBC of that individual, that patient, is antigen negative.
So you will need what to confirm that? You need something, na?
Antisera.
Specific, that antibody specific antisera.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Introduction. Lymphadenopathy is the most common clinical presentation in outpatient and inpatient department, which consists of various etiological factors ranging from inflammatory to malignant condition. FNAC of lymph node has become integral part of the initial diagnosis and management of patient with lymphadenopathy, early availability of results, simplicity, minimal trauma with less complication. It provides valuable information about the nature of lymph node enlargement, aiding in the diagnosis of various conditions such as reactive lymphoid hyperplasia, infectious disease, granulomatous lymphadenitis, and metastatic malignancy. FNAC helps further management decision, including the need for additional investigation, treatment planning, and patient care. FNAC play a pivotal role in assessing lymphadenopathy, allowing healthcare professionals to make informed decisions based on cytological findings. Its non-surgical nature, diagnostic accuracy make it an essential tool in the evaluating of lymph node disease. My aim is to analyze utility and importance of FNAC as a diagnostic tool in the etiologic cause of lymphadenopathy, to study the cytomorphological feature to categorize the cause of various lymphadenopathies. It is a prospective study was carried out in pathology department, RDGARDI Medical College over a period of 8 months. Sample size 101 patient of all age group underwent FNAC of enlarged lymph node during this study period. Inclusion criteria, all patients presenting with lymph node enlargement were included in study, and a patient with aspirated material were either inadequate or smear were unsatisfactory for evaluation, and non-palpable were excluded. In every case, a quick medical history, physical examination, and if available, an assessment of pertinent investigations were done. FNAC was performed after taking consent and explaining the procedure to the patient. FNAC was done using 5 to 10 ml disposable syringe with 22 gauge needle. Immediately after aspirating, the substance was smeared onto slide. Only a few slides were submerged in 95% ethanol right away, with the rest being air dried. Giemsa and pep stain were used to stain the air dried smear and alcohol fixed smear. When necessary, Zn stain were carried out for AFB. All stain smear were evaluated and diagnosis was based on cytologic feature and clinico-cytological correlation. Result, out of 101 patients with peripheral lymphadenopathy, ages of patient were from mostly 6 months to 65 years, in which 62% were male and 38% were female. In this study, most common site was cervical lymphadenopathy, and reactive lymphadenitis with 39 cases was the most common diagnosis on FNAC, followed by metastatic lymphadenitis with 22 cases, then granulomatous lymphadenitis, followed by necrotizing lymphadenitis, tuberculous lymphadenitis, acute suppurative lymphadenitis with 8 cases, and lymphoma 2 cases. Lymphoma 2 cases both were non-Hodgkin lymphoma. It has been noted the cervical lymphadenopathy is most common site. Cervical is the most common site. Then supraclavicular lymph node was the most common site, second most common. Then axillary lymph node. Then inguinal, forearm and arm, and then generalized lymphadenopathy. Age distribution, most common age was 6 months to 20 years of age, most common with cervical. Mostly cases were cervical lymphadenopathy, in which most reactive lymphadenitis, most common diagnosis. Then 41 to 50 years of age, second most common age group involved. Discussion, lymphadenopathy is the commonly seen clinical condition requiring quick and accurate diagnosis so that a proper treatment regime can be started at the earliest. FNAC is a completely safe, quick, and appropriate method for early diagnosis of lymphadenopathy, reducing the need of excision biopsy. This study was carried out to find out the relative frequencies of various etiology factors presenting as lymphadenopathy in different age group and cytomorphological changes in different lesions. In this study, out of 101 cases presented with palpable lymphadenopathy and sent for cytological evaluation. Age of the patient 6 months to 65 years, and ratio male to female ratio 1.58. Out of 101, in which 77 cases were benign and 24 malignant cases. Out of 77 cases, reactive lymphadenitis with 38%. Reactive lymphadenitis was the most commonest among the benign or infectious cases, followed by granulomatous, then suppurative, necrotizing, and tubercular lymphadenitis with 3% case. Out of 24 malignant cases, 22% were metastatic and 2 were lymphoma. FNAC is a quick, simple diagnostic test. FNAC can identify both neoplastic and inflammatory lesion. Both definitive diagnoses in lymph aspirate when biopsies are not necessary. It is safe and suitable method. A more accurate diagnosis can be made with the understanding of the cytological pattern of different lymph node lesion in a given location. It can reduce cost and eliminate the necessity for excision biopsy. FNAC is appropriate for poor nation with limited resources. These are my references.
Okay, Sonakshi, I have a question.
Yes,
That
ma'am.
you did this study on cytopathology, right? Please, on your
Yes,
video.
ma'am.
So
Yes,
it
ma'am.
was a FNAC spectrum. Just on your video for a second. Okay. Did you analyze these cases by Sydney system of classification?
Yes, ma'am.
You did that?
Yes, ma'am.
Have you mentioned that in your presentation? If I missed,
No, ma'am.
then
No, ma'am.
that's a very important tool, and But if you have observed it according to Sydney system, why you haven't included in your presentation? And what is your experience about it?
Ma'am, Sydney system is a better classification for arrange.
Or how many classes are there in Sydney system?
Ma'am,
Of
5.
categories. Can you just enumerate?
Benign. Yes, ma'am. First class 1 is inadequate. Second is benign. Third is atypical. Fourth is suspicious for malignancy, and fifth is malignant lesion.
Dr. Reena, you can ask, continue.
Yeah, I just wanted to know कि सिडनी के हिसाब से अगर किया है तो उसमें क्या ऑब्जर्वेशन मिला? आपके टोटल केसेस
Ma'am,
कितने थे
category
सोनाक्षी?
1. Yes, ma'am.
How many total cases were there in your study?
Ma'am,
इस study
101 cases.
101 में से क्लासिफिकेशन कैसे कैसे हुआ फिर?
According to 5 classes, class 1 is inadequate. Class 2, most of cases were in class 2.
Okay, then?
Which is benign.
आप ठीक से बता नहीं रहे हो बच्चे?
Sonakshi, how many of your cases diagnosed as tubercular lymphadenitis were AFB positive?
Ma'am, 3 cases.
Only 3 cases? And total?
Yes, ma'am.
And total,
Ma'am,
how many?
actually, AFB positive were only 3 cases. Then
In general, and how many total cases of tubercular lymphadenitis you have diagnosed in this study?
ma'am, if they're
There
AFB
is no
positive,
question of
then
if
give
and
diagnosis
but.
of tubercular.
आपने टोटल ट्यूबरकुलर लिम्फेडेनाइटिस कितने केसेस बोले हैं अपनी स्टडी में?
Ma'am, 3 cases.
Only 3?
Which
Out
were
of
AFB
100?
positive. Yes,
Arey,
ma'am.
in general, how many cases you have diagnosed as tubercular lymphadenitis?
कितने केसेस में आपने टीबी को डायग्नोस किया? ग्रैनुलोमेटस
आपने
दिया
अपना
या ट्यूबरकुलर दिया?
Ma'am, yes, ma'am. Granulomatous. Ma'am, total out of.
कितने था ग्रैनुलोमेटस? ये बता दो.
Ma'am, granulomatous were 20 cases, ma'am. So
20.
out of.
अच्छा, अब मैं
Yes, ma'am.
आपसे खाली
20 cases.
टीबी पूछ रही हूँ. In how many cases TB cases you found granuloma only? In how many cases you found granuloma and necrosis? And in how many cases you found necrosis only?
Ma'am, only necrosis found in 7 cases and granuloma found in 20 cases.
And granuloma plus
AFB
necrosis?
positive cases 3.
And these were cases out of those 7 necrotic cases, or includes granuloma cases also?
No, ma'am, granulomatous 20 and necrotizing 7 cases.
बच्चे, मैं ये पूछ रही हूँ, जिन 4 केसेस में आपका AFP पॉजिटिव आया, उनका
Yes, ma'am.
साइटोमॉर्फोलॉजी पे क्या पिक्चर था? खाली नेक्रोसिस था, ग्रैनुलोमा और नेक्रोसिस था, क्या था? ये पूछ रही हूँ.
Ma'am, necrosis, there were necrosis and granuloma both.
उन चारों में नेक्रोसिस और ग्रैनुलोमा दोनों.
But they are tubercular, AFB positive.
ओके.
Okay, fine.
ठीक.